Very good morning to one and all. We will be starting the first session. I invite Dr. Maskati, Dr. Elizabeth, and Dr. Leela Mohan on the dais. And the first speaker of the session is Dr. Lipika Rai. She is Senior Consultant in Paediatic Ophthalmology and Chief Medical Officer, Center for Vision and Eye Surgery in Chennai. And she will be speaking vision therapy softwares. Are they helpful? Dr. Lipika. And your time is 8 minutes, and you have to be adhere to the time strictly.
Thank you, everyone. Considering the time restraint, I would directly go on my topic, vision therapy softwares, are they helpful? We have been seeing, if we are doing these therapy softwares in our regular clinic practice, that so much is available, but it is so confusing which one to take and which not to do. So these are some of the abbreviations which has been used. The literature search which we have done while making this presentation, and these are some of the emerging technologies and what are the basic principles used in the technologies like dichoptic, perceptual, MFBF mode, etc. These are the emerging softwares. So there is so much available in the market that it is really confusing both for the doctors as well as what treatment to be given, and also for the patient, because most of the things are also available online. So you can, and these are the only things which I have taken which is available here with us. In India, it has been used most widely. Now, dichoptic therapy, it's not a new principle. It's a treatment modality which involves presenting a different visual stimuli to each eye independently in a way to encourage the use of amblyopic eye with simultaneous binocular function. This is important, and this has been used for a long time. And it is most useful with minimal strabismus or visual obstruction, and if there is an interocular difference in the acuity. And lots of softwares which has been making, or the apps which are coming, are based on this principle. Another thing, a little bit, I would say a little bit ahead on dichoptic is MFBF mode, which is nothing but monoocular fixation in binocular field. Here one eye sees detail and the other eye sees the background in the same space. The goal is the accurate perception of details with one eye and the perception of the background with the other eye. So these most monocular activities, it can be modified to MFBF mode. We just have to change the occluder to a filter and change the target so that it can be seen with the one eye. So the type of occlusion which have been used previously were like patches and all. This in the MFBF mode, it is a translucent light but less detail, and one eye can only see the background. You can either use red lenses, green, blue or cyan lenses depending upon the software or the technology being used. Now this is a paper where I just took this out just to show that how with the application of these two therapies, there are also the reports which are coming out that even with more than 20 years old, if there are 20 dichoptic therapy and BVT sessions are given with a minimum follow-up of 6 weeks, it is showing an improvement. But of course, they have also used the SVI integrator for the perceptual integration as well. So of 18 patients, 14 had unilateral amblyopia and demonstrated a median improvement of 2 logMAR lines. Obviously, the sample size is less, but that's how the reports are coming now with the different softwares. Now, effect of MFBF on amblyopia, there was a pilot study comparing it with patching, and it shows that the patching group did demonstrate 3 logMAR lines of visual improvement, but the MFBF group showed 5 logMAR lines at the end of the therapy. Now, binocular perceptual learning, it refers to any stable change in the perception of a subject as a result of the experience with one or more stimuli, and this is becoming more and more critical for more of the holistic approach in terms of the visual software's training. Now, how do perceptual learning-based amblyopia treatments differ from traditional? It is basically, fundamentally, it works on 3 different strategies: contrast, rebalancing, visual blur, and the partial presentation. The studies show promising in use of perceptual learning, including tasks like stereopsis, anti-suppression to enhance visual functions and stimulate the binocular system. Now, main types of visual perceptual therapies which have been used in the softwares on the apps are like some of the interactive video games. So there are different types of games which are being given to the kids. Virtual reality or augmented reality, which is pretty in nowadays. Video viewing, different softwares like Embleo Play. It is not being used that much because there are other things like QC, Binox are available. OccluTab, CureSight, all vision therapy related activities and softwares also combines perceptual learning. Now, what are the predictive factors for visual rehab after PL? Type of amblyopia, age, astig, baseline stereo, fixation stability, and contrast sensitivity. These things are very critical to determine how the patient would improve. So it is really important to document what all we are doing. Then this is beyond occlusion. This is perspective for amblyopia treatment using OrthopTech, where it basically evaluates magnocellular stimulator. And I think Dr. Santana Gopal would be here also who is the one who invented this. And it has been shown that this has also been helpful in treating the patients. And in one study which is done by himself and his team, it shows that patients were evaluated for improvement in visual acuity, stereopsis, BSV, as well as the amount of strabismus. All patients were followed up for 1 year with maintenance therapy, and none of them showed any regression. Before I move on to anything, I just forgot to mention that all these therapies, minimum time has to be at least 3 months. Because you have to give at least 20 to 25 sessions, 40 minutes to 1 hour each, before you can conclude anything, where am I going? And after that, the patient should be followed up. And for a year, they have to be seen for any regression or not. So ideally, it's like iGEM. I mean, that's what I say in my, just to the patients, because you cannot leave it. You have to keep on checking because the child is also growing and each parameter is changing. Now, this is another syntotic phototherapy. We don't have personally any experience in that, but there are some of the people who are using it, where they present the fovea with the different lights, and it stimulates the sympathetic and parasympathetic nervous system. While OrthopTech, it works on the parvocellular and the magnocellular pathway, and it has shown a positive change. Then we have Gabber patches, which is Revital Vision. Then virtual reality, which is coming up, the new things which all of us know is coming up. And obviously, I don't have the time to go more into it. Visual motor integration by using Sanet Vision Integrator. So this, again, it is a visual guidance of motor performance and offers primary programs used for vision training. And it's very useful for sports vision therapy for children who need a very high level of the training. And it includes eye-hand, saccadic, tachystome, and metronome training.
Kindly come to the conclusion slide.
Yeah, I am coming. Vision therapy softwares, we had put the things you can ask to me. So there is no one fit for all. We have to consider several factors before starting any therapy. If in doubt, first correct the basics. There are promising technologies coming which are more engaging and creative therapies. Cost and affordability is one thing, but there is no structured approach and consensus among usage of therapies. Thank you.
Thank you, Dr. Lipika. That was a nice overview of several therapies in the pipeline. I think only time will tell. We go on to our next speaker on neurovision therapy in amblyopia and its clinical significance. Dr. Damaris Magdalene is a senior consultant at Sri Shankar Deva Netralaya at Guwahati.
Good morning. I'm very happy to be here in your midst. I will be talking to you about Revital Vision, neurovision therapy in amblyopia, a clinical significance. I have no financial disclosure. As we all know, amblyopia is the leading cause for impaired vision in children and young adults, accounting for 232 million population. It is a cortical deficit that leads to reduced best-corrected vision in a healthy eye with binocular and stereoscopic dysfunction. Treated early during the critical period when the brain is plastic, considered untreatable after age 9. Can we improve amblyopia beyond the critical age? For this, we should know what is neural plasticity. It relates to the ability of the nervous system to adapt to change conditions in acquiring neural skills and retaining it. And there has been evidence for neural plasticity reported in case reports after prolonged patching or when the beta eye's vision has been lost or degraded by ARMD, cataract, and trauma. Large meta-analysis and RCTs have demonstrated limited vision improvement in amblyopes older than 11 years, even with permanent or prolonged patching. This is what is done in Lancet 2002 and also a Paediatic study which found that 25% improved with patching compared to 23% with optical correction alone. We used to do monocular occlusion, which leads to improved monocular vision but lacks effective anti-suppression therapy. But these days, amblyopia is considered as a binocular disorder, so there has been so many digital solutions for amblyopia. Do they really work? Dichoptic therapy, stimulating both sides of the visual cortex with equal stimulus, will improve stereopsis and binocular vision and hence treated binocularly. But still, there is no level 1 evidence to support the use of binocular treatment as a substitute for current therapies for amblyopia, including patching and optical treatment. On the basis of this review of the published literature, binocular therapy cannot be recommended as a replacement for standard amblyopia therapy. So these are the different digital solutions which are available in the market, and Revital Vision has got the FDA clearance and is effective for children above 9 years of age. So what is there in this Revital Vision? It is a vision training web app that effectively stimulates the brain visual cortex. It is tailored to the patient's specific need, algorithm-based cloud technology. It can be performed at home by the patient's computer, 30 minutes 3 times a week, 30 to 40 sessions in 2 to 3 months. And the outcome, there is improvement in contrast sensitivity, two lines improvement in vision, and also improvement in stereopsis. Exactly what is the mechanism of action? How does it work on the visual cortex? These are the 4 building blocks, that is the Gabor patch, neuronal lateral interactions, brain neural plasticity, and perceptual learning. Gabor patches are widely used in the field of visual neuroscience and has been shown to efficiently describe the shape of the receptive fields of neurons in the primary visual cortex. They represent the most effective stimulation, and this is what the software uses. The next is lateral interaction. To characterize an image, visual processing involves the cooperative activity of many neurons. So they have conducted experiments and they found the response to stimuli presented within the receptive field can be facilitated or suppressed by other stimuli falling outside the receptive field when present fail to activate the cell. So when it's only the target or with the target with the flankers and target plus flankers, they give the maximum response. And this is what they have used in this therapy. Neural plasticity, based on the evidence which we have already seen, where nervous system is able to adapt to change conditions in acquiring neural skills, new skills and retaining it. And perceptual learning technique, that is repetitive performance of controlled and specific visual task will enhance neuronal interactions and stimulate the specific neurons and effectively promote spatial interaction, improve the contrast sensitivity function, and hence the visual acuity improvement. This is how the stimulus is placed. Either they increase the contrast, the global orientation, or target displacement. So first there is 2 sessions which will identify the patient's cortical deficit, and accordingly the system generates the target to be given to the patient. For example, if it's a meridianal amblyopia, the system will understand that the patient is not responding to the stimulus at a specific degree, and accordingly they will give their visual stimulation. So the patient is given 2 tasks. The first display has 3 Gabor patches and the second has only 2. The patient has to identify which has the 3 displays, and accordingly he will press the right or the left mouse button. If there is a mistake, there is an auditory feedback and the patient knows that he is not doing well, and accordingly again the target is given to the patient. So we decided to evaluate the efficacy of revital vision in adult patients who have been used occlusion therapy with no improvement. 45 patients, and we found that the improvement was from 0.54 to 0.2 logmer units, almost 2.2 lines, which has been published. And now I have done a long-term results over a 5-year period of 89 patients. 25 patients, they remained the same, and all the others had visual improvement, either 1 line, 2 lines, 3 lines, or more than 3 lines, and they have been maintaining it all these 5 years. There is a broad clinical evidence with 26 clinical studies, 11 published in peer-reviewed scientific journals, 7 randomized control studies, and 5 ongoing RCTs. And also this therapy has been used in nystagmus, albinism, keratoplasty, Stargardt's, and keratoconus. To conclude, today the key to optimize visual functions lays in addressing the brain as well as the eyes, and that is revital vision neurovision therapy. Thank you.
Thank you. Any comments? Now I invite Dr. Quresh Muscati. He is consultant ophthalmologist from Bombay. He is past president of All India Ophthalmological Society and current president of SAOPOSA. He will be speaking on red light therapy for myopia control in children's new initiative. Sir.
Thank you, Dr. Subhash. And right at the outset, I have no personal experience with this, but I was fascinated by a talk I attended at the last APO conference. And I thought that I should just share it with you because we should know what is going on everywhere in the world. Tomorrow this might become mainstream. So we should know the pros and cons and what it's about. So this is based on the talk that I heard and the notes that I took down and then the literature search. So it's they call it RLRL, which stands for Repeated Low-Level Red Light Treatment for Myopia. Why does it fit into the previous 2 talks have been on amblyopia? Because the Chinese first tried it for amblyopia. And it worked for amblyopia. And they took ethical committee clearance to see whether they could use it for myopia control. So progressive myopia, we know, raises the risk of irreversible visual impairment. So prevention and control are crucial. We know that we should be spending more time outside to reduce myopia risk. In fact, some researchers said that if we can't take the children outside, let's make glass walls and glass ceilings so that more light will come in. However, this strategy is costly and challenging. We could also all sit in golf face and have our schooling there in the brilliant sun, but that is not very practical. So there was a landmark study by Jiang et al. They proposed delivering light directly to the retina for short bursts through a device that emits red light at a wavelength of 650 nanometers. So they did a multi-center trial. They tested this as a method of controlling myopia. The data showed that the treatment is effective, safe, and because it is at home use and just 10 minutes bursts twice a day, it's quite highly acceptable to the users. So what was the inclusion criteria they used? It was a single masked parallel group study. They enrolled myopic children aged 8 to 13 years, so little older kids so they could follow, with a spherical equivalent refraction between -1 and -5, anisometropia of less than 1.5 between the 2 eyes, and astigmatism of less than 2.5. So these were mild to moderate myopes, no severe astigmatism. They were randomly assigned to the intervention group, which is red light plus their single vision spectacles. I will call it SVS, or the control group, those wearing single vision spectacles only. Red light therapy was given at home, supervised by parents. A desktop device delivers the light, that's the device that you see, delivers the light at an illuminance of roughly 1600 lux and power of 0.29 milliwatts. So over a 12-month period, the treatment was given just twice daily, 5 days a week, Saturday, Sunday off. Each session lasted just 3 minutes. So main outcome measures were change in axial length and the SER from the baseline on each follow-up visit. The follow-up visits were at month 1, 3, 6, and 12. device is connected to the internet. Please understand, China is not a democracy. So they want to know exactly what the kid is up to, the high command. So the device is connected to the net. It requires the user to log into the system using a designated username and password so that the research coordinator at the back office can observe, document, and monitor the treatment and see how compliant the patient is. Did he do it for 2 minutes? Did he not do it today? The study further demonstrated that treatment efficacy increased significantly with improved treatment compliance. So what are some of the cons? Perhaps we could extend this. Why 3 minutes? It could be more, but they'd taken approval of ethics committee for 3 minutes, so they couldn't extend the time. But no evidence was there to suggest that further extension would not be suitable. So perhaps future results. Of the 264 enrollees, 246 or 93% qualified for data analysis, and it showed the 12-month axial elongation and SER progression of just 0.13 and minus 0.2 diopters in those treated with red light versus 0.38, almost 3 times the amount, and minus 0.79 in the control. So both the spherical equivalent also was, progress was much less, and the axial length also progress was much less. No significant adverse effects. Compliance rate was 75%, and this has been published. They also found, curiously enough, an axial length shortening of 39% in participants at 1 month, and of course much less later on. And I can't explain this, but they said we use the IOL master, which is generally accepted to be quite accurate. The hypothesis for the success is that their postulation is there is scleral hypoxia, and when you give this red light there, the blood flow increases, that ameliorates scleral hypoxia, and therefore restores scleral collagen levels, so more collagen is laid down, so the eye doesn't elongate quite that much. So of course, it's more effective in slowing down the progress of SER than the axial length. All other parameters like AC depth, corneal thickness, all that of course remain quite the same. It's approved by the Chinese equivalent of the US FDA. Only 2 patients discontinued because the light was too strong, and there were no other side effects, so it's fairly safe. According to me, these are the limitations of the study which they will have to address in broader studies. They didn't implement any masking, such as using a light treatment simulator, not giving the red light, but giving some other colored light to see. Level of compliance was not assigned randomly. They just found 75% were compliant, but it's not that you do it and you don't do it type of thing. And they've not tried other wavelengths, power intensities, exposure time, duration per session to see whether those could give better results. There was another study which did a sham. That means they give just 10% power. If the RLRL study did 100%, they gave only 10% and found that the myopia progressed more than with the 100%. So that is some evidence that we have that 10% doesn't work. Duration of the trial was just 1 year. This may not be long enough to observe full-term the myopia control effects. So we need to see whether this lasts over time. And we don't know, unlike the ATOM studies for atropine drops, we don't know what happens if you stop, whether there are any rebound effects, and whether this works in non-Chinese population as well, because it's been tried only in the children of Chinese heritage so far. So in conclusion, RLRL seems promising. I think we'll hear more of it as time goes by. We need multicentric studies to see whether it works in non-Chinese children. Longer duration of studies are required, and we need to experiment with different wavelengths, different powers and duration studies to find out which is best for all humans, not just the Chinese. Thank you so much for your attention.
Thank you, sir, for an excellent talk. Now I will invite Dr. Amar Pujari. He will be speaking Strabismus Surgical Training Wet Labs, useful tool for residents. Dr. Amar Pujari is Associate Professor at RP Center, AIMS, New Delhi. Dr. Amar.
Good morning, everyone. So I'll be talking on something practical, which we can use and we can teach it to our residents. So I do not have any financial interest with respect to this presentation. So in strabismus, we are mainly interested in doing the muscle surgery. So to get an experience, we need to know the actual muscle anatomy, and we need to have a repeated exposure, what all the variations we are going to get with respect to muscle anatomy. Then only we can do the surgery. So if you look back, the surgical simulation of strabismus surgeries are evolving since almost like 4 decades. So what is the aim? Theoretical aspects, so many people were telling the theoretical things. Even we can read the textbooks and we can teach or we can discuss the theoretical aspects. But when it comes to exposing the muscle, suturing the muscle and passing the scleral suture, that is very critical because you need to do it repeatedly and you need to have a good thorough understanding. So for this one, I went through the literature since I'm working on this one since 2017, since almost 8 years. So I had some of the previous literatures. So after that, I tried to simulate it on a goat eye. So you can see that this is a goat eye where we can get it from the butcher shop. So initially I went there and I said that you need to retain a more amount of extraocular tissue, right? So we inspected the eyes and we got some amount of muscle. So later we said that try to retain more tissue. So in that one, we were able to see that the muscles were intact in those eyes. So whatever the eyes which had 10 to 15 millimeter of extraocular muscle which was intact, we selected those eyes. Of course, they were not perforated. They had a good tone. And we tried to fixate it on a mannequin head. So that's how you can fixate it. So that is the gauze. And you can roll it around the globe and you can fix it in the orbit. And at the free hand, you can pass a suture so that you want to simulate the normal tension. So this is simple recession and resection surgery. That is recession, this is resection surgery. So similarly, that is one possibility which I published. So later, we wanted to see whether we can simulate other complex surgical procedures which are very important in strabismus and also oblique muscle surgeries. So let's see. So this is the infraoblique muscle. So this is a globe here. So this is the lateral rectus muscle which I am simulating here. This is the inferior rectus muscle. So there is a nasal crust is there. So lacrimal crust, sorry. So this is the infraoblique muscle because we are going to take more muscles and we are going to fix it to one eye. So there is a naturally IR is there. This is the LR and I took another infraoblique. This is the lacrimal crust which I have fixated there, and this is around 9 to 10 millimeter behind the lateral rectus muscle. So this is how infraoblique muscle anatomy looks. So once you teach it to the residents and you can simulate for yourself also, see how I am hooking the muscle, I am separating it, and I am going to disinsert. So this is a free end, I am going to pass the sutures using 6-through vehicle. You can see that this is Fink's procedure, that is 6 mm inferior and 6 mm posterior to the inferior border of the lateral rectus muscle. So this is a Fink's location. So you can teach it to the resident that, of course, Fink's we are not doing it often. Parks we do this one. So Parks is nothing but 2 millimeter lateral to the inferior rectus muscle and 3 millimeter posterior. So this is a Parks level. So you can understand, you can imagine practically how this is getting recessed and also how it is getting anterior positions, right? So here you can see that this is iliac and Ankin, where this is the lateral rectus, inferior rectus lateral border. Both the sutures we are going to pass it. So we do modified DNN where one end we suture here, another end we suture here. So this is total anterior positioning. So you can see that muscle has moved from here till here. So there is a recession also. This is recession cum anti-elevation. So this is nothing but stages or anteronasal transposition. This is inferior rectus muscle. I was here. So we sutured on the anteronasal side. So we can simulate the infraoblique muscles. We can repeat it and we can practice it. So at the same time, let's see whether we can simulate other complex rectus muscle surgeries. So this is another globe. You have the muscle here. So Fardan or the posterior fixation, post-equatorial fixation of the muscle, which we do commonly. So we have the 5081 suture here. So often we suture at 14 or 16 millimeter, right? So we are going to suture it on the muscle. After that, we are going to take the muscle. You can see how the curvature or the liver arm has reduced. So effectively, this reduces the torque. That's how you can selectively weaken the muscle when it is actively acting, right? So this is another this thing eye. You can see that this is superior rectus, this is lateral and medial rectus muscle. You can transpose half the rectus muscle after splitting it. So you can do posterior fixation or without posterior fixation. So this is a full rectus transposition, superior rectus, LRMR. So it is like doing the naps with posterior fixation. So this sort of like transposition with fixation you can do because you are going to get an understanding, right? So what all the things we'll see and how the muscles are getting reoriented, how that is going to change the vector force. So this is a simple Y splitting. You have the rectus muscle, you are going to split it into 2 halves, then you are going to disinsert, right, after suturing, and you are going to recess it. So this is Nishiza's procedure or belly transposition. We have 2 rectus muscle, vertical is there. So in the respective quadrants, around 8 millimeter, right, you are going to pass the suture, and 14 millimeter from the limbus in the respective superior-temporal and superior-nasal quadrant, you are going to transpose the rectus muscle. So these are the often, almost like it covers the 95% of the strabismus surgery. So similarly, for supraoblique muscle, we do posterior tenectomy of the supraoblique muscle. So this is a superior rectus which we are simulating. So we are going to retract it. So this is supraoblique tendon. You can see that. And depending on whatever the measurements you have, 1/7 or like 2 millimeter anterior torsional fibers we are going to separate. And these are the depressor fibers. We are going to take a chunk out of it, right? So only torsional fibers are intact and the depressor fibers are gone. So this is PTSO, which we do commonly. Similarly, you can simulate the Harada Ito, where these are torsional fibers. You are going to move towards the lateral rectus muscle, right? So whenever there is a torsional inability because of supraorbital palsy, you do in Harada Ito. So this is tucking. Again, this is for to get an understanding. Tuck is done, but it is not that common. But of course, PTSO is more common. So you can fold the muscle on itself, you can pass the Weichel sutures, and you can leave it just to tighten the muscle whenever there is a congenital supraoblique tendon laxity is there. So to conclude, GOAT-I can be used to simulate various simple and complex strabismus surgeries. So in wet lab, we can use it for ourselves who are the consultants who are getting hands-on training, or you can teach to the residents, and by doing this one, we are going to get more practical experience, how to expose the muscle, how the surgical procedure actually work, rather than just saying hypothetically, right? But the limitations of these, simulations are, there's so much free space available here. You can see that, right? We need to open the conjunctiva when you are doing it on human eyes, and it's going to bleed a lot, right? So here, there's no bleeding. These are fresh eyes or dead eyes. They don't have any vessels, so that's why they are very clean procedures. But that should not give an extra liberty saying that, okay, this will be this simple. This is for understanding purpose. So we need to understand that there is so much space here. We need to have a repeated practice in a constrained space. And of course, bleeding, we need to have a hands-on training. Once we get a training here, we need to have a monitored training in the surgical OTs. And these are some of the posters we have made, which we have displayed in our National Ophthalmic Surgical Skill Center at our center, RP Center, AIMS, New Delhi. Thank you.
Thank you, Dr. Amar.
Yes.
It was nice talk about all the variety of various procedures. But have you not found that obliques are so too far away from what we see in the human
Yes,
eyes?
ma'am.
We
So,
have had this wet lab
yes,
done.
ma'am. As I said, I am suturing it 9 to 10 millimeter behind the lateral rectus insertion for infraoblique muscle. For supraoblique, definitely, because the orientation is in GOAT-I is not that practical as human eyes. Of course, it is slightly anterior. But just for understanding, we showed that one. But of course, infraoblique we can simulate. We can go posteriorly. But supraoblique, because we need to span the tendon. So if you want to find a naturally inserted muscle, which will be quite anterior in GOAT size.
Thank you, Dr. Amar. I now invite Professor Subhash Dadaya to talk about role of AS-OCT in strabismus resurgery. Dr. Subhash is Director, Professor of Ophthalmology at the Guru Nanak Eye Center, Maulana Azad Medical College in Delhi.
Very good morning to one and all. So basically, what is the role of imaging modalities in strabismus surgery? It is to understand the etiology of strabismus, good surgical planning, and it is especially important during the time when surgical details are not available, because most of our patients, they are uneducated and they don't keep the records. So in that situation, then to operate the same eye or other eye, to know the exact location of the muscle, to know the status of resected and recessed muscle and any scar tissue. Various modalities are CT, MRI, USG, UBM, and AS-OCT, and basically each has advantage and disadvantages. AS-OCT is superior in terms of non-contact, and basically the wavelength is around 310, so it generates two-dimensional images of high resolution. There is faster scanning, less scattering, there is no contact, no radiation hazard, and no need of anesthesia. So this is the machine which is being used at our center, no financial interest. So basically, we have to identify the muscle on AS-OCT. In unoperated eye, the muscle begins as a curved, thin, hypoechoic structure at the fixed distance from the angle, and this corresponds to initial tendinous part of the muscle, which then traced posteriorly corresponds to hypoechoic area that corresponds to the muscle belly. So basically, this longitudinal scan provides the lengthwise details, and the cross-sectional provides a widthwise detail, and hence combined scan is more effective and productive. And you can see the muscle in this. Then medial rectus identification. In recessed medial rectus muscle, the anterior ocular coat contour can be unremarkable, and posterior ocular coat contour can show variable thinning. In resected medial rectus muscle, the posterior ocular coat might appear thicker and irregular with variable conjunctival folds. So these are the AS-OCT imaging of the resected medial rectus muscle, which is confirmed by increased in muscle thickness at the insertion site, and this is the recessed medial rectus muscle, which is found at around 6.7 mm from the limbus. Lateral rectus identification is more easier because there is more working space and there is absence of plica semilunaris and caruncle, which shadows the visibility of the structures. And this is the ASOCT picture showing insertion of lateral rectus muscle from the limbus. So there could be errors in muscle identification. Postoperatively, the muscle image needs to be closely judged till 4 weeks because the muscle space often anomalously appear large hypotenuse layer which settles over a period of time with resolution of edema and conjunctival flattening. Then presence of vessels and presence of dense conjunctival folds are scarce. They interfere in identification of the muscles. So this is part of ongoing thesis where we have referred patients for the resurgery, strabismus resurgeries, and this is the preoperative and postoperative photograph of case of residual esotropia, and this is the ASOCT picture in which medial rectus was found around 7.8 mm, and when we measured with the intra-op handheld caliper, it was found at around 9 mm, and lateral rectus was on ASOCT, it was at 6.39 mm, and with caliper it was around at 7 mm. This is another case of residual exotropia with V pattern. This is the preoperative and postoperative photographs, and these are the ASOCT pictures of the medial and lateral rectus, and approximately the medial rectus was found at around 8.7, and intra-op it was found around at 9 mm, and lateral rectus was found around 13.5, and on caliper it was found at around 14 mm. This is another case of residual exotropia with V pattern. This is pre and postoperative photographs. These are the ASOCT pictures of medial rectus and lateral rectus. Another case of residual esotropia with pre and postoperative photograph. These are the ASOCT pictures of the same patients. Another case of residual exotropia. These are the preoperative and postoperative photograph of the same patients. These are the ASOCT and caliper findings, and here lateral rectus was not appreciated. This is another case of consecutive exotropia, preoperative and postoperative photograph, and on ASOCT, MR was around at 8.7 mm, and intra-op it was found at around 10 mm, and in ASOCT lateral rectus was found around at 10.85 mm. This is another case of residual exotropia. These are the pre and postoperative photographs, and these are the ASOCT findings of medial and lateral rectus. And intra-op also with the caliper, the medial rectus was and lateral rectus were found at around 6 mm from the limbus, and in ASOCT it was 6.25 and 6.47. This is another case of consecutive esotropia with preoperative and postoperative photographs, and these are ASOCT findings where medial rectus was found at around 6.05, and on intra-op it was found around 6 mm from the limbus. ASOCT lateral rectus was found around 11 mm. This is another case of consecutive esotropia with preoperative and postoperative photographs. These are the ASOCT findings of the medial and lateral rectus. This is another case of residual exotropia, pre and postoperative photographs. These are the ASOCT findings and intra-op findings of the medial and lateral rectus. This is case of left consecutive exotropia, pre and postoperative photographs. These are the ASOCT findings of the same patient on medial and lateral rectus. These are the ASOCT findings of patient, DRS patient. And this ASOCT can also be used for measuring the vertical recti also, and here you can see the ASOCT finding in superior and inferior rectus muscle. So basically, Extraocular muscle insertion site is treated as a reference point in calculation of the amount of the surgery. Since prior strabismus surgery can alter the insertion point of muscles, a careful preoperative evaluation is mandatory, especially in patients of resurgery. And basically, this role of ASOCT, it helps to design a surgical plan by localization of the displaced extraocular muscle insertions. And I think we have done around 27, 28 patients in that thesis, and we have been able to operate only in that eye in which surgery has been done previously at other center, and surgical details were not available. So it is a useful modality for localization of displaced extraocular muscle insertions. Previously another study has been done by Savlin Kaur et al., and they have found it useful in resurgeries, and they have done only in 12 patients. And another study has been done by Dr. Ahmad Puzari et al., and they have also found it as a reliable modality. So, to conclude, this ASOCT with advanced scanning ability can be used to locate extraocular muscles locally. It is readily available for preoperative measurement of extraocular muscles, and it is useful. Thank you.
Thank you, Dr. Subhash, for highlighting use of something which is there in most institutes for other purposes, that it could be used for strabismus surgery as well. Invite Dr. Dipti Joshi to tell us about how a toxin has turned a friend, botulinum tox, in the management of strabismus. She is a pediatric ophthalmologist at the M.M. Joshi Eye Institute in Hubli, South India.
Good morning, everyone. So for the next 8 minutes, I would be taking you through the journey of botulinum toxin for us strabismologists. So it basically started as a terror, as a causing food poisoning and paralysis in 1700. And this paralysis was used by Alan Scott to induce palsy of muscles in rhesus monkey first, which was then turned into human muscles. And finally, it got an FDA approval in 1989, following which it has been used for various oculoplasty procedures and as by strabismologists. So it acts by blocking the release of acetylcholine at the neuromuscular junction. And so immediately it causes a flaccid palsy into the injected muscles and antagonist contracture or the overaction. But the effect does stay for a prolonged period of time. And how does it happen? That is because of our sensory effect and binocular effect inducing fusion, which helps in maintaining orthotropia at a later date. So the preparation, a 50 unit of botulinum toxin usually is prepared by adding a 1 ml of normal saline. So it makes a 0.1 ml which contains 5 units, that is 1 unit of your tuberculin syringe. So the most important point here is to just roll it very gently, not to shake it vigorously after reconstitution. Dosing has been a big question mark among all the strabismologists who have been using it. But if you use it solo, nearly for 40 PD, 4 to 5 units in ipsilateral, and more than that, a bilateral injection may be required. But if it's used as an adjuvant to a surgery which is already being performed, 2 to 4 units would be more than sufficient, depending on how much residual we would be anticipating post our surgery. So it's become a Brahmastra in strabismus surgery in the past 3-4 years. We have been using it in various types of esotropias, ranging from infantile esotropias to acute comitant esotropias, being used in paralytic strabismus, as well as being used in restrictive strabismus, especially in case of thyroid eye disease and few cases of nystagmus also. So let me take you through few of the cases. Like this is a case of infantile esotropia. We all know that leaving behind a small residual ET, if when both MR recession has been done, could be dangerous to the child at this age. A microtropia could negate all the effect of surgery done by us. And in those scenarios, direct injection and open sky injection, where after performing medial rectus recession, we locate the belly of the medial rectus and directly inject the botulinum toxin. The care to be taken here is it shouldn't ooze out, and after injecting, not much of meddling of the muscle has to be done, and immediately the conjunctiva has to be closed to prevent the extravasation of the botulinum toxin into the surrounding muscles and to prevent the side effects. You can see here that open open procedure still causes some amount of ptosis and some amount of exotropia to some duration of the time, but over a period of 6 to 7 weeks, the child gets restored to orthotropia. So there have been two schools of thought with respect to botulinum toxin in infantile esotropia. The first school of thought says about solo botulinum toxin, no surgery, but then solo requires multiple procedures and multiple GAs would be required. Advantages here, we can go through closed approach, so less doses and less extravasation into surrounding tissues. When used adjuvant to surgery, usually a single injection takes care of our procedure. And because it is open sky, to some extent post-operatively, we do see ptosis as well as a consecutive exotropia. But there are some clinching points which has to be taken care when we are doing botulinum toxin for infantility. For example, in this child, when we injected botulinum toxin and this child went into this consecutive XT as it was expected to us, but over a period of next 3 months, the XT didn't return back. So where did we go wrong? The amblyopia management is crucial before giving botulinum toxin into any child when we are planning with respect to surgery. If amblyopia management is not done adequately, the chances of the child going into consecutive XT fusion doesn't come back and the XT remains. An adequate amblyopia management was done and the MR which was resist was advanced, and this is the child at a later age, but it was a Herculean task. And so a learning point when we are using a botulinum toxin is an amblyopia management. Pre-injection is mandatory. In cases of large angle esotropia, as in this girl, so usually we may require 3 muscle surgery, and if we are really hesitant to go ahead with 3 muscle surgery, which sometimes at a later date can cause a consecutive exotropia, or you want to preserve the child's third muscle for a future surgery, a botulinum toxin augmented medial rectus recession. If you can see here, the left eye has a minimal ptosis, and this is over a period of next 2 months, and the child is perfectly orthotropic with the botulinum toxin augmented medial rectus recession. Botulinum toxin went into a boon after the boom of an acute comitant esotropia, which happened in the past 2 to 3 years post-COVID. So usually this works well in case of acute comitant esotropias because it is an acute esotropia. Stereopsis is good. It is mild to moderate amount of esotropia, and hence the ET, can the audio be muted please? And hence the ET is being taken care. In these scenarios, the botulinum toxin can be given as a OPD procedure too. It can be given in lying down or the sitting position. The most important point here is there shouldn't be any conjunctival bleb which is formed, and immediately the child shouldn't be rubbing his or her eyes, and a wrapping of the eyes or the protection of the eyes immediately, so that for the next 2 to 3 hours, the child doesn't rub his eyes to prevent the extravasation becomes more and more important. This is the child post-operatively. So we in North Karnataka, in the last summer, we had a boom of an epidemic of mumps viral infection, and post-mumps viral infection, in most of the children, we had a cases of acute comitant esotropia, which was a viral ET, and in some infants, we did try about only botulinum toxin in these acute esotropias, as seen here. This was a case of bilateral ET, which was seen, the unilateral left ET, which was seen in the child, and post-botulinum toxin injection, the child was orthotropic. This is another child. Both of these children are still being observed by us for the past 6 months. There has been no recurrence, but I think they do need a long-term follow-up. We need to mention the parents that any type of strabismus can recur. So none of the treatment which is being done by us is a permanent procedure. So the chances of recurrence is very high, and if that happens, a surgery is being done. So this is just an adjuvant therapy, temporary therapy. When parents are not ready for surgery, when they are not compliant with patching, at least we are taking care that the amblyopia is not happening in the child. Sixth nerve palsy is a known phenomena where we actually measure, and in the closed procedures we can give to the medial rectus muscle. Similarly, the same thing has been done in case of third nerve palsies and to treat the intractable diplopia and to prevent the contracture of the antagonist muscle. So this, before I wrap up, consecutive tackling has been another role. This is a case of a post-SO palsy where there is a left hypotropia post-SO tuck. And in this scenario, when we injected botulinum toxin into the inferior rectus muscle, there was some amount of inferior rectus underaction immediately, but later the patient turned out to be orthotropic over a period of time. So immediately, no post-operative medication is required. Follow up at 2 weeks. Please see for the early effects of the toxin, and 4 to 8 months to see the delayed effect. complications do exist like ptosis, vertical diplopia. Re-injections are required in many of these cases, and cost is one of the barriers in developing nations. But we need to select few ideal cases which are best for botulinum toxin. And as mentioned here, the acute cases, the intractable diplopia cases, cyclical deviations, which we are still doubtful about the surgery, these become some of the ideal cases. With this, we can use botulinum toxin to treat some amount of the strabismus in children too. Thank you.
Thank you, Dr. Deepti, for discussing the possibilities of botulinum toxin in the various situations of strabismus. Now I call upon Dr. Elizabeth Joseph to talk on sharp vision and straight eyes, role of LASIK in accommodative esotropia. Dr. Elizabeth Joseph is the head of the Department of Ophthalmology and Chief of Paediatic Ophthalmology and Strabismus at Little Flower Institute of Ophthalmology, Angamali, Kerala, India.
Good morning, everyone. At the outset, I would like to thank Professor Subhash Dadia for inviting me here and giving me this opportunity. I'm talking on sharp vision and straight eyes, the role of LASIK in refractive accommodative esotropia. See, accommodative esotropia can be refractive or non-refractive. In the refractive type, it is due to hypermetropia, uncorrected hypermetropia, usually starts by 2 to 3 years of age and is treated by glasses as seen in this picture. And usually, as the child grows older, the esotropia will come down because the hypermetropia also come down. But most of the time, as the child grows older, so although the esotropia comes a little down, it persists and the dependence on glasses is persistent, like in this child who has grown into adulthood. And I will present one person. This is a 22-year-old lady presented to us with hypermetropia and esotropia. And he gives history of wearing glasses for the last 18 years. And with glasses, she's orthotropic. And she doesn't want to wear the glasses. Can we offer refractive surgery? See, that person was taken for LASIK surgery. In hypermetropic LASIK, the laser ablates the paracentral circular area of the corneal tissue, unlike in myopia. In myopia, we treat the center, and in hypermetropia, we treat the paracentral area to make a central steepening. You can see the video. Yeah, you can see the video. I have applied the suction ring and Moria microkeratome. The microkeratome is being used to make the flap. And after the flap is made, the suction is released and the microkeratome and the suction ring is removed. And then an instrument like a spatula is used to lift the flap. And once the flap is lifted, the bed is irrigated well and laser is applied and the flap is repositioned. That is the flap LASIK we do. And postoperatively in that patient, she attained 6/6 vision in both eyes. And you can see the pre-op pictures. It's an esotropia corrected with glasses. This is just after LASIK. On the first day, the esotropia is gone and the refraction is corrected, and this is 1 month later picture. That means both esotropia and hypermetropia were corrected in one single sitting. And I'll present another case. This is a 13-year-old girl who gives history of hypermetropia, unilateral, and amblyopia. And the child is not using contact lenses and is not very compliant with patching. So amblyopia had become irreversible or intractable. And here we have done a transepithelial laser because the child was not cooperative for flap LASIK. You can see that straight away we are using the laser onto the epithelium, first to laser off the epithelium, and after the epithelium is lasered, we do the stromal laser. In this, there is no need of any suction ring, there is no need of any flap, less invasive procedure, and there are no flap complications. It means even if the patient rubs the eye, since it is a child, it does not produce any problem. There is no problem with rubbing, and on the table you don't have to have alcohol. Only thing, the patient may take long time to fixate, and once it is fixating, we can apply the stromal laser. And this is ideal for children or young adults. Transepithelial laser is supposed to be safer than the flap LASIK. Now let us see the postoperatively the patient had a residual esotropia which was treated by medial rectus recession. And you can see that that picture, the eyes are straight and there is no need of any glasses. So in partially accommodative esotropia, the refractive surgery will correct the accommodative portion of the partly accommodative esotropia, and after that, medial rectus recession has to be done. This is one publication. When I looked at the literature, although in 1983 we started, the laser was popularized in the 90s, but it is very popular in the treatment of myopia. And in accommodative esotropia, very seldom it is used. So this procedure can be popularized. That is the purpose of this presentation. See, another article showing the effectiveness of refractive surgery in accommodative esotropia in children with special needs, and children and adolescents also with special needs. Clinical outcome of 108 cases was published in the Investigative Ophthalmology 2013, and they have shown good results. Again, this is another article from JAPOS 2004. The LASIK is effective in hyperopic eyes. See, when we discuss about hyperopia, unlike myopia, in hyperopia, all the parameters like the axial length, dioptric power, etc., get stabilized earlier than myopia. So you don't have to wait up to 18 years of age. This is again another literature search showing that both LASIK and PRK are effective in the long-term reduction of accommodative esotropia. Sometimes accommodative esotropia goes into decompensation. In that case, even if you correct the refractive error, you may have to do a strabismus surgery. How young can you do refractive surgery? Actually, FDA approval is only after 18 years. That is the FDA approval. But many perform refractive surgery in children. And the younger stage is still not established. The difficulty is to get a good fixation even after a general anesthesia. And when you do LASIK, issues like eye rubbing is there when you do in a younger child. But it is worth the trouble in anisometropic amblyopia. Latest preferred practice pattern in American Academy of Ophthalmology, I had looked in 2024, they have recommended refractive surgery in accommodative esotropia, especially if it is associated with anisometropia and amblyopia. And special concerns in hyperopic laser, the regression. Regression is more common in hyperopia. Corneal regression caused by the progressive change in the shape of the cornea after LASIK intervention, and flattening of the central cornea may cause decrease in the corneal power. And if there is a latent hypermetropia, it may become manifest. So these are two things which we have to remember when you do a hyperopic LASIK. That means later on there may be some refractive problems. And to conclude, refractive surgery in refractive accommodative esotropia is effective in the correction of refractive error and strabismus at one shot. This is well received by patients. Long-term results are good, stable and safe. Main indications are adults with fully or partially accommodative esotropia and older children who are not compliant to wearing glasses or contact lens, and children with special needs. Thank you very much.
Thank you, ma'am, for an excellent talk. Now I invite Dr. Sweta Chaurasia. She will be speaking on full tendon modified Nishida's procedure in large complex strabismus. Dr. Sweta is working as associate professor at PGI Chandigarh, India.
Thank you, sir. I would like to thank Dr. Dadia for having me here. To begin with, transposition procedures are often useful in improving ductions past midline and at the same time correcting large angle primary position deviation in large angle concomitant strabismus. But recessing the tight antagonist with full tendon transposition can bear the risk of anterior segment ischemia if done in the same sitting and even when spaced with time. So partial tendon transposition and modified Nishida are the safer and popular alternatives, but efficacy remains low. Because the vector forces used in modified Nishida no-split nototomy transposition procedure consist of only 1/3 of the muscle width with mean correction of only 30 prism diopters. So we described a no-split nototomy full tendon modified Nishida procedure in a rare case of bilateral medial rectus aplasia in which we use the full muscle width, and we got a good alignment in the primary position along with the correction of adduction. So let's see the varied case examples of large angle strabismus managed with this procedure. First, a patient of monoocular elevation deficit who presented, he had squint surgery done outside. Right eye inferior rectus was recessed for 4.5 mm way back. On motor examination, he had a hypotropia of around 30 degrees in primary position and SR under action of -4. Ptosis workup revealed a severe ptosis with poor Bell's and Marcus jaw winking. So full tendon modified Nishida was done in the right eye and the left eye RNR was done. And you can see that there was primary position alignment was achieved along with improvement in supraduction. So this is the surgical procedure. Traction sutures were passed and limbal incisions were given temporally. The superior rectus was hooked and check ligaments were dissected. The muscle was isolated. 8 mm was marked on the muscle and non-observable 6-0 dacron was used and the muscles were secured. Now 14 mm was marked along the superior border of the lateral rectus and the same needles were passed to the marked site and the same needles were then passed to the superior rectus and the muscle was mobilized. Similarly, the inferior rectus, the procedure was done, 8 mm was marked and muscle was, then 14 mm was marked at the inferior border of the lateral rectus and again the sutures were passed through the sclera and through the muscle. So the modification in our technique was that the full width method was used as well as we transposed along the border of the lateral rectus, unlike modified Nishida where the sutures were passed through the sclera between in the midway between the superior rectus and the lateral rectus. So there were 7 patients who were operated and there were 3 patients who had IR recession done prior and 3 done in the same sitting. So mean preoperative hypotropia improved from 65 to 4 prism diopter at the end of 6 months. Mean pre-op supraduction improved from -4 to -1.36. So mean correction achieved by this procedure alone without IR recession was 52 prism diopters. And Bell's improved post-operatively, following which ptosis surgery was done in all the patients. These are some of the other patients showing improvement in primary position and as well as improvement in supraduction. So coming to the 6-nerve palsy, this patient presented with post-traumatic 6-nerve palsy in the right eye. You could see there was a large esotropia in the primary position of around 50 prism diopters with abduction limitation of around -4, -5 because the eye was not coming to midline. Then force duction test was moderately tight for medial rectus and force generation test, there was no tug. So this was the post-operative picture after the procedure. You could see the improvement in the primary position alignment as well as improvement in abduction. Then the patient did improve with the binocular free field of around 10 to 15 degree and along with the improvement in binocularity. This is the patient after MR recession preoperatively showing residual esotropia which was corrected after this procedure in showing improvement in abduction. So there were 8 patients which were operated and all of them underwent this procedure along with the MR recession and mean pre-op esotropia improved from 65 to around 2 prism diopters at the end of the 6 months. Mean pre-op abduction deficit improved from -4.29 to -1.36 and mean correction achieved by this procedure was 41.75 prism diopters. There were 2 patients of esotropic DRS which were operated of 45 and 40 prism diopters. Mean abduction was improved from -4 to -1 in each of the patients and they underwent this procedure along with the MR recession and correction achieved was 30 and 25 each. Then there were 2 patients of exotropic DRS, and mean abduction was -5 in each patient. Both of them underwent LR periosteal and full tendon modified Nishida. This is the patient after LR periosteal fixation showing deficit abduction. So the full tendon modified Nishida was done after the LR periosteal, and mean correction achieved by this procedure was 25 and 30 base out respectively. Then there were 3 patients of lost muscle, and mean pre-op exotropia improved from 71 prism diopter to 21 prism diopters post-operatively, and adduction deficit improved from -4.67 to -0.27 prism diopters, and mean correction achieved by this procedure was around 52 prism diopters. So this is the boxer whisker chart showing the correction achieved by each of the procedures, and you could see the overall mean correction was around 44 prism diopters. The vertical group improved around 53, and the horizontal the procedure improved around 40 prism diopters. The mean correction achieved by in the restrictive squint was smaller, but the overall p-value was statistically significant, but applying Bonferroni correction, the multiple comparison, the adjusted p-value was not statistically significant. If we compare the results with the augmentin full VRT, and we found a similar results. Even in cases of restrictive strabismus, our results matched with the study with Velez et al. So we didn't had any anterior segment ischemia in any of our patients, which we did with the ICGA. To conclude, this full tendon modified Nishida is a safe and effective procedure in correcting large angle incomitant strabismus and improving ductions when done with or without ipsilateral antagonist recession. Without tenotomy, this technique displaces the full thickness pulleys of the bellies and hence the muscle center in the direction of the transposed side, which is close to the border of the paralyzed muscle, resulting in greater tonic ducting force. Thank you.
Thank you, Dr. Shweta. And we now have Dr. Leela Mohan to tell us about large angle exotropia, recess resect with muscle transplantation. Dr. Leela is a senior consultant and head of the Department of Paediatric Ophthalmology and Strabismus in Comtrust Eye Hospital, Calicut, India.
Good morning. Let me thank Sao for giving me this opportunity. So, recess resection with muscle transplantation in large angle exotropia. Large angle exotropia, the definition is not very precise. We may consider more than 60 prisms as a large angle. Large angle intermittent exotropia often become constant over time and bears a great psychosocial impact on the patient. Often there is a dominance of one eye in these cases. Sensory exotropia with a large angle is also not uncommon. Sensory exotropia, often this single stage surgery may not be enough in these cases, and exotropia of more than 55 prisms often need more than 2 horizontal muscle surgery involving both eyes, which may not be acceptable to the patient, especially in sensory exotropia. So, coming to the surgical options, best option for large angle exotropia is debatable, and most of the surgical procedures give undercorrection or lateral incomitance is not uncommon. Maximal or supramaximal recession, that is 2 muscle surgery with augmentations with either Botox injections to the recess muscle or central tenectomy to enhance the effect of recession, produce palpebral fissure changes or lateral incomitance. 3 or 4 muscle surgery, that is bilateral lateral rectus recession with one or both medial rectus resection, is often chosen in large angles. And Riza et al. Evaluated the dose response of 3 muscle surgery in large angles up to 80 prisms and found it to be 2.5 to 3 prisms per millimeter. So even with these suggested tables, undercorrections are very common in these cases. And in recess resection with the transplantation, the segment of resected muscle is used to lengthen the lateral rectus, which prevents muscle from creeping forward, and the actual insertion remains behind the equator, so ocular movements are not affected. So this is a resection of the medial rectus, 6 millimeters. Sutures are placed at the resection and at the where disinserted, and after clamping you take the muscle. Usually we get only about 5 millimeters even after 6 millimeter resection because the muscle shrinks to some extent. And in exotropia, the medial rectus is less, the lengthening is less available, but in large angle esotropia, you get a larger amount of resected lateral rectus. So still about 3.5 to 4 millimeter enhancement is obtained in these cases. You resuture after taking the resected muscle, you insert it to the recessed lateral rectus. Should I fast forward? This was done under topical anesthesia, so we have placed a cotton button over the cornea. So this is the resected muscle which is sutured to the distal end of the lateral rectus, and after suturing it to the distal end of the lateral rectus, the muscle is inserted to where you want the recessed muscle to be, in this case 10 millimeters behind the insertion of the lateral rectus. So it is sutured, and so I think I will. Yeah, that is the lengthening obtained, and would like to fast forward it. So that is about 10 millimeter behind the insertion of lateral rectus. We are suturing the muscle. So how does it work? Up to 90 prisms of exotropia can be fully corrected with this technique, and the transplanted muscle undergoes fibrosis by the end of 3 to 4 weeks. Elasticity of the muscle is lost, but the autologous nature has the advantage of tissue spacer and maintain the tensile strength. Roger Hayat in 1973 has shown in animal studies that the tissue, though it loses elasticity of the muscle, attaches to the sclera by about 3 weeks and is viable. And he did the first transplant in humans as well. So this autologous tissue can be used for an extension of the recessed muscle. In the 90s, it was mainly used for resurgeries by Diamond et al. And later, many surgeons, including Amitava, Jitani, and many others, have shown it to be useful in primary surgery in large angle strabismus. So these are some of the cases. We have done recess resection with muscle transplantation and under local topical anesthesia. And a correction ranging from 85 to 95 prisms was obtained in these cases. And it was maintained for more than 6 months. And no abduction limitation was seen after 3 months. There was some amount of limitation of -1 immediate post-op, but no abduction limitation was seen after 3 months. So often patients are not willing to get both eyes operated at the same time, and in long-standing exotropia, the chance of second surgery are very high. And recess resection with transplantation gives us maximum correction, and a second surgery may not be necessary. And topical anesthesia in this age group especially gives an edge for the prolonged time for surgery, in which case the peribulbar block may wear off also. So unilateral maximal recess resection with transplantation is a good option in large angle exotropia and can be successfully done under topical anesthesia too. Thank you.
Thank you, ma'am, for nice talk. We were given the mandate to finish the session at 9:15, and we have finished it at 9:15. And I will request all the speakers to come for a photograph.
We are about to commence the ceremonial inauguration of the Annual Ophthalmological Congress 2024 of the College of Ophthalmologists of Sri Lanka and Association of Vitreoretina Specialists of Sri Lanka. Please remain seated. I kindly request the audience to rise and keep standing while the ceremonial procession enters the hall.
Ladies and gentlemen, please remain standing for the national anthem.
Sri Lanka Mata, Appa Sri Lanka, Namo 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 Mata, Sundara Sri Varini, Surani Ati Sobhamana Lanka, Ranya Ganaya Nikamal Valaturu Piri Jaya Bhumiya Ranya, Appa Hatta Sapa Siri Setta Sadhana, Jeevanaye Mata, Viliganu Mena Appa Bhakti Puja, Namo Namo Mata, Appa Sri Lanka, Namo 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 Mata, Obave Appa Vidya, Obamaya Appa Satya, Obave Appa Shanti, Appa Hada Tula Bhakti, Oba Appa Aloke, Appa De Anuprane, Oba Appa Jeevanane, Appa Muktiya Obave, Nava Jeevana Devini, Nikina Appa Pubudu Karan Mata, Jnana Veeda Vadavamina Ragena Yanu Mena Jaya Bhumikara, Ekamavakade Daru Kala Vedina, Yamu Yamu Vinopama, Prema Vada Samaveda Durara, Namo Namo Mata, Appa Sri Lanka, Namo 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 Mata.
Kindly remain standing for the lighting of the traditional oil lamp. I would like to call upon the following dignitaries to light the traditional oil lamp.
Dr. Quresh B. Muscati, President, South Asian Academy of Ophthalmology, Paediatric Ophthalmology and Strabismus Association.
Dr. K.R. Dayavansa, President, Association of Vitreoretinal Specialists of Sri Lanka.
Dr. Amila J. Alvis, President, College of Ophthalmologists of Sri Lanka.
Thank you. You may now take your seats. Ladies and gentlemen, the ceremonial inauguration of the 32nd Annual Congress of the College of Ophthalmologists of Sri Lanka and the 13th Retina Meeting of the Association of Vitreoretinal Specialists of Sri Lanka has now begun.
We would like to invite the following dignitaries to make their way to the head table.
Dr. Quresh B. Muscati, President of SAOPOSA.
Dr. K.R. Dayavansa, President, Retinal Association.
Dr. Amla D. Alvis, President, College of Ophthalmologists.
Professor Subhash Dadaya, Secretary, South Asian Academy of Ophthalmology, Paediatric Ophthalmology and Strabismus Association.
Dr. M. Malaravan, Joint Secretary, College of Ophthalmologists of Sri Lanka.
Dr. Vatsala Gunasekara, Secretary, Association of Vitreoretinal Specialists of Sri Lanka.
Please take your seats.
Now, I would like to invite Dr. K.R. Dayavansa, President, Association of Vitreoretinal Specialists of Sri Lanka, to welcome you all and deliver a few words.
Aibowan. Very good morning. Dr. Quresh Maskati, the President of SAOPOSA, South Asian Academy of Ophthalmology, Paediatic Ophthalmology and Establishments Association. Dr. Amile Dialvis, President of College of Ophthalmologists of Sri Lanka. Councils and past presidents of both College of Ophthalmologists of Sri Lanka and Association of Veterinary Specialists of Sri Lanka. Delegates of SAOPOSA and all the delegates from all our partner associations and Women in Ophthalmology and the young ophthalmologists. Consultants, postgraduate trainees, medical officers, allied professionals, sponsors, trade exhibitors, and all my dear delegates. It is a moment of extreme pleasure to welcome each and every one of you present today on behalf of College of Ophthalmologists and Association of Veterinary Specialists to the 32nd Annual Scientific Sessions and the 13th Colombo Retina meeting. A warm welcome to Dr. Quresh Maskati, the President of SAOPOSA, and your presence today is an honor for all of us, sir. It is my great pleasure to welcome Dr. Amile Dialvis, President of College of Ophthalmologists of Sri Lanka, and he is a key innovator and the coordinator of this wonderful conference. It is impossible to organize this sort of such a great event without a good team. Therefore, I extend my sincere welcome to the councils and the past presidents of both College of Ophthalmologists and the Association of Veterinary Specialists of Sri Lanka. I take this opportunity to welcome the Director and Deputy Director of National Eye Hospital. We are truly honored by your presence, sir. And I wish to extend my warmest greetings and heartfelt welcome to all the delegates from SAOPOSA and Women in Ophthalmology, Young Ophthalmology Forum, as well as all the partner associations, delegates from all the partner associations. Along with all the consultants, postgraduate trainees, medical officers, and allied professionals. We cannot forget our wonderful sponsors without whom this event would not be possible. Alongside the trade exhibitors, so I welcome each and every one of you to this event. I look forward to rewarding and informative session with all of you. During this conference, I would like to direct your attention to a few hot issues we face during our day-to-day ophthalmic practice. Today, the technology is advancing beyond our understanding in a way even we cannot at times keep up. Also, the expectations and demands of our patients are also at very high levels. The question is whether we can fulfill all their requirements. Indeed, I trust we all do our best, but do we truly perform in the best way? I would like to direct your attention to main concern I deem to be truly important, and that is surgical consumables. In cataract surgeries, a cassette is a huge burden for all of us. And when you think of retinal practice, the number of consumables what we use are enormous. Indeed, I want you all to think again. What exactly do we do to single-use consumables? As the term suggests, they are typically meant for single use and not disposables. But I hope we can all take a moment to accept the truth. Exactly how many times these surgical consumables are reused effectively. This leads me to the question of, are we supposed to do so? Or is it the right thing to do? And is it the best possible practice in our field? Main concern, is it ethical, or do we have a legal cover to do reuse disposable items? Ladies and gentlemen, I would like to direct your concern to this topic during my brief address. I hope to encourage you all to use this sort of platform we have today to bring up a conversation, to get the ball rolling at least within the Southeast regions to discuss this sort of issues and realize solutions or make a sort of uniform consensus among us and hopefully facilitate a safe future to the generations that are to come. And finally, I hope you will excuse me if I was remiss in mentioning individuals by name to welcome you all. But I guarantee that the memories of next few days of this meeting will be everlasting in your hearts. I hope this will be a fruitful and rewarding experience for everyone. Thank you very much.
Thank you, sir. I would now like to call upon Dr. Quresh B. Muscati, President of SAOPOSA, to address the gathering.
Ayo Bhavan. I am extremely happy to be here, and my dear President, Dr. Amila D. Alvis, President of the College of Ophthalmology, Sri Lanka, Dr. Dayavansa, President of the Vitreoretinal Society, Dr. Vatsala, Secretary of the Vitreoretinal Society, Dr. Subhash Dadaya, Secretary of SAOPOSA, and Dr. Malaron, Secretary of the Secretary of the College of Ophthalmology. My greetings to you from SAOPOSA. So this is what SAOPOSA is all about. For those of us who are not aware of this organization, I don't blame you because we are a very low-key organization. The colors used are random, have no hidden connotations, and the maps of the countries are certainly not to scale and not necessarily very accurate. So apologies, this is the countries which comprise the South Asian Academy of Ophthalmology, Paediatic Ophthalmology and Strabismus Association. Not all of them are active. We hope to get all of them on board as soon as possible. So a little history of SAOPOSA. We had this SAO, formerly called the SARC meetings, for decades. It's the South Asian Academy of Ophthalmology. It's been around. We just had a meeting in Bhutan a week or so ago. In 2018, at the SAO meeting in Nepal, a need was felt to have subspecialty societies, as all subspecialties have grown considerably since SAO was founded. Hence, SAOPOSA was born along with the other subspecialty SAO societies. And it was not such a traumatic birth. It was quite a normal delivery. Unlike most of the other subspecialty societies, SAO thrived. Our office bearers, myself, Vice President Dr. Seema Qayyum and Dr. Kazi. Secretary is Dr. Subhash Dadaya. Treasurer is Dr. Srijana Adhikari. Apologies for the spelling mistake. Luckily, she is not here to point it out. Joint Secretary Dr. Niuma Fatimat from Maldives. Chairman Scientific Committee Dr. Sudarshan Khokar, who's here. And Editor Dr. Samira Irfan from Lahore, Pakistan. We've held some meetings so far. 2018 was Nepal, where we were founded, as it were. 2019, we had an excellent meeting in the Maldives. And then COVID came along. We did have an online meeting arranged by our colleagues in Sri Lanka in 21. And we are now meeting in 24 in Sri Lanka. The fun fact is that SAOPOSA is the only ophthalmic society in the world to have derivatives of the word ophthalmology twice in its name. I did a lot of research on the net and found that no other society has ophthalmology written twice. South Asian Academy of Ophthalmology, Paediatic Ophthalmology, and Strabismus Association. So we need to be proud of at least one fact there. So I appeal to all to present to strengthen the hands of SAOPOSA by attending subsequent meetings in large numbers. We hope to have the next meeting in Mumbai, where I hail from. Volunteering to contribute to the journal. The journal has had a great start after Nepal and then died a slow, whimpering death, but it can always be revived if we get interest from others. Please offer to host subsequent meetings in different venues. We can offer observerships for youngsters if you have a teaching program. And I would welcome everyone in this audience. You're all members of Sahoposa just because you belong to one of the 7 countries which I depicted, to keep Sahoposa relevant by suggesting new ideas to us. Thank you so much for your attention and welcome you all to this lovely island meeting. Thank you.
Thank you, sir. Up next is the awarding of honorary fellowship. The fellowship is conferred to distinguished persons in the field of ophthalmology and in other disciplines in recognition of their exceptional service to the specialty of ophthalmology. This year, the honorary fellowship will be conferred on Dr. Nalin Rajakaruna.
I would like to invite Dr. Jayan De Silva, Consultant Eye Surgeon at Vijay Kumaratunga Memorial Hospital, Seeduwa, to read the citation of Dr. Nalin Rajakaruna. Dr. Jayan De Silva is the first trainee of Dr. Nalin Rajakaruna.
Thank you, sir. It is with profound pride and immense honor that I present Dr. Nalin Rajakaruna for the conferment of the honorary fellowship of the College of Ophthalmologists of Sri Lanka. A compassionate healer and a tireless educator, Dr. Rajakaruna has consistently exemplified the highest standards of medical practice throughout his illustrious career. Dr. Rajakaruna was born as the younger son to the late Dr. M.S. Rajakaruna, a consultant psychiatrist, and Mrs. Chandra Rajakaruna. He received his primary and secondary education at Ananda College, Colombo, where he excelled academically. He graduated from the Faculty of Medicine at the University of Colombo in 1990 with second-class honors and distinction in obstetrics and gynecology. Dr. Rajakaruna completed his internship in medicine and surgery at National Hospital, Colombo. It was during his undergraduate clinical rotation in ophthalmology that he developed a passion for ophthalmology and became an eye surgeon. Thereafter, he joined the National Eye Hospital, Colombo under the in-service program where his aspirations to become an eye surgeon was solidified. While at the Eye Hospital, Colombo, Dr. Rajakaruna completed the diploma in ophthalmology in 1998 and passed the MS Ophthalmology examination in 1999. He then pursued overseas training at the Queen Elizabeth Hospital, King's Lynn, Norfolk, UK. Thereafter, he got the opportunity to serve at H.M. Stanley Hospital, St. Asaph, North Wales. Whilst in the United Kingdom, he obtained the fellowship of the Royal College of Surgeons, Edinburgh. Upon returning to Sri Lanka in 2003, Dr. Rajakaruna was appointed as the acting eye surgeon to General Hospital, Chilao. Following his board certification, he was appointed as the consultant ophthalmologist to the base hospital, Avisavela. As the first board-certified consultant eye surgeon at Avisavela, he played a pivotal role in elevating ophthalmic care. He tirelessly worked to enhance the infrastructure of the eye unit at this hospital. After completing 4 years of dedicated service at Avisavela, he served as the consultant ophthalmologist at Maravilla, Watupitiwala, and Horana base hospitals. His commitment to improving the facilities at each of these eye units left a lasting impact, benefiting not only these hospitals, but his successors as well. During his tenure at these outstation hospitals, he organized mass screening camps for eye diseases, outreach cataract surgery camps, and public awareness programs on eye health. Dr. Rajakaruna considers himself very fortunate to have been able to serve the underprivileged populations in these regions. His exceptional service in restoring sight to the needy is deeply appreciated and remembered by those who benefited from his care. In 2015, he was appointed as the consultant ophthalmologist to North Colombo Teaching Hospital, where to date, he continues to teach and train both undergraduate and postgraduate students. A passionate educator, Dr. Rajakaruna is currently dedicated to training undergraduates from the Raghav Medical Faculty. He also plays a critical role in postgraduate education, overseeing the training of postgraduate registrars, senior registrars in ophthalmology, as well as registrars in emergency medicine and sports medicine, candidates for the diploma in family medicine. His dedication as a teacher and trainer, coupled with his exemplary leadership, has made him an inspiration and role model for his trainees over the years. His exceptional contribution to medical education has been recognized through his membership in the Board of Study in Ophthalmology. Furthermore, as an examiner for the MD Ophthalmology examination and the Postgraduate Institute of Medicine, he has helped to shape the next generation of ophthalmologists. He has also served as a chief examiner at several examinations and is a member of the MCQ core groups for all modules for past 10 years. Dr. Rajakaruna's involvement with the College of Ophthalmologists dates back to 2003. Since then, he has been actively engaged in many activities of the college, serving various capacities, including council member, secretary, president, and an advisor to the council. In 2018, he served as the 27th president of the College of Ophthalmologists in Sri Lanka. He was instrumental in starting a website for college and served as the representative of the college for the CPD program of the Sri Lanka Medical Council, demonstrating his forward-thinking approach to modernizing healthcare education and practice. He represented the college in various committees of the Ministry of Health, including Drug Evaluation Subcommittee and Technical Evaluation Committee. He also represented the college at the International Council of Ophthalmology and the South Asian Academy of Ophthalmology. As a member of WHO Regional Committee for Disability and Rehabilitation, he worked to improve the accessibility to assistive and technology for persons with disabilities in Sri Lanka. In addition to his professional contributions, Dr. Rajakaruna has presented several papers at the annual Congress of the College of Ophthalmologists and has published in journals of the college. Dr. Rajakaruna's contribution extends beyond the walls of the hospital. He has been actively involved in many health camps organized by the Ananda College, his alma mater, thus giving back to the institution that nurtured his early talents. Further, as a devoted Buddhist, he is involved in various Buddhist activities, including health camps organized at temples. Mr. President, in recognition of the contribution to the field of ophthalmology, medical education, and community service, it is with great pride and deep admiration that I present Dr. Nalin Rajakaruna today for the conferment of the honorary fellowship of the College of Ophthalmologists of Sri Lanka.
I would like to invite Dr. Amla Alves to award the honorary fellowship.
This is to certify Dr. Nalin Rajakaruna has this day been admitted to be a fellow of the College of Ophthalmologists of Sri Lanka in recognition of the achievements and benefactions of the said personage. Hence, his accomplished personage shall enjoy all the privileges and honors attending this rank. This certificate with the seal of the college and the signatures of its president and secretaries affixed here to by the authority of the council is presented as testimony to this matter on the 12th of September 2024.
Congratulations, sir, and thank you for your service.
We now move on to the presentation of awards and certificates to the best performers at the postgraduate examinations in ophthalmology.
The College of Ophthalmologists of Sri Lanka wishes to encourage the performance of the ophthalmology trainees at the postgraduate examinations by awarding certificates to the best performers at the selection examination, ophthalmic basic sciences examination, and the final examination in MD Ophthalmology.
I would like to invite Dr. Quresh P. Muscati to present the Professor Benita Stephen Gold Medal for the best performance at the Ophthalmic Basic Sciences Examination 2024.
This best performance and the gold medal and certificate is won by Dr. G.A. Dilini Aravindika, Registrar in Ophthalmology for the year of 2024. Thank you, sir.
May I invite Dr. Amiladi Alvis, President of the College, to present the certificate for the best performance at the MD Ophthalmology Final Examination 2023.
The best performer at the final examination in MD Ophthalmology 2023 is Dr. Praveen Dayasena, Senior Registrar in Ophthalmology.
Thank you, sir. Now, ladies and gentlemen, we move on to the main part of the inauguration ceremony, which is the presidential address. I would like to invite Dr. Amilati Alvis, President of the College of Ophthalmologists of Sri Lanka, to do the honors.
So, at a time in our country where about 40 candidates are vying and speaking, delivering addresses to the audiences island-wide in trying to become the next president on the 21st, it gives me great honor and I feel a sense of pride to stand here as I was elected unopposed a few months ago, and I'm enjoying it as much as I could without all the extras that go with applying and contesting a presidential election. Good morning, and thank you for being here. And it's good to see that you're all very relaxed and not too tense. Now, at the same time, when deciding about what I need to speak about the presidential address, firstly, you've got to realize that I had a self-imposed limit of 15 minutes. So in this time, I was thinking, what can I actually say that might last in your minds for a few years to come? What can I say that will help ophthalmology and maybe even the rest of your life? And looking at all these conditions, I had really no doubt, and I was limited by time as well, but I was very lucky to choose the topic of mindful ophthalmology as what I'm going to address today. And in addition to that, there might be a few tips of you becoming a superhero on the way as well. Now, about 10 years ago, on a busy clinic day that I was already running late, I had so many things going on in my mind that I was trying to juggle at the same time mentally. I had backed up clinics, I had another list to do. I had also to pick up my children on time from school. Anything could get late, but not that. And in walked 81-year-old lady, helped by her daughter because she couldn't see anything. She was obviously there against her will because she didn't want to be there. And then the examination took place. She had bilateral cataracts. And I was in a bit of a hurry as well. And she was also in a hurry to leave before I did anything to her. So overall, the consultation was a bit of a struggle for the both of us. I fixed her for a surgery, and the surgery was even more a struggle. She didn't understand the concept of what she will and will not feel during topical anesthesia, because I didn't take the time to properly explain that. As we started, she perceived pressure as pain. She started struggling, and as that went on, it got even more difficult. The more she moved, the more she struggled, the more she squeezed her eyes. I asked her not to do it, as if she was doing this on purpose just to challenge me on that day. Luckily for her and also for me, the surgery went off well. We got the implant in, and I saw her routinely post-op. The lady who walked in with holding things because she couldn't see hand movements in both eyes, because of her myotic pupils she was reading and even watching TV without her glasses. And then when I asked her about this, what she said was, there's a small irritation in the corner of my eye. And we've all experienced this. And that naturally, with all the struggle that I went through, irritated me a little bit as well. Acute stress keeps us alive. Our caveman ancestors used stress to run away from wild animals. We sometimes use stress, the acute stress, to run away from angry colleagues and friends, family members. Even if we go for a run or we walk, That's a stress, acute stress that we're intentionally exposing our bodies to. But the problem is that chronic stress is killing us all slowly. Our busy days are packed back to back. Just like a computer with many tabs open, we've got so many things that we're mentally juggling at any one time. And we are either thinking about the negative experiences of the past, and we are projecting this into the future and worrying and being anxious about the future, and we are rarely in the present moment. Studies say, on average, it's about 5% that we spend consciously during the day. So with this, what happens is that decision-making is tired, it's flawed, it's based on worst-case scenario, and like I said, is made in an unconscious way. And when this unconscious decision-making takes us, where it takes us is, it's a herd mentality. We just do what is routinely to be done, we go with the flow, and our life goes by. And overall, this is known to definitely lower our levels of happiness and contentment. Us ophthalmologists and those in the field of eye care, we are no exception. A study from 2022 tells us that over a third of about 600 ophthalmologists in the US had some symptoms of burnout, such as irritability, physical tension, loss of energy, and concentration. Now, we've all had this experience, but often it's misinterpreted as just being tired and hungry. And also in Sri Lanka, with the challenges we've faced over the last few years, with human resources and other resources being limited at some times, are these numbers higher in our population? Now, I'd like to take you through a small exercise where I'd like you all to close your eyes, everyone. We close our eyes and we imagine ourselves in the middle of a frozen lake. We're standing there, we're taking a step at a time. It's cold, there's wind. We're taking a step at a time, trying to find our way to solid ground. We take every step very mindfully. We take it one at a time, aware of the sounds and the feelings that we're exposed to. We're never at that moment, because we're so worried about what will happen next, we're never in the future or the past, we are just there. You can open your eyes, and this, I found in the past, is a very, very powerful metaphor for mindfulness, where you're there in the moment, and it requires a lot of patience, presence, and awareness with every step. And just like walking on ice, and just like mindfulness, our life also needs to be gently and deliberately taken forward, mindful of each step. And remember, also accepting uncertainty in the next step is something we've got to accept. But we find stability in the present moment, and that gives us the best chance not only to survive, but to thrive, right? So our superpower number one that all humans we have, or we have the ability to develop, and is innate, it's inside of us, is the ability to be mindful. Now, this is a buzzword, and I'm sure you've heard of this over and over again. It's applicable to everything from government to relationships, to education, to business, to sports, to performance. It's related to everything, and you've heard of this. Unfortunately, it's something that was actually invented and conceived in this part of the world. We had to wait for the West to let us know that it's something useful to actually take it seriously now. So what it is basically paying purposeful attention in the present moment without judgment. Or simply put, just being here just as they are, right? And when you do that, in the present moment, things are generally good. Every one of us who are sitting here and listening to me speak, in this present moment, your life is excellent. You've got all the basic luxuries to keep you more than happy. You've got food, you've got good health. But the problem is, if our mind wanders into the past and the future, that's where you even spoil this good moment right now. If you have a good present moment, and the next moment, and the next moment, these moments, they form like a string of pearls, and that's where your life takes off in a different direction. When you have more mindfulness, remember there's increased awareness of your own emotions, your thoughts, and your actions as to why we're doing this. Is this appropriate or not? When you are mindful, you create this pause between someone else's action and your reaction. For example, if someone cuts you off in traffic, our natural unconscious tendency is to go behind them, maybe cut them off, show them a few gestures, say a few choice words. But if you're mindful and you think, maybe this person's rushing to see his wife about to deliver their first child, you give them way. And when you think of it even more mindfully, we've cut other people off as well ourselves. So this pause is very important for you to react more appropriately. Now, what are the benefits of mindfulness to the ophthalmologist? Like I said earlier, it really helps manage chronic stress and keeps you healthy to continue performing the amazing work you do in making people see. It improves learning, it improves training abilities, and thereby obviously improves patient outcomes. We talk about work-life balance, but I like to add to that the word isolation, right? As we're going to speak, we want to isolate our problems that we have at work and not take them home and vice versa. And also mindfulness as surgeons, as physicians, will give us clarity of not only our daily goals, but our goals on the long term as well. Now, what about initiating mindfulness? When I speak about this to lots of my friends, I mean, they're like, no, we don't have time to go into an isolated forest and sit in a cave for a few days and, meditate nonstop. But that's taking it to an extreme. So initiating mindfulness could happen as simply as, if I ask you right now with me, we take a breath, inhale for 8 seconds. Could you do that with me? Inhale for 8 seconds while counting. Inhale, 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 inhale. You hold that breath for about 6 seconds. And you exhale this breath for about 10 seconds. You are very slowly exhaling for longer than you inhale, and you're emptying your lungs. This little few seconds of what I told you to do is a simple step in mindfulness. You could employ this between clinics, between patients, between surgeries, just to calm down when you think that things are getting a bit overwhelming. And this works simply, medically we know, by engaging the vagus nerve, and that stimulates the parasympathetic nervous system, which helps you calm down and relax. You can also employ mindfulness while doing your daily activities, like brushing your teeth. Commonly, when we are brushing our teeth, our mind is never right there. When we're brushing our teeth, we're thinking about what we're going to get ready, how we're going to get dressed. When you're getting dressed, we're thinking what we're going to eat, and this goes on. Your mind's always somewhere else as compared to what you're doing. But if you brush your teeth with mindfulness, the toothpaste being put on your brush, you're brushing up, down, left, right, you're washing your mouth, you're spitting the water out, and that task is complete. If you do that mindfully, that's all you need. You need to set aside hours to be mindful. Labeling your emotions is a very easy way, right? You can label your emotions even now. Could be the emotions when you're listening to me speak of being interested. It could be your emotions of being bored. It could be your emotions of waiting for tea, like I know some of you are waiting. Just label your emotions. And then when you've got that as a habit, it becomes much easier, because when you see yourself or you feel yourself getting angry with someone and you label it as being angry, it's very difficult for you to continue spiraling down that path. You change directions. And like I mentioned earlier, role silos. Now, we've got some amazing people in the audience here, and we're here, I suppose, predominantly as eye surgeons and optometrists and industry providers today. But you've got other roles in your life. Your parents, your wives and husbands, your children, your students, your teachers. But the problem is that when too many of the roles, like I said, having all those tabs open, when you have too many of the roles clogging you at the same time, it's a bit difficult to function well. When you're driving from home to work, you're not an ophthalmologist, you're not a mother, a father, a student, or a teacher, you're a driver. You've got to keep that role separate from when you reach work. When you reach work, you're no longer a family member, but an ophthalmologist, right? Now, if you use these simple techniques and make these habits, and you use the power of habit to embed these routines daily into your daily routine, that's where mindfulness initiates. And then who knows, if you see the benefits of doing this, right, maybe even a small meditation practice might be the next result. Now, coming back to my friend, my 81-year-old friend who wasn't very happy with me for her first eye, she decided to wait another whole 4 or 5 years to get her second eye done because she was doing so well with her first eye. But this time around, I mean, she's grown 5 years, 6 years older. The cataract's grown 5, 6 years more mature. And I've grown slightly more mindful as well. My clinics were better timed. I had better space between patients. There was a room in my day and during my timetable for possible delays. The consultation was slightly more mindful. I had clear thoughts. I had good eye contact. My body language and tone was supposedly a bit better, and I got used to active listening. You are really listening to someone, not waiting for them to finish so that you can speak. And getting her to do the second eye was a bit of a difficult conversation because she could do well with one. But in these difficult conversations, remember, mindfulness helps you be more calm, more empathetic, and it helps you pause, invite questions and slow down, and makes even the most difficult conversations slightly better. The surgery was better as well. It was less of a struggle, right? Because when you're mindful, what happened in the previous surgery or your previous list is not bothering you right now. You're here in front of this one patient, you're going to operate, and even within that surgery, each step, when you do it mindfully, everyone who's a high-volume surgeon will know you're less tired, and you're just getting that step done, you're getting to the next step. And most importantly, when you're actually mindful, you're thinking about the patient's perspective. For us, this is a patient who we're operating to get to the next patient and then get home. For this patient, who doesn't understand exactly as to what's going on, it's a terrifying experience. They're awake, they hear everything, and it's their eye that you're operating on. And also, when this lady, when she came for her post-op care, as expected, and I asked her, how are things? The vision's improved nicely. As expected, her first thing was, even this eye now, I'm having a little bit of an irritation. But this time around, without being irritated, I said, and I thought to myself, I mean, if she doesn't tell her eye surgeon about her irritation in the eye, who is she to tell this to? I accepted her complaints and the fact that her vision was good equally, and we moved on. Now with this mindful approach that's initiated and getting even stronger, there's a story, one more story that I'd like to narrate before I end. I remember a few years ago I was driving to work. I got a call from home and telling me that Shanu, my wife, was having difficulty in breathing and it was progressively getting worse. And she was finding it extremely difficult to breathe. So I turned around and I got home as soon as I could. And when I got there, the ambulance was there waiting for her. I put her in the ambulance and she was really struggling. And at that time, those are the times where your entire life, your values, all what you have, the fact that, you're thinking all these material possessions, what does that really matter if something bad further was to happen? You're thinking all of this. Maybe mindfulness makes it a bit difficult also in those situations, but that's what went through my mind on that ambulance drive from home in Kotte to Sri Jayawardhanapura Hospital, the emergency unit. Once we got there, I still remember the consultant. He was calm, he was very professional, and he was extremely empathetic. He realized I didn't even have time to tell him who I was or what I do, but he just treated first Shanu. She was having a very, very bad episode of asthma, so got her under control, and then came and spoke to me as well. And I was thinking to myself, this sort of thing, I mean, who in this country with a population of 22 million people, just a handful of people who can actually do this. It's such a special power that that consultant had over me and my wife, right? Coincidentally, on the same week, a few days later, to my clinic, I had separately walking in, possibly one of the top 5 wealthiest people in the country, and also the following day, for some reason, so as to teach me a lesson, I had one of the most powerful political figures walking in. The first one had a foreign body in their cornea. The second one had an epithelial defect, and they were in extreme levels of pain. At that time, I was realizing all their money and all the power that they had really couldn't help them. simple procedure and a simple explanation from my part is what actually got them through that episode, right? So with this, I realized that we've got a second superpower. And this is even more unique than the mindfulness that was applicable to all humans that they could do. But the eye care providers in this room and elsewhere, we have this really, really special superpower, and that's something that only we can do. Be empathetic, truly feeling what the patient feels, their desperation and their anxiety. How many times have we had patients coming in with a subconjunctival hemorrhage? The entirely families come with them, because they're so worried. And in our mind, this is just a simple thing that will pass over without any treatment in a few weeks' time, right? So generally, what I feel is a good approach would be, let a kind, mindful practice that heals eyes be your only and only goal. And then, for sure, if that is the case, and there's no other goal in mind, stature and money are just byproducts that will surely follow. There was a time where, money was an important thing to me, and it's still now, just to make sure that the basic things are on the table. But I realized, having a conversation with one of my friends who is a big person in business, he just roughly asked me how much I make every year, and he was surprised, and I was surprised as well. He just mentioned, after all this work that you put in to become a consultant eye surgeon, I made that in one business deal last week. So that's something that I just keep in mind as well. So basically, using mindful techniques to develop handling of patients at every stage of care, initially, during, and after. And not only the patients, but the bystanders as well. That makes a huge difference, will make a big difference to your practice, hopefully. And not only to that, like I said, once you're more mindful at work, your work-life balance is better, and your family and your friends will appreciate that as well. Because after all, even superheroes need a regular eye check to make sure that their vision is good so they can keep helping us, help other people who are in trouble. Thank you very much for your mindful attention. I've also got the great honor of delivering the vote of thanks to everyone. I'll start with Dr. Dayavansa. Thank you very much for agreeing and helping me get the inauguration down to an hour and have it on the morning of the first day. And thank you very much to my council who are gracious enough to accept this slight change in tradition. Thank you to all our partners. We've got them all listed there for the next 4 days. Like Dr. Dayavansa, thank you very much to Dr. Quresh Muscati and his team, Dr. Dadea and Dr. Coker, who are here, who've been extremely helpful in getting this program together. And we'll be also hearing from the Asia Pacific, a pediatric group in the afternoon. So thank you to them and all other partners. Thank you very much to all the speakers. I think we've got a record number of speakers this time. It's close to maybe 90 speakers over the next 4 days. And I think, thank you very much. A special thank you to the foreign speakers. We've got 63 foreign speakers addressing us, and out of that, 50 are going to be here physically over the next 4 days. Thank you also to the local speakers. I know that sometimes it takes longer to get to Colombo from certain parts of Sri Lanka than it does to fly over from India. Thank you for your contributions. And the delegates. The speakers and the delegates, that's the core of an academic event. And this time, I think, again, I've been told that possibly a record number of delegates. We've got close to 300 delegates signed up for each day of these, of the 4 days for the meeting. Thank you very much to Dilisha and Upeka and the event management team, and who also did the event management, plus also the AV, the stalls, and we kept and will keep bothering them throughout the next 4 days. Thank you very much to Mayo, who is going to capture all your sleeping pictures over the next few days in the afternoon after lunch. We've got a good lunch ready. It's not too minimalistic as well. Thank you to the Cinnamon Grand team, who's been very flexible. Thank you very much to the college office staff, who I've seen firsthand. Everyone goes on about how this is a lot of work, and being the president, I've spent a bit of time, not enough, but spent a bit of time in the college office this year, and I realized to put an event like this together, it's unbelievable amount of physical work, organization, and attention to detail. So thank you very much to Samanmali, Kumari, we got Nipun, and also Mel. Thank you very much for making this possible. And we all know, without our sponsors, we've got sponsors here displayed for the Paediatric Ophthalmology Day. Then we've got our platinum and our gold sponsors for the Colombo Retinal Meeting. Got a few other sponsors also helped. And no matter how much you contributed, I know you contributed as much as you could. Every single rupee is valuable and means a lot that you took the effort to be part of the program. And also, in addition to this financial input that you give us at this time of year, we've also got to thank you and acknowledge you for the amazing work that you do to enable us to deliver the eye care that we do. Without that, it's not only the finances, but everything else, the support that you give us. And then we've got our sponsors, the platinum sponsors for the Congress, the Gold Plus sponsor, the gold sponsors for our Congress, our silver sponsor, and our bronze sponsors as well, and a few other sponsors who have again tried their best in whatever way they could to help the meeting proceed. Thank you very much for your attention, and I hope you have a great meeting where there's lots of things to be learned, lots of people to meet, and at the end of it, we'll kick off our college dinner in celebration of the 4 days of hard work and knowledge you've gained. Thank you very much.
Ladies and gentlemen, this concludes the ceremonial inauguration for the year of 2024. Please rise while the ceremonial procession leaves the hall. You may now enjoy the refreshments.
The other session is on pediatric cataract. I invite Professor S.K. Khokhar sir, who is the chairperson of this session, and Dr. Sweta.
Thank you, Subhash. We just got 30 seconds before we start the session. So all these guys here, I can just want to see the raise of hands. I'm sure you're doing the pediatric ophthalmology. How many are actually doing pediatric cataracts? Can I just see the, oh wow, lovely. Are there some people outside? They can't raise their hands because they're holding the plates in one hand and the cup in the other hand. If they raise the right hand with the cup, it will spill over, and the left hand, the samosa will fall down. I'll request, Amira, can you ask all the guys to come in? If they're interested, yeah. Okay. Okay, so pediatric cataract is another. See, strabismus, when the patient has a squint, parents can see. More than the parents, the relatives can see, and the neighbors can see, and they pinpoint, your son has a squint. I mean, even the parents can't see, because parents can't see anything wrong in their kids. Whereas if it's a cataract, and until unless it's a white cataract, which is in the anterior part, not even the ophthalmologist can pick it up if they're not using a distant direct ophthalmology. That's why the concept of Bruckner's reflex came, that when the kid is there, always dilate both eyes and just run a ophthalmoscope. 99.9% you pick up the problem if there are any. But I don't know how many people are actually doing. So this will come a little later, but if we pick it up earlier, it could be presenting as a deviation, or most commonly we see when the kids start going to the school. At that time, the parents realize suddenly he can't see the blackboard. It's not a refractive error, there could be a cataract also. So if it's a zonular right in the middle or posterior subcapsular, it will not be picked up early. So if this kid goes blind and you don't operate in appropriate time, he'll be in amblyopia, and then whatever you try, red light, blue light, Chinese light, or whatever, it's not going to work to the same extent. All these amblyopic eyes, if they have nystagmus and all, vision seldom improves better than 6/18. So why do you want to go there? Why can't we pick it up early and operate? So now I think time is good. So if there's a pediatric cataract, I'm asking about Dr. Bharti to come and take a talk, to tell us what are the basic fundamentals in these cases, how to pick it up, when to operate, and then we'll talk how to operate, and gradually I think we'll go throughout. And then later on we have Aditya, who will be talking about the EDOF lenses, how they're going to work in the children, his study. Then, of course, we can't have a talk session without Muscati, so he has a myopia control again. Let's hope he talks not about the red light this time. And, of course, the glasses has to be given to all these kids before and after the cataract. Even if you put an IOL, you still might have to give glasses. So Dr. Bharti, yours, please.
Thank you, Professor Coker, chairman of this session, and Sao Posa, along with Professor Dadia, to have given me this opportunity to share my talk and to invite me here for this session. I'll be talking on pediatric cataract, fundamentals of surgical treatment, and the prevalence of childhood cataract has been reported as 1 to 15 in different studies out of 10,000 children in the developing countries, and they could be congenital, developmental, or traumatic. Now, there is a difference because whenever we see a child, we do not kind of make a diagnosis of congenital or developmental, we just say childhood cataract. So there are little differences in the congenital cataract, which is present at birth, and developmental cataract, which starts developing after birth. And the congenital cataract is smaller than 5.75, and the fixation of the light is absent because it's there since birth. And most of the time you see nystagmus in these children, and they are visually significant, progressive, sometimes bilateral or complete. Whereas developmental cataract situated outside the fetal nucleus, so it is larger than 5.75. Majority of times the light reflex is present. Nystagmus may or may not be present. Squint may or may not be present. And usually it is partial, and stationary does not develop, does not increase. Etiology is genetic or metabolic, infective like torch organisms, rubella, and then chromosomal like trisomy 21, 18, or 13, and the skeletal, and idiopathic in 50% of the cases. And here are the pictures of different types of cataract, which are defined here from most commonly seen cortical and nuclear, but and also punctate, the blue dot cataract, which is most commonly seen even in adults also, because it does not hamper the vision at all. History is very important. Most of the time parents bring the child with the detailed, and from there you get the detailed history. There is history of diminution of vision and does not recognize objects and parents, and white spot in the pupillary area, unsteady eye, deviation, and other such symptoms. And we have to quantify the visual acuity of the child with cataract as precisely as possible. And grade of visual fixation is also important, and photographs. If you can go ahead and take photographs of these cataracts, then you will be able to understand whether they are growing or not. And also you need to screen parents and siblings to rule out the familial causes. Ocular examination includes EUA, retinoscopy, and as Professor Coker said, distant direct ophthalmoscopy. The pupillary reaction, the intraocular pressure. Here you see this handheld slit lamp for pediatric examination. This is to evaluate the size, density, and location of cataract to plan the surgical procedure and prognosis. Squint evaluation, fundus examination should be carried out after pupillary dilation. And A scan and B scan have to be done for axial length, for IOL calculation, and posterior segment pathology, as quite a number of pediatric cataracts are dense and preclude view of the fundus, and the diagnosis is not complete and accurate without a B scan in such cases. Pediatric evaluation, the child should be assessed by a pediatrician to rule out systemic associations, anomalies, and congenital rubella, and the titers for toxoplasma, rubella, cytomega, CMV, herpes, The torch profile should be carried out in all these cases. Every white reflex is not cataract. So most common other cause is the retinoblastoma and PHPV, which are very, very common and give a very white reflex, but the prognosis and management is entirely different. In early childhood, you can find Coats disease, toxocariasis, and hematomas also. And that is why B scan is of utmost importance in condition, as performing cataract surgery in such condition can be disastrous and also can be, because you have not done the diagnosis properly, can lead to medical legal problems. Laboratory workup is blood test for, including blood glucose, calcium, phosphorus, RBC transferase and galactokinase levels. And torch, of course, is very important, hepatitis B virus. Urine for galactosemia and for Loeys syndrome, amino acids. And mostly pediatric cases with the unilateral cataract are mostly idiopathic. IOL power calculation is a very important aspect of IOL surgery. And it also depends at what kind of IOL you are putting. It depends on the age at surgery. And also you have to check the axial length and keratometry, elongation, myopic shift, visual deprivation and amblyopia in all these cases. And primary IOL implantation is to be standard of care in patients over 2 years of age, definitely. Increasing trends of implanting IOLs in children less than 2 years of age, and for a child of 6 months or lesser, it is controversial to whether to implant the IOL, which many people are doing now, or we have to wait till the age of 2 before we go ahead and implant the IOL. The contraindication for IOL is corneal diameter less than 9 millimeter, extremely myophthalmic eyes, and poorly formed anterior segment structure. And these congenital anomalies, we must be, very, very careful in implanting the IOLs. Mostly they are, I would say, contraindication. Gordon and Donzi's cross-sectional biometric study of 148 normal eyes found that length increased from 16.8 to 23.6, but refraction changed from 0.4 to minus 0.5. That is because crystalline lens power declined. And that is why there is no proportionately changing lens to compensate for ocular growth. Aphakic eyes have a large myopic shift. So, implantation of an IOL can address this issue, although the initial hypermetropic overcorrection needed may necessitate contact lens or a spectacle use. And anisometropia should be reduced, try to be reduced for embryogenic stimulus it is. And no formula is 100% accurate. Holiday 1, Haggis and SRT give almost similar results. Keratometry, handheld keratometer is the best. And applanation. And
I request Dr. Bharti to conclude.
One slide I want to show here, and this is the Inedi et al., the recommended postoperative refractive goal. This is the rule of 7, and this is very important to be kept in mind. Thank you very much.
I would now invite Dr. S.K. Khokar to present his talk on capsular management in pediatric cataract cases, different strokes for different folks. As we all know, Dr. Sudarshan Khokar is professor in charge of lens clinic services in RP Center, AIMS, New Delhi.
Right, thank you. So I was thinking that he'll talk about the basics of cataract. So basically these are bimanual surgeries, so you need 3 incision and all. So the toughest thing which people found in this surgery is the capsule management. Because these capsules are not same as the adult capsules. So basically what is the concept of the surgery is that you want to make the media clear. If the lens is there, if blocking the light, you just take the lens out of the picture. Even if you don't put an implant, if you have glasses, you're still helping the child out. And whenever you do that, please do not eat the entire posterior capsule. Leave a little rim in the periphery, which over the time will become a little harder, and you can put a secondary implant. And this entire procedure should be least traumatic and having minimal collateral damage and minimum complications. So this is what it is. It's not like adult guys, He walks in, he sits in the biometer, you pick up IL power, calculate, hit it, targets, bullseye, always. Like Amila had this lady coming in, he could do it. Whereas the other one is still growing. It's a dynamic. It's like a shooting, like a flying bird you want to shoot. So it's going to be a little different. Okay. So capsule is what is the problem, and we're going to stick to capsule. I think you need a 5 millimeter capsule, so I'll just come to the basics. So this is a slide which I show in all my American Academy courses because this is a basic concept. You have an anterior capsule which is bulging anteriorly and posterior capsule which is bulging posteriorly. So your aim here is to keep the incision small and push the anterior capsule backwards, and you can just go in, come, nick from the side, give a nick, use a Utrata forceps. Because Utrata forceps, I think everybody is used to. Make the incision 2.2. If you have a good viscoelastic, it'll stay in the eye, won't come out. And if you don't have a good viscoelastic, which is heavy, anything more than 4-5 million Dalton, you can go with a methyl cellulose, but make a smaller incision and then smaller opening. And if in the adults you're holding the capsule 5 to 6 times, here you hold from 7 to 8 times, maybe 2-3 times extra, and you'll get away with that all the time, all the time. Okay, so similarly, posterior capsule, once you've done the anterior rhexis, you've done the lens aspiration. Lens aspiration is the easiest bit of the entire surgery. So what you do here is, you put in the viscoelastic in the chamber, not in the bag. Do not inflate the bag because posterior capsule, if you push it further with a heavy viscoelastic, it'll go further away from you. And you will give a nick, it'll open up. It'll run to the periphery. It's inverse of the top of the hill phenomena which you get for the anterior capsule. So yes, go, give a nick from the side and come from superior again, because once you give a nick, it's vertical nick, and you can come from here straight, hold the standing edge. It's just waiting for you to catch. Hold it with the forceps. In this case, I'm using a noodles, long forceps, chopsticks, not the Utrata, and go all around, and it will never run. My anterior capsule still runs away in 1 to 2% of a patient. I've been doing this for the last 40 years. But posterior capsule had ran out only 2-3 times. That was when I overfilled the bags and never when it was underfilled. So you can use your chopstick or the forks to eat your noodles, whichever you're good at, but after practice, you will be good at both. So what happens now, different stroke for different folks, if it's not the same thing? Now this video is going to cover up a few of the anterior capsule plaques. Let's hope my time is enough. So I'm trying to do a rhexis here. I'm trying to put my needle inside cystitome, but it's not going. That means because this entire thing is actually a plaque. And during those days, we didn't have a UBM. Now we do UBM for each eye, and we can pick up these plaques. So if I pick up a plaque, I'll put a MVR entry from here and cut it. But this one, I was lucky to have a plasma blade with me. And I could just go all around, cut with that. I'm just drawing it on the anterior capsule, and it cuts like, well, that is what is technology. But I'm not here to talk about technology. I'm here to teach you the techniques, how to do it, even if you don't have it. So you can actually cut it with the MVR and take a scissor and cut it all around 360 degrees. Okay, so this is what happens after the aspiration, and that's what is my topic. I'll stick to the capsule only. So that's how it looks after the, okay. Now this is another one. Some part is plaque and other part is clear the anterior capsule. So you can try using that, pulling it inwards. So this is where your physics comes in. I think ophthalmology is just physics. Optics is physics, so is the dynamics and the torque and the forces. Whatever we talk about on the cornea, everything is physics, pure physics. So if I'm pulling it, I can tuck it. Always pull it inwards. If you're pulling outward, it will run out. Okay, now this is the third scenario in which even if I pull inwards, my upper capsule part will go out. I don't want it to be more than 6 millimeter at any cost. So once I've done that, some part I do a rhexis and other part I give a nick with the scissor. So your scissor, intravitreal scissor has to be there, and if you're not very good at cutting, you can always make an opening inferior also, and this is how it looks like, and the lens can easily go into the bag in these patients. Now this is a fibrotic plaque, anterior posterior capsule all stuck up, so you can't do much in this one, so you have to just make a, now this is what you can try, which I was telling earlier, make a nick with the MVR and cut it all around with the scissor using whichever direction you are. So if you're stuck, you can make one opening and go. You've got 3 incisions, you can cover 360 very easily in this one. And if you're not from India or Sri Lanka, you're not a great surgeon, you can always put in an implant and go and cut it from the back. I do not suggest that, but people do that. Okay, this machine came into vogue. This was a femto. But the problem is that for anterior capsule and posterior capsule, you have to use 2 PIs. That means double the cost. And most of the patients in which you're doing femto are adults, and they don't have a GF facility in that one. And most of the machines, femtos, are not mobile. You can't shift it from one to another OT. But now we have one LASIK machine, which is Lanka, which can be shifted to the GA side. So I have some videos of that also. So you can do anterior capsule, aspirate, and then you can again dock in with a new one and go for the posterior. It will work. It's expensive. I think that's not the way to go. Okay. Now then came Zepto with David Chang, and this was Zepto is an instrument in which you will go inside onto the cornea, suck onto the cornea, and then you can cut it off. Right. So it's a technology which can work for the anterior capsule, but never for the posterior capsule, because posterior capsule is concave. You can't have a suction on that. So this may work for the anterior, which you can actually do a rhexis otherwise also. So it's not a way to go again. So we just got a new kid on the block, which is called the Lensar. So this we got about 6 months back, and we got few patients under our belt. So this is one of the surgery I'll show, and I think I will be well in time to finish it. Okay, so that's a cataract I picked up. It's not a very hardish cataract, but it's blocking. It's in the middle. It's blocking when the pupil is small. It's blocking. So this is what you have to stain the anterior capsule with the Trypan blue, which the company provides you. The other Trypan blue will also work, and you saw that with a flash of your eye, and this gets over, and that's how fast it is. I'll go back again to this one, since I have the time. Okay, so I'm just focusing the spots, and that's how. So this is the GA. Even adults, if the patient is not even cooperative, by the time he realizes something going on, the rhexis will be done. And this rhexis is pretty good. You see the measurement, that's a 5 millimeter, and it's covering all around, and you can just pick it up. And then aspiration is the easiest part. It's like a putty cortex which is inside. You can just aspirate with a biomanual, a coaxial, whatever you want. And it's not difficult. So the capsule, and this one, you can do the posterior capsule also after staining. So when you're staining the posterior capsule, since the time is not there, you put in an air bubble and put 2 drops of dye into the bag and leave it there for at least a minute. And go ahead and do it. Nothing will happen. The only thing you have to be careful about is when you focus, you have to focus onto the capsule only. If you focus on the anterior, because anterior the cornea can pick up some dye and it will get burnt, or it can have a little reaction. Within a week, it will settle down. But all these patients which we did, where the focus was good, and we didn't have any edema in any of these patients. So with that, a difficult step of the surgery can be made very easily, because this capsule size is very important to have the lens in the bag and centration. And you can try any lenses, maybe at a multifocal, monofocal, or EDOF, as my next speaker is going to talk about. And with that, I'll close this talk. I'm well in time. Thank you very much.
It was quite an enlightening talk. As we know, pediatric capsules are not equivalent to adult capsule. Any comments or any questions to Dr. Khoka?
No question. It's a good talk, right?
Okay. So I would now like to invite Dr. Aditya Sethi for his talk on long-term outcome of EDOF IOL in young children.
Sorry? Oh, we're doing anterior vitrectomy in all the patients less than 7, 8 years. And if a patient is mentally challenged, even if it comes up at the age of 25, I'll still do a posterior vitrectomy and a posterior capsule rhexis, because I don't want to go into the OT again, because they won't sit on the YAG. It'll damage the lens. So don't be scared of the vitrectomy. Anyway, doing the vitrectomy right in the core and under the capsule all around. So it should be done. If you have a doubt, please do the vitrectomy. But have a good cutter with a high cut rate. Don't have a traction onto the vitreous. That's what is the name of the game.
Dr. Aditya Sethi is consultant ophthalmologist in Arundhya Desert Eye Hospital, Gurgaon.
Thank you so much. Thank you, SAO, POSA, Sri Lanka College of Ophthalmologists, Dr. Dadia and Dr. Maskati for this opportunity. I'm going to be talking about long-term outcomes of implanting extended depth of focus IOLs in adolescent and young children with pediatric cataract. So this is the main question that we've been trying to answer for a really long time, because this is what causes amblyopia in these kids is generally the cataract, and after we do the cataract surgery, it's the implantation of a wrong IOL or post-rehabilitation being absent. So just doing pediatric cataract surgery may not be the answer. The rehabilitation is of equal importance. And does the IOL type actually cause an impact on how your rehabilitation will be? So how do we decide which IOL type is most suitable for a child who's still going? So this was the question which was in my mind. And in the era of EDOF IOLs and advanced monofocals or monofocal enhanced IOLs, it may not, the idea stuck that it may not be right to just go with traditional IOLs. And then we decided to do a retrospective study. So the idea was that traditional IOLs often provide limited to no pseudo-accommodation, which is a concern as the child grows, because his life, which is more of near and intermediate, goes more towards distance, and we're not really treating them for near and intermediate, immediate post-op. So EDOF IOLs offer extended depth of focus and potentially increase ability to focus on viewing distances which are concerned to the child. And advanced monofocals, which have given great results in adults, is optimized for near and intermediate vision. And it also acts by balancing clarity and simplicity. And both types are aimed, but which is long-term better. So this is just a comparative case study. This is a boy who's 13.5 years of age. That means he's a teenager. So we chose EDOF IOL in this particular condition. And we noticed that 1 year post-op, in fact, immediate post-op, he started doing much better. And the activities which were he was doing, most of them required him to be either with a very small, thin glass or maybe not even that. And that's made his binocularity much better and improvement of his day-to-day visual acuity and the rehabilitation much more lenient. We compared that with a 9-year-old with an advanced monofocal who did equally well, but her dependency on the glasses was a little bit more, even though the glass acceptability was much better. And we compared it with a regular spherical IOL, which was in a younger child, and we found it more tasking and more follow-ups were required to ensure that the dependence on the glasses was maintained. So basically this study is bridging gaps, which is not in the current research armamentarium that we all are used to. EDOF IOLs are not being studied in pediatric cataract till now. And this is beyond the immediate results. The idea is to go long-term, trying to figure out that we will be able to make an impact. And there's been the requirement of comparative study has actually been highlighted, and there are implications in clinical practice which come along with this. And this may be one of the first studies which are out there for EDOF IOLs. And the idea about this was only quality of life enhancements. So methodology, single-center retrospective study was done. We compared long-term outcomes of EDOF, enhanced monofocal IOLs, and traditional. We had 15 adolescent eyes implanted with EDOFs greater than 10 years of age, and 11 with enhanced monofocals between 1 to 10, and 14 with the traditional monofocal spherical IOLs that we used. And we selected only those eyes which were comparable, did not have any prior ocular surgery, presence of other ocular conditions affecting visual, and didn't have enough data to compare. So the implants we chose were no financial disclosure here. Vivity Alcon, Lucidus, which is refractive EDOF. In the true EDOFs, which were classified with basic spherical issues, spherical aberrations done. We had the IHANS, the AdTech Comfort, and the EMV, and the monofocal, we had the spherical Alcon lens. So we collected in retrospective way, statistical analysis was done. We had got all the ethical considerations, considering it's retrospective in nature, and we had some challenges as far as data was concerned, but we went in and did it. So the result was the visual acuity improvement was actually noticed to be much faster and much better with the EDOF and the enhanced monofocal IOLs. Of course, these are measured more for distance and intermediate in these conditions, and that's what we showed, that 85% of the patients actually achieved without the need for all the time glasses in EDOF IOLs. Also considering the age, this may be a little biased, but that was the result. And enhanced monofocal IOLs, we saw about 70 to 75% doing better, 20, 40 or better, and this compared to 60% with 20 or 40 or better with the traditional IOLs. We also implied that EDOF IOLs actually give a slightly more higher promising result, and enhanced monofocal IOLs may be replacing the spherical ones as time goes on, as per the statistics. The main concern was amblyopia, and we wanted to compare how the management success was with these lenses. And then we noticed that the traditional IOLs had a great success rate of 70%. The enhanced reached up to about 85% and a rapid improvement. What was surprising with the EDOF IOLs, we actually touched 90% and a rapid improvement in these cases, with inclusive even ocular motility in some certain cases. The spectacle question was something that we wanted to study, and we noticed that the idea was not to make them spectacle independent, but reduce the dependence on these glasses, at least for most of the activities, so that rehabilitation happens with greater success. And that was the case when EDOF IOLs and advanced monofocal IOLs were implanted as compared to traditional IOLs. So in discussion, this is actually filling a small research void. The need for a bigger study, more numbers, and a more impact is still pending, which I would hope that we do in the future. And this is basically a recommendation for your future research, and collaborative efforts have to be done. So conclusion, I've actually left it blank because the study numbers are way lesser than to conclude something very imperative, but of course it opens a Pandora's box, and the question still lies that which is the IOL of choice today. Thank you so much for the time.
Thank you, Aditya. I think we got a minute and a half. So Aditya, one question. You said which was the youngest patient you had here?
So for EDOF, above 10.
10 years. So they're basically not adolescent. We're talking about the grown-up kids, actually, right? Adolescent, not the pediatric, genuine ones. So after 10 years, you can take them as adult only. You can go multifocal. You can go. We can go toric also. We do that. The question is, what about multifocals? This one in younger age group. We at the RP Center routinely are using eye-hands. We use EDOF, which has aspheric module. You have a spherical, you have diffractive, and you have refractive ones. Diffractives will work wonderfully well also because your neuroadaptation happens. But calculating the power in those age group when eye is growing is always an iffy thing. So if you put a EDOF, again, whatever lens you put in these kids, less than 2 years, be prepared that maybe 4 to 5% patients will come back and you might have to take them out. So after said that, I think there's no perfect lens.
We've actually classified them as advanced monofocals, the eye-hands, the EMVs, rather than calling them true EDOFs basically, and kept them between 2 years to 10 years of age. And 10 years above, we use the refractive EDOFs.
Yeah, so that's what I'm saying. So after 10 years, you can consider them as adult and do whatever you want to do, right? Except they can't sign their checkbooks and they can't vote. They're as good as adults. Okay, thank you very much.
Thank you,
right?
Thank you.
And now we have no other than Dr. Muscati. He's going to tell some jokes also. And of course, he'll talk about myopia control, not the red lights this time. So Quresh needs no introduction, and he's a gem. He started ophthalmology with his father, I think, a big way, a long way back. You there?
No, I was just wondering why the eye was missing.
Yeah.
So I came there to check.
Are we good?
Okay.
Okay, all yours.
So this is we thank Messrs. SLR, Stellest, for being a big sponsor for this meeting. And this is, they wanted to come in from India. We saved them some money. They donated that money to the Sri Lanka College of Ophthalmology. So I have no financial interest, but I'm giving this talk with slides loaned to me. Many of the slides have been loaned to me by SLR Stellest. So important thing is if you just remember this one slide from the rest of the lecture, why we are so obsessed with things different from what we used to do. What we always gave what is called single vision spectacles, or SVS, if the patient had -3 myopia and we gave them -3 glasses and the patient saw 6x6, we were thrilled, parents were thrilled, they could see the school blackboard and things like that. And life went on. He came back after 6 months with -3.5 and after another 6 months with -4. And we said, well, his genetics, you know, as the child grows up, he's a growing child, it goes up, with nothing you can do about it, and so on. What has changed is this concept of hyperopic defocus. That when you put spectacles, single vision spectacles in front of the eye, they focus beautifully on the macula over here. So, but the peripheral rays of light, these are biconcave glasses. So the peripheral rays of light are just like they are inverted prism. So they focus behind over here where the red light is. So it's called peripheral hyperopic defocus. So central perfect, but peripheral hyperopic defocus. Now when that happens, the brain interprets this saying that we need to bring the light here. How do we do that? Let's get this sclera to grow. So let the eyeball grow a little bit so that everything comes into myopic defocus. So desirable is this myopic defocus. Everything should focus here. When you don't do it and you give single vision glasses, it goes behind what is called hyperopic defocus in single vision glasses, and that is what causes the progress of myopia. So therefore the optical mode is corrective. If the child is happy, it's corrective, but it's not preventive. In the good old days, about 40, 50 years ago, without realizing it, our senior ophthalmologists used to slightly undercorrect myopes. When you slightly undercorrect a myope, the hyperopic defocus is a little reduced. But then the vision is not so clear at the macula, which again serves as a stimulus for growth. So ideally, you need to correct it with something more than single vision glasses, which can bring all the images inside the retina, or what is called a continuous myopic defocus. Now, there are various means of doing this. So again and again, I'm just repeating that if you get this concept of hyperopic defocus in mind, even in the absence of visual signals from the fovea, you can get myopic progression. So if you kill the fovea, in a monkey and scar that fovea, the monkey will still get myopic, this hyperopic defocus and a progression of the myopia. This has been proved by experiments. So this is where there are many ways to skin a cat, and we've got different contact lenses, you've got different glasses, and a little bit from about the Stellest lenses. They provide correction via a single vision zone, so the central vision is perfect. And there are highly aspheric lenslets all around. These are highly aspheric lenslets. 11 rings are there. And this combination sees to it that all the rays of light come to a focus on or in front of the retina. There are different types of special glasses. Two main technologies is the HAL, H-A-L technology or HALT technology, and the DIMS technology. I'll just share with you some of their data on patients who wore Stellest glasses for 2 years, and they found that the myopia progression, 67% wearing Stellest glasses, more than 12 hours every day, and they slow down the myopia progression by 55% for all at an average, and the axial length itself also is slowed down. So both the SER and the axial length progression slows down. This is a 2-year study, and then they went ahead and they found that can the children adapt? Yes. Within 3 days, 90% of children were adapted. Almost all of them were adapted within a week, and 94% felt comfortable with SL or Stellest lenses. Please understand, this is the company which has done this. 94% of no kids are comfortable because they'll complain of pain at the ear, the spectacle becoming crooked in 5 days, but that apart. So these are some of the publications which they have shared with me. 1 year myopia control efficiency, JAMA and other reputed journals which have shown this. Now, because this did so well for 2 years, they moved it on and they said, can we extend this to a 3rd year? So all those, so they had compared initially those on single vision versus those on the Stellest glasses. And they said it's not fair to those wearing single vision glasses because the result was so great. So they shifted all of them, those who are on single vision lenses, to Stellest after 2 years, and they found that this was still efficacious. When they shifted it from 24 months or 2 years, and they shifted them to Stellest, they found good results even in this compared to those who had earlier wore single vision glasses. So this is now 3-year results. The new control group progressed very little again when they switched to Stellest, and the cumulative myopic progression for those of these 2 years on single vision and 1 year on Stellest was again better than those who were only on single vision. So in effect, when you go to 3 years and average it out, this Stellest slowed myopia progression by 1.06 on average for all the subjects. And axial length. So two criteria we always use, SER and the axial length. And the axial length also slowed significantly, and this was statistically significant. So those with single vision glasses, almost a millimeter increase in axial length over 36 months versus almost half that for those who are on Stellest glasses. So the axial length also reduced almost 50%. So this is the 3-year summary. They remained effective over 3 years. They demonstrated a total accumulated slowdown by 1.06 diopters and axial length slowdown by almost 50%. And so they were effective in both reducing slowing myopic progression and axial elongation. In comparison, those wearing single vision glasses, myopia progressed slowly over 3 years, but didn't stop progressing. Then they went on to, emboldened by this, to a 5-year study. And they found that even in 5 years, it remains effective in slowing down myopia progression, even as late as in the 5th year of its use. And axial length similarly slows down by only 0.7. If you remember the 3-year study, those wearing single vision, almost a diopter, but even at 5 years, this axial length increased by only 0.72. So not that it reverses things, but it slows down the progression. So the 4th and 5th year results summary is very similar to that of the first 3 years as well, and that the slowing down in both the axial length and the SER maintained over the 4th and 5th year as well. And these are some of the publications for the 3 years, 4 years, and 5-year control study. Again, this is in the American Journal, which was a crossover study. So spectacle lenses with highly aspherical lenslets, which is the HAL technology for slowing myopia. And this was a double-blind crossover clinical trial, which showed that the data were not suggestive of rebound in myopia progression when patients were switched from SLR to single vision. So if the patient was wearing it for X number of years and then you switched him to single vision, it's not that the rebound occurred. So I told you there were two technologies, HAL versus the DIMS technology. HAL is the highly aspherical lenslets, while DIMS is the defocused incorporated multiple segment spectacles. So there are several companies making spectacles now. There is SLR, there is Zeiss, there is Hoya, and a couple of other companies also which are making these. But since these slides have come to you from Stellest, it demonstrates obviously that HAL is a little superior as far as myopia progression is half that of the DIMS, and axial length elongation is also much less than with DIMS. So this was studied in Chinese children. So they have carefully said that at least Chinese children wearing HAL had less myopia progression and axial elongation than those wearing DIMS lenses. And this is very recent from the ARVO 2024 meeting itself. There were several posters and papers on the HAL technology, which does show that this all of it does work. I won't go into the details of this. So to conclude, this is what the Stellest glasses look when you take special pictures, but otherwise, when the child is wearing it, you can hardly make out that it's different. I have been using these since the last 1 year or so in my practice. So the technology is called HALT or HAL technology, and these are for those who are interested. This is the material. It's of course all 100% UV protected. It also is available now with sun tints. So those who want can wear tinted Stellest glasses. Thank you very much for your attention.
We have some time left.
Yeah. So we'll give you an extra eclair.
Yeah. Any questions or any comments? Sir, I would like to ask, like these glasses are pretty expensive. So in Indian subcontinent and in countries, developing countries, this will burden the expenditure of the parents. So like in your setup, how often do you change these glasses?
Yeah, so one good thing is that these companies are so sure of their product that they give you a guarantee that it will not progress. And if it progresses by more than 0.5, then they give you a free replacement. Within 6 months, if it increases by 0.5 or more, they give you a free replacement of these glasses. They're not all that expensive if you go for multiple glasses in a kit for 3 to 4 times in 2 years, for example, and if you wear these and don't have to change it for 2 years, it works out almost equal.
It's something like putting IOL in the eye versus giving the glasses, and you keep changing the glasses, or contact lenses for that matter. In pediatric age group, you have contact lenses, the child is going to drop about 3.4 every year, contact lenses, so 3.5. But if you put IOL, you get away. So I think that's right. The cost is...
Sudarshan, the way I look at it is this. Yes, the glasses are a little more expensive than the regular.
Yeah.
But if you can prevent myopia progression, you're later on a person with, I didn't go into all those details, but a person who goes from moderate myopia to high myopia, the chances of retinal detachment, the chances of cataract, glaucoma, increase exponentially, and the cost of this is a huge burden as the child grows up. So if we can prevent it and keep the myopia under control in his growing years, I think your overall financial burden will be much, much less.
Yeah, just a food for thought. This myopia, you're saying, is a mid-peripheral blur, and it causes extension, stops the extension. What about the periphery of the retina? Do you think the periphery is still going weaker and you will have lattices of the whole? Anybody has done a study in which they followed this patient for 5-10 years and they realized that, yes, we don't have the substantial amount of problem in the periphery, which can go to RD detachments and all.
Yeah, see, the most studies which have been done have shown that the higher the myopia, the more the risk of peripheral lattice. And so again, if you can slow down the myopia by corollary, it should have less risk of detachment. Lattice is a different thing, but detachment itself, yes.
Yeah. But the thing is that all these studies, I think we all have to have a swept source OCTs to pick up the thickness of the sclera at different levels and then come back with this one. I think most of the studies don't have it.
No.
So now I think we should start doing the scleral thickness, especially if you have a swept source. And you still might have peripheries not getting corrected well. Your central part of myopia might be getting corrected well. Axial length is not progressing axially. But the periphery still might be weak in this one. So I don't know, because we had a discussion on this at the RP center, and debate still goes on. Nobody has the answer. So one company says this is working fine. The other company, I'm sure, is going to come out with the answer that mine is better than yours and cheaper also. And we'll give you 2 free. Buy 1, get 2 free. But at the end of the day, it's your call.
Absolutely.
If you're satisfied and the patient is following up with you, the proper centration of the... do you think the centration is the issue in these ones? I mean,
very much so. You must train your optoms because unless the data is given correctly to Stellest, you're going to have unhappy patients.
Correct.
So one thing that Stellest does is that it comes and trains your optoms for you on the data that they need. So they have to provide the data, the interpupillary distance and things like that accurately. And only then will Stellest supply the glasses.
So that's very important. Thank you very much. That was a very good talk.
One last comment I would like to make here, that it is very important to estimate monoocular estimation method accommodation lag. Because if there is a lag, then this glass will not work, and you will need a addition, maybe a progressive glass will work better in these children.
Absolutely true. And so one of the ways earlier to halt myopia progression was progressive glasses, and multifocal contact lenses were also tried. But they reduced the myopia by an average about 40 to 45% as compared to 60% and more with the DIMS and the halt technology. Yes, sir.
To strengthen the sclera, is any work going on?
Yes.
Anywhere in the world?
Earlier in the morning I mentioned from China there is a study on using red light 3 minutes a day, twice a day of a particular wavelength, and they feel that reduces the hypoxia to the sclera, and therefore the sclera strengthens, more collagen is laid down in the peripheral sclera, and that contributes to reduction in myopia progression. So these studies are there from China. Yes, Dr. Schultz.
Okay, thank you.
What's the effect of a child's accommodation there? Huge amounts of accommodation.
Exactly what she said the same thing, that this is something that has to be taken into account. There's no such thing as a magic formula in these patients. So you need to estimate your myopia more accurately using an AR machine, auto-ref machine for kids. Is a big no-no because they accommodate hugely, and you need to do subjective, objective, cycloplegic refractions before you fit them onto these, otherwise you'll have dissatisfied patients.
Right. Thank you, Kurish. I think we're running short of time. We had extra time, but then the ESLA people ate into it. Okay, fine. So now we have a lady coming all the way from Taj Mahal, Agra. You from Agra, right?
Yes, sir.
Okay, perfect. So how's Mumtaz? She's doing fine? Okay, good. So she's going to be talking about recent guidelines and prescription of glasses. I think that's the crux of everything. Whatever you do, any surgery, if your glasses are not centered properly, not powered properly, and not checking them and they've got scratches, the parents are not using glasses, it's not going to work. So the media has to be clear, and the glasses are the one which you can take off and clear, not the same for the IOLs. So Arushi, all yours, please.
Thank you. I'm so very happy to be here and extremely thankful for Dr. Dadia for the opportunity and the College of Ophthalmologists for such a warm welcome. So I have no conflicts of interest to disclose. Refraction continues to be the same. What really has changed is the visual behavior and needs of the modern day child, leading to a major rise in childhood refractive errors. So we understand that every child has a right to clear eyesight, and every child who visits our clinics should undergo a cycloplegic refraction. However, not every refractive error that is unmasked on cycloplegia needs to be prescribed. To answer which ones need to be prescribed, we need to know whether they are ambliogenic, whether it is significant for the visual needs of the given child, and whether this error will cause any effect on a strabismus if present. It is not easy to formulate exact guidelines for what to prescribe for each child since there are multiple factors. But the most important considerations are age, anisometropia, and associated strabismus, visual acuity assessments, whether it is reliable or not, how much the child is accommodating, and the risk factors for amblyopia for a given child. We should therefore always try and get an idea of a baseline visual acuity, preferably one eye at a time, using the age-appropriate methods. A dry retinoscopy should be attempted before cycloplegia to help us assess accommodative effort. Autorefractometers for younger children are best avoided. Presence or absence of a squint is important to be judged. Manifest tropias can be noticed the minute a child enters the room, but even in cases where the child has very good control for near and uncooperative for a covered test, just putting a translucent occluder can help reveal a misalignment. Presence of dissociated vertical deviation is almost always indicative of an amblyopia. So, which cycloplegic to be used? Is it to be used for all cases? Yes, all cases. Even for the myopes? Yes, because then it can help us identify pseudomyopia and accommodative spasms. So, which cycloplegic should be used? Tropicamide by itself is not good enough for children. Cyclopentolate is strong enough for most children, and hometropine and atropine, those strong cycloplegics, are more for therapeutic uses. Moreover, there are multiple logistic drawbacks with atropine. So, the best way out for children with dark eye rides is to use tropicamide in combination with cyclopentolate. Cycloacceptance, which is done in the same manner as a manifest refraction, except checking for near, is an extremely useful tool, but to be used judicially. It is best avoided in hypertropia. So in patients where we are getting a hypermetropic component, we can do an acceptance just before installing the eye drops. This helps save a visit for the post-Paediatic test. After dilatation, fundus examination is a must. At least we should take a look at the posterior pole before making a final decision. Now, how do we prescribe? There are many guidelines, almost similar and widely accepted. But these are based on practice patterns and definitely not the rule. This chart here is from APOS. The general consensus is that our threshold for prescribing is higher in younger children because they need to emmetropize. However, the minute there are any amblyogenic factors that come into the picture, our threshold goes down immediately. So myopia less than 3 to 5 diopters is not high risk of amblyopia as the near vision remains unaffected. However, when there is a myopia greater than 5 diopters, even in a very young child, we should be prescribing. But if an infant has very high myopia, like a 10 diopters or something, I would probably think of a syndromic association, like Stickner's or maybe retinal dystrophy, etc. Once a child becomes preschool going or school going, they need to see clearly, and we have to correct them completely because they have, for the myopia, because they need to see for distance as well. The aim is to prescribe the lowest minus power needed for best visual acuity. Now, tackling progressive myopia in kids is a work in progress, and what we've learned from the WSPO's consensus is that undercorrection does not work. In fact, it is more detrimental. Only a handful of studies saw benefit from the PALs and hyperopic defocused lenses, hence they are not recommended either. Among others, what does appear to work are the newer DIMS and HAL myopic defocus lenses, which have so beautifully been discussed by Dr. Muscati in the previous talk. In cases of hypermetropia with straight eyes, we prescribe if the error is greater than 4.5 to 5.5 diopters. Mild undercorrection can be done because accommodation is a binocular phenomena and undercorrection has to be equal in both the eyes. We should always rule out an intermittent esotropia, and which may be in the form of an early refractive myopia, refractive accommodative esotropia. Before we put the drops, it should be ruled out. So for first-time hyperopic glass wearers, short-term use of hometropine may help in easy breaking in of their glasses. Coming to astigmatism, a cylindrical power of 1.5 to 2 diopters even can be amblyogenic. That is why a full power of a cylinder should always be prescribed after the age of 2 to 3 years. We feel that the child might not accept it, but young children accept full cylinder extremely well. Once the child is older, if their visual acuity is getting affected, even a smaller cylinder should be prescribed. In these children, the spectacle central is extremely important because bent or crooked glass frame can change the axis, so they should be repaired immediately. Anisometropia, it is an extremely powerful risk factor for amblyopia, hence our threshold for prescribing 2 is low. Prescription should be given at or more than anisoastigmatism of 1.5 diopters and anisohyperopia of 1 diopter. We think that with too much anisometropia, a child might not fuse, but that's not true. Even because of Knapp's rule, even with glasses, they do fuse. Only thing is that single-side high glass may be cosmetic concern, so sometimes to remove the blemish, contact lens may have to be given. Ocular deviation, once it enters the picture, changes our guidelines. And whenever there is esotropia, we have to fully correct the error. For myopia, we give a full correction. For hyperopia, less than 5 years, we give full cycloplegic correction. More than 5 years, we push for the maximum plus that is tolerated by the child. In a case of high AC by A ratio, near ad can be given. In exotropia, we have to fully correct the myopia and astigmatism, can sometimes even over minus. But small hypertropias with normal vision have to be ignored. However, if a hypermetropia is reducing the vision, we have to definitely prescribe, but we choose to undercorrect. Then there are special situations like cataract surgery. In younger children whose visual world is only for near, we give single vision glasses with the plus addition. Once the child starts using down gaze for near, bifocals are given. Sometimes an otherwise healthy child may not be responding to visual stimuli even up to 4 to 6 months of age. They may have something called as a delayed visual maturation. So giving these glasses and +3 or a +4 chances, +3 or +4 glasses suddenly changes their visual behavior. Other conditions like CVI and Down syndrome may also have an accommodation lag who may benefit from near addition glasses like bifocals. And children with aniridia, oculocutaneous albinism will do much better if an amber or rose-colored tint is incorporated in their prescription. Now, finally, the parents. We need to clear out all the myths surrounding glasses they believe and explain to them that we don't want the vision holding up the general development of the child. And if they like, in future, there are refractive corrective options for them. So, follow-ups. For the first follow-up at 3 to 6 weeks, we assess the glass compliance, fit, look for scratches, etc. At 8 to 12 weeks, we see if the child has improved in vision, whether there is any change in deviation, start amblyopia therapy is needed. For the first year, the child should be followed up every 3 months, and then depending on age, the next years, 3 to 6 months. So thank you for patient listening and happy prescribing.
Dr. Arushi, it was a very beautiful presentation, well explained. There's a question I have for you. Like an infant, 1 year old, and if he is having a myopia slightly more than what is expected of his age, suppose like -6 or -7 he has, then how will you balance the process of immetroposition and the amount through which he doesn't get amblyopogenic?
So ma'am, most of the times myopia in an infant is not axial. A lot of times it is lenticular or corneal. So we're not really worried about the axial component. However, I would probably undercorrect this child by 3 to 4 diopters. Or maybe if the family is extremely compliant, we can visit them, have them visit us every 2 to 3 months and see how the visual behavior of the child is changing. I would not be, slightly hesitant in prescribing in the first go.
Yeah, the message should be like that. The residual amount of the refractive error should always stimulate the process of immetroposition. So it should always be whatever the amount, the prescribed amount, slightly less than that.
Right. And thank you very much. I think she covered the basics very well. But that's where we started, and we got all the machines, LASIK cutting the corneas and all. But the basic thing is refraction under cycloplegia, which she covered very well. Arushi, thank you very much.
Thank you, sir.
Now I'll call upon the speakers to have a photograph here, and we're going to break after that for lunch. And people who are not going to be in the picture, they can go start their lunch.
Very good afternoon to one and all. We are starting the next session. So I will request Dr. Anand to come on the dais and speak in current concepts in management of keratoconus in children. Dr. Anand, your time is 8 minutes and kindly stick to the time.
Thank you for allowing me to be a part of this lovely session. I'd give you a broad overview of what we have been doing as well. So I guess the first question is what is different from adult versus pediatric? One is that here you're treating for long-term visual gain, which is 70, 80 years into the future. The second is the definition of success is slightly different from what we do for adults. The progression of keratoconus, we do know, is a lot more advanced and a lot more faster. You invariably will need post-treatment visual aids, but the challenge will be acceptance of those post-treatment visual aids. An important part about cornea is that the type of collagen is different. The collagen turnover tends to be significantly more. So over a period of time, you may require some patients who may require a repeat treatment, and the response to treatment in our hands is very variable. Some of them have very significant flattening to the treatment. Some of them respond very, very mildly. The second is the symmetry of involvement between eyes. What we find is significantly different. Most times they have asymmetric involvement, and there is a variable depth of the demarcation line. Sometimes there is resistance to acceptance of glasses, and also some of them will require contact lenses. Now, the important point is about early detection. So we do recommend yearly follow-ups for anybody with chronic allergy. The second is, in terms of rapid progression, if there is significant change in the refractive error, more than 1 diopter per year, we do recommend a tomography or a topography. A comprehensive approach doesn't mean only the eye treatment, but also the systemic part, which requires, in about 30 to 40% of patients tend to have associated allergies. We do know that the prevalence is higher in patients with allergies. The progression rates are up to about 20% annually. There is some genetic factors, and in 14 to 16% of the cases, there is a family history, either cousin, sister. We have about 4 families in which brother and sisters are affected. And we've already touched about environmental factors. Now, when we look at diagnosis and early detection, the important part is not only the slit lamp examination, and if you note, I put refraction plus retinoscopy. That is, refraction is an equally important part. And for all children, just like pediatric ophthalmologists, retinoscopy becomes important. I do retinoscopy even for my refractive surgery, SMILE, LASIK patients, because that becomes an important part of detecting from fruit keratoconus. Topography and tomography, probably indispensable in the present modality of treatments, because we can invariably pick them up very, very early. The treatment paradigm is basically the goal, approach, and the options. The goal is stabilization of keratoconus to prevent changes in the shape. The approach is, as I said, based on disease severity, and I'll show you an algorithm that we follow, and we try and customize it to individual needs. When we're looking at collagen cross-linking, probably the most commonly performed procedure, aim is basically to increase the corneal rigidity. The effectivity is actually very good. In pediatric patients, almost about 90% of them have stability of the keratoconus, and it is generally well tolerated in all patients. Very occasionally, if the allergies are not controlled, they tend to be symptomatic and tend to move around during the collagen cross-linking. Most of them, we are able to, at least up to 9 years and above, we are able to do it under local anesthesia with very, very mild sedation. And as I said, that it does stabilize the keratoconus quite good. Usually, the average reduction is about a couple of diopters, and effectivity, as I said, is about 80%. The important point is about yearly follow-up. A lot of them may require, 20% of them may require a second treatment. We have done it in about 2 patients on progression, which occurred almost up to 6 years. So the patient was operated at 10 years, and at 16, we needed to repeat the collagen cross-linking. There are some advanced collagen cross-linking techniques which come under accelerated protocol, which is what we use normally, which is 9 milliwatts for about 10 minutes, and that gives the stability the best, based on current literature as well. Some customized protocols are there wherein you treat only the area of the ectasia. Most of them, the reduction in Kmax is about 1 to 3 diopters. There are some riboflavin options in collagen cross-linking, which is transepithelial, though there is some long-term data saying it may be not as effective as epithelial off, but in some centers this seems to be a preferred option purely because of the patient comfort. Scleral lenses in keratoconus, an important part for visual rehabilitation. Almost all of them have an improvement in the best corrected vision. Patient satisfaction is almost about 90%, and most of them, once they are taught, are able to do it themselves. The important part is that even for slightly advanced cones or patients not willing for immediate treatment, the collagen cross-linking fit is actually very, very good. The BCA improvement is invariably in about 85%. Very occasionally, we need to do some additional intervention to improve the fit, but majority of the time, they have very, very successful adaptation. Intracorneal ring segments, probably more recent addition. Not my primary procedure for collagen cross-linking, but that is a reduction in the Kmax, usually up to early to moderate keratoconus. We suggest this. A lot of them have an improvement of uncorrected and best corrected vision. A small risk of segment extrusion tends to be there in about 5%. In the follow-up of patients, usually the uncorrected and the best corrected improves by about 70%, and the reduction is slightly more than collagen cross-linking. So you may get a synergistic effect if you plan that with collagen cross-linking. Topo-guided PRK, slightly controversial when you're looking at pediatric, but very well accepted for adults. And the response is slightly less than collagen cross-linking, or when you're doing it with intracorneal rings, partly because you cannot ablate a lot. You have a restriction of about 20 to 30 microns. But about 70% of them do show visual improvement. Clinical outcomes probably is good, but what is something troubling, especially in children, is sometimes the corneal haze, but the stability is very good. Most of them will require a secondary optical aid, either a good spectacle fit or scleral lenses. Phakic lenses, also something, some of them not the most common way of approaching visual rehabilitation, but almost a very rapid reduction in the amount of sphere and the cylinder. So if you have large refractive errors with stable keratoconus, the youngest we have done is about 16 years, but there is a significant improvement both in uncorrected and definitely the best corrected vision. What is important in phakic IOL calculation is probably in some of them there may be a myopic shift. The second part is the sulcus to sulcus measurement, which is important because some of them you would have to get a very good refractive calculation to be done, and we aim for a bit of myopia, usually about -1 in phakic IOLs. Lamellar keratoplasty techniques was something that we were offering a lot more. The amount of surgery that we're doing has come down significantly. But graft survival in children is almost about 90%. I would not touch upon this, but long-term outcomes of LK are very, very good. Vision therapy is something we started doing for pediatric keratoconus. We found that there is an improvement in some of these patients if they are selected well, especially if there is a chance of amblyopia. We are still in very, very early stages of vision therapy, but now our approach is combining treatments, and that we find is probably the best way of doing that. Some mention of iontophoresis. I know it's quite popular in Europe. I don't have any personal experience. So now the approach is genetic profiling, tailored treatment as per the stage of the keratoconus, and usually you get very good outcomes, almost 85% improvement. I mentioned about family counseling partly because of the results, and I will touch with my last slide about the broad outcomes. So when we look at early and advanced keratoconus, the approach is based on the stage of the treatment, and I'll be very happy to share this if anybody is interested. Thank you so much for your time.
Thank you, Dr. Anand, for an excellent talk. Do you recommend phakic IOLs in children?
So as I said, it's not my first preferred option, but in stable keratoconus beyond 16, in case of advanced refractive errors where the significance of myopia and astigmatism is very, very significant, we have done about 2 patients. But as I said, not my primary procedure. If you're looking at younger patients, probably not.
What is the youngest age of the youngest child you have done collagen cross-linking?
7.
So that is under general anesthetic.
Yes. So anything, as I said, my cutoff is 9 to 10. You can make out during examination itself. If it's a cooperative 9, 10-year-old with a bit of speech, occasionally I do get one of the patient relatives in the OT, so they're speaking and holding the hand. That really helps.
Any questions to Dr. Anand? Anyone from audience? If there are no questions, then thank you, Dr. Anand.
Thank you so much.
Dr. Tariq Qureshi, he will be speaking on role of vitrectomy in ocular trauma in pediatric cases. Dr. Qureshi, please.
Good afternoon, respected chairman, co-chairman, and delegates. I'll be shortly speaking on role of vitrectomy in pediatric ocular trauma. Today's child is tomorrow's future. So 2.4 million eye injuries occur worldwide, out of which 35% occur below 14 years of age. 60% of the pediatric injuries occur during sports or recreational events. Prevalence of ocular injuries is more in male children. Eye injuries are leading cause of visual disability and blindness in children. It's a preventable cause of visual impairment. 90% of the injuries can be treated or decreased in severity with timely diagnosis and treatment. Vitrectomy has an important role in the management of pediatric ocular trauma. It prevents morbidity and mortality in perforating and penetrating injuries. Indications of vitrectomy. Penetrating injury with vitreous in anterior chamber on the wound, thus preventing epithelial ingrowth or fibrous ingrowth, dislocated lens, vitreous hemorrhage, retinal detachment, retinal intraocular foreign body, endophthalmitis, and perforating injury. Now, the question comes when to do vitrectomy. If it's the vitreous hemorrhage, one can wait for 2 to 6 weeks, but it's a retained intraocular foreign body, immediate surgery, endophthalmitis, immediate surgery, perforating and penetrating injury, immediate surgery. Advantage is that present-day 27-gauge vitrectomy offers wide array of advantages, which is it's transconjunctival, so no suturing is required, no corneal distortion or no astigmatism, maintains intraocular pressure per op, reduce operation time, thus reducing the inflammation and complications. The role of vitrectomy in ocular trauma is immense and ensures good visual recovery. Key to success is early intervention. Results of surgery are rewarding. And this is a short video. This is a case of injury with a retained foreign body. The primary repair was done somewhere else, and the patient was referred for vitrectomy. After clearing the vitreous, we have found an intraocular foreign body in the subretinal space. We are trying to make a retinotomy there to dislodge the foreign body into the vitreous cavity and clearing the vitreous around the foreign body and removing the foreign body thereafter. And such a case needs an intervention, and we cannot wait for a week or so, and early improvement of the vision is guaranteed. This is another case of perforating injury wherein the vitrectomy was delayed, and you can see the thick membranes in the vitreous as if you are cutting the cloth. It's very difficult to operate such as already in children the vitreous is quite gel, and induction of PVD in children is very difficult. And now you can see the part of the retina is visible, and now you will see the exit wound. Exit wound has formed a thick scar, and if we don't remove this scar, it's going to cause a tractional retinal detachment or a giant retinal tear. You can see we're going around the margins of the wound, and this scar has to be removed, and we have planned a retinochoroidectomy with fluid exchange, endolaser, and silicone oil. Fortunately, the exit wound was in the nasal side of the retina, and patient was fortunate enough to have a vision of 6/12. We are trying to remove the scar, but we had a lot of difficulty as the scar was very, very thick. But we finally managed to remove the scar piecemeal and achieve the retinochoroidectomy. We have removed the central part, and now we are trying to remove it en masse. We tried to pull it, but it's so adherent to the retina and it may cause a total detachment. So at this stage, one should have a patience and remove it by piecemeals till it is removed completely and chopped off. And at the end, you can see this whole scar is removed and the retinal choroidectomy is achieved, and retina is finally settled with endolaser. These are the cases where the intervention in pediatric ophthalmology is very, very important, and interventional surgeries have to be done at the earliest. And in such a case, if it's not treated as it was done, this surgery would have lasted, say, maximum of 30 minutes and lasted around 1.5 hours. And you can see with piecemeal how difficult is this to remove the scars. And once we removed it, everything was perfect and retina got settled. This is the last stage where we removed the whole scar and achieved retinochoroidectomy, and then induced fluid exchange, and then endolaser and silicone oil. This is the final picture, and the scar is completely removed. And this is the final story. Then there was another case of a vitreous hemorrhage, and wherein the vitreous hemorrhage was quite thick, and for 6 weeks it didn't resolve. We planned to do vitrectomy, and as I said earlier, that vitrectomy in a child is not that easy in an adult. Firstly, the vitreous is quite thick gel. Induction of PVD is very difficult, and once we induce PVD, one has to be very, very careful of not touching the lens, because the size of eyes in the pediatric age is smaller than what we expect, and in such cases we have to be absolute meticulous and do all the procedures of core vitrectomy, induction of PVD, peripheral cleaning, indentation, and the key to success is that even the last bit of vitreous has to be removed. This was another case of foreign body with a hole near the disc, and we have been able to remove it completely. Thank you all for your patient hearing.
Thank you very much for your excellent presentation and nice videos. So as pediatric ophthalmologists, we are always worried about amblyopia, vitreous hemorrhage causing amblyopia. So how soon do you want to do vitrectomy in case of dense VH without any other globe injury or lens subluxation or RD?
Sir, as I said, that few situations demand early vitrectomy, like if it's a retinal detachment, intraocular foreign body, retained intraocular foreign body, or endophthalmites. Endophthalmites in children is nowadays prevalent because of these hypodermic needle injuries, and in such cases, the early vitrectomy. Amblyopia in every pediatric surgery is treatment of amblyopia in every pediatric surgery is key to success. Whether you have done an IOL, you have done a squint surgery, or you have done a retinal surgery, post-operative treatment is more important than the surgical intervention. So they have to be followed frequently and treated accordingly. Thank you.
Any questions from the audience? We can allow one question.
Yes, Dr. Pochari, I'm a resident from Rome University. I wanted to ask, in the case of the advanced scarring, is it possible, or do you think you could use like a fibrinolytic for helping with the scar removal tissue?
You have seen that even with a cutter, it was very difficult to remove. How can a thick scar be removed by a fibrinolytic agent? And even with this cutting rate of around 20,000 per minute, it was very, very difficult, and it was a time-consuming procedure. I don't think, in my opinion, the fibrinolytic in a thick scar will be effective.
But using it beforehand Would it
No, I have
help
never
to make
used
the
such
easier?
agents in my life.
Okay, thank you.
Thank you very much, Dr. Tariq Qureshi, for your excellent talk. So the next talk will be by Professor Karanjit Singh. We'll talk about refractive lens exchange in anisometropic amblyopia.
Actually, my talk was at 8 o'clock in the morning. And before my talk, there was one talk by a stalwart and ophthalmologist. She discussed about esotropia and LASIK procedures and in young children. Go to 8 o'clock slot and there you might get my talk.
Professor Kamaljit will take the next talk and then take you in the immediately after.
Okay, thank you.
Okay. So I invite my co-chair, Dr. Hiranya Abhisekara, consultant pediatric ophthalmologist at the Lady Ridgeway Hospital for Children, to give us an update on retinoblastoma.
Thank you very much. Thank you very much, Dr. Amila, for inviting me to do this talk. Sincerely, I forgot to send my CV to the organizers, so I'm just displaying a few sentences on my CV. So I was trained in Birmingham, and I've been managing retinoblastoma, and I have contributed a little bit to the science as well. So retinoblastoma is the most common ocular malignancy in children. It is lethal if you leave it untreated. In Western world, in high-income countries, the outcome is really fantastic, with 100% disease-free survival rate over 10 years. But depending on the economic stage of the country, the outcome depends. As far as health indices are concerned, Sri Lanka is a little bit outlining. So, like our maternal mortality, childhood mortality, the mortality from retinoblastoma also different from rest of our colleagues in low, middle-income countries. So, first, before managing, you need a proper diagnosis, and you have to classify the disease. So, diagnosis and classification of retinoblastoma is mainly clinical. So you see this odd wide reflex or this unusual squint, and you dilate the kid to see the one of these tumors on the posterior pole. The next thing you would do is get your B-scan probe and do an ultrasound scan. You may do this while you are doing the EUA, but you can do conveniently in the clinic as well. And demonstrate this retrolental mass with or without RD, and you will see this calcification in the lesion, which is almost diagnostic. So you need EUA for accurate classification, and you need to look at the other eye, make sure it's a bilateral disease or unilateral disease, and if there are any tumors in the other eye, group A tumors particularly we find, we can do laser. And we can document with retinal photography. So international classification of retinoblastoma is the current classification system in the practice. Group A, small tumors away from disc and macula. Group B are bigger tumors closer to disc or macula, may have a cuff of SRF without vitreous seeds. Group C, isolated vitreous seeds with a cuff of SRF and a bigger tumor. Group D is diffuse seeds, and the stage, the group increases, the prognosis becomes poorer. Group E is the poorest one, as far as the intraocular disease is concerned, and it's extensive tumor. So, enucleation is a fantastic management option. Perhaps it's the oldest managing modality of retinoblastoma. It cures in most cases, particularly in unilateral group E diseases. If a patient doesn't need further chemotherapy or any other therapy once a proper enucleation is done. But our mainstay of treatment is thermochemotherapy. That includes chemotherapy plus focal therapy with laser or cryo. Intraarterial chemotherapy has risen over the last decade as primary treatment and as well as the second salvage treatment for certain selected cases. Intravitreal, intracameral chemotherapy are very good modalities of globe salvage treatment. And there are plaque and brachytherapy, which I don't have experience in these techniques. Intravenous chemotherapy is our primary therapy. And in most parts of the world, this is the primary therapy. So this includes 6 cycles of chemotherapy, 3 agents. In institutions where intra-arterial chemotherapy is available, they have separate indications to start intravenous chemotherapy. But in our setup, we start intravenous chemotherapy in all patients who require chemotherapy. So long-term outcome is very good. Of course, we never use intravenous chemotherapy as the sole therapy. It is combined with other therapies. So focal therapy is basically is to consolidate the tumor, which is reduced by the chemotherapy. Cryotherapy and transpupillary thermotherapy are excellent ways of giving focal therapy. So cryotherapy is performed under indirect ophthalmoscopy. So we can place the probe either on the conjunctiva, or we can make a nip on the conjunctiva and place the probe on the sclera directly for more posterior tumors. And we have to follow the triple freeze thaw technique. Thermotherapy is by 810 nanometer diode laser on continuous mode, which is an excellent way of treating these patients. And in difficult cases, ICG can be used, although I have no experience in using ICG. Intra-arterial chemotherapy, as I said earlier, has become a mainstay of treatment for selected cases in retinoblastoma, but still remains away from our systems. So it involves delivering chemotherapy directly onto the orifice of the ophthalmic artery, which is very successful in selected cases. So first line therapy in unilateral, particularly unilateral disease, and salvage therapy once the primary therapy is failed. So a lot of my friends ask why IAC is not available in Sri Lanka. Of course, Dr. Santosh Honavar, the editor of Indian Journal of Ophthalmology, has given the answer. So we have economic barriers that we cannot go through. So that's the main reason why we are not having intra-arterial chemotherapy. Not that expertise, not the ability to do these things, but the sustainability of maintaining this modality of treatment is very, very difficult in our setup. Intravitreal chemotherapy is used, is basically a very safe way of injecting melphalan and topotecan into the vitreous without refluxing. And it's a main globe salvage treatment in our setup, and it's being standard throughout the world. So precision intravitreal chemotherapy is upcoming. And it involves delivering the chemotherapy directly onto the accurate place where it requires through intravitreal injection. So in selected cases, we can do intracameral chemotherapy, but we have to remember intravitreal or intracameral chemotherapy are never used as primary chemotherapy. So these are globe salvage, secondary treatments. So this is a summary of amalgamation of all the treatment modalities. First, we have to establish the diagnosis. Once the diagnosis is made, we have to decide whether to go for chemotherapy or whether to do enucleation. So enucleation is a very excellent, it's a great way of treating certain selected patients. So it saves lives. In centers where IAC, intra-arterial chemotherapy is available, so you can use for group C, D, E, unilateral, non-germline cases very successfully. But bilateral cases almost always require intravenous chemotherapy. So remember, retinoblastoma management is not one man's job, it's a teamwork. If one fails, the whole system fails. So to give the life expectancy and the globe salvage to these kids, we need this team going on. Thank you very much.
Thank you, Dr. Irania. Any questions from the audience. Dr. Irania, how you mentioned Sri Lanka rates as 93%?
Yes, sir.
Of salvaging the globe.
No, life expectancy.
Life expectancy. Okay. So, in your hands, enucleation is still the most widely practiced. And
Yes.
as an adjuvant, you give any of the other therapies that you're talking about.
Sorry, question is.
For tumors which are greater than grade 2, enucleation would still be the primary.
No, enucleation I would do in group B cases, particularly if it is unilateral. I would not think about any other treatment. But if it is bilateral, then I would go for the intravenous chemotherapy and then decide on enucleation later on, because I do not want to delay the proper treatment for the child.
Okay. Thank you.
Thank you.
We'll now have Professor Kamaljit Singh on refractive lens exchange in anisometropic amblyopia.
Thank you, Dr. Maskati, Dr. Dadia, and Sahoposa, and Sri Lanka Ophthalmologists for giving me this opportunity. Amblyopia, you see, is a big problem in our hand, and presentation of amblyopia is many a times delayed in India. People don't worry about getting their examination done, and when the examination is done, they find that in one eye they have amblyopia. So that is a big problem. Then there are studies in which for amblyopia phakic IOLs have been tried, and the results have been very good. So refractive surgery for amblyopia continues, and many people do LASIK, and you had seen in the morning that Madam was talking about doing LASIK and other procedures for treating the esotropia, accommodative esotropia that was there. So now there could be a myopic and isometropic amblyopia in many cases, and at the age of 25 years, 50 years, I have seen that people having an isometropia and they were not even aware of that. One of them is my school friend who used to come to my house every day, and still he'd never bothered to get his vision checked. And at 50 years he called me, and I came to know that he had amblyopia, an isometropic myopic amblyopia. So that sort of situation is there. So what to do at this stage? You can do a refractive correction, you can give them glasses. You can do patching also even in adult amblyopia, and penalization pharmacological therapy, but none of them usually work. So this was my first case in 2009, where I found that this patient had minus 9.5 diopter of spherical error with this little bit of cylinder, and a divergent squint also in that eye. So I asked him, why have you never used contact lenses or glasses? He said that I can't afford the contact lenses. Every time they need to be changed. And the phakic IOLs he never bothered about, so he could not afford even that. So that was my first case where I did my refractive lens exchange. And to my surprise, the best corrected vision was 618 before surgery, though the squint was there, and the other eye was normal. So when I did the refractive lens exchange, I found that the vision improved to 6.9, and that means that there was no anisometropic amblyopia. Little bit of strabismus was there. Still the patient's vision improved at the age of 38 years. This is another case where the refractive error was there. Anisometropia to the tune of minus 11.5 diopters was there, and we did a refractive lens exchange, and these options were there, but the affordability is very poor, so we do refractive lens exchange. Plus in adults, even in myopia, the refractive lens is advocated. So the RLE can be done in all these cases, and the results are very good. And in myopia, usually the amblyopia is not very dense even at this age. I came to know then only. And if you give them glasses, the magnification occurs, so the vision remains poor, even with the best corrected glasses, so that can be done. And we have done about 30 cases, And in most of them, we have found that the results are very, very good. So this is how we... This is in refractive lens exchange, what we do is we make slightly larger capsular axis, and this lens is taken out of the bag, and then simply phacoaspiration is done. Take care that you don't do too much of surge in them, so that too much of movement of the vitreous is not there and chances of detachments are reduced. So it has been already said by various authors and by Professor Prem Prakash, the authority in India, that usually occurrence of amblyopia in myopia is not common, because these patients, even when not corrected, have the opportunity of having adequate stimulus for development of vision from near objects. So the amblyopia is not that dense, and if you do the surgery, refractive correction plus strabismus correction, patient gets very good vision and very good outcome. So these are some of the cases which were done by Professor Prem Prakash and found that the results were very good. And it was in the year 1983 that he told that the amblyopia is not dense. So this is how you can do the job there. And therefore, in conclusion, we can say that refractive lens exchange with IOL implantation in amblyopia with manifest squint has the advantage of providing cheaper and most stable refractive procedure. Thank you so much.
Thank you, Professor Kamaljeet. And any questions from the audience? Okay. Thank you.
Thank you so much.
We now invite Dr. Rameshri Shastri, consultant ophthalmologist and glaucoma specialist from Hyderabad, talk to us about recent advances in management of pediatric glaucoma.
Good afternoon, everyone, and I would like to thank Dr. Qureshi, the organizing committee of SAOPOSA, and Professor Dadea for giving me this opportunity. Today I will be speaking about the recent advances in pediatric glaucoma. It's a heterogeneous array of diseases with ocular dysgenesis and causing raised intraocular pressure that can cause blindness to the percent of 4.2 to 5% in pediatric population. Study in South India have shown it is in 1 to 3,300 population, bilateral in 70% of the cases having asymmetric disease and a male predilection. We know about the classical triad of congenital glaucoma, but there are certain signs which are very subtle, like dilatation of the upper eyelid veins, anterior embryotoxon, and peripheral iris degeneration that can make things complicated. Molecular etiology of PCG is not yet fully understood. However, the recent advances in genomics have shown us multiple genes that are involved, and the most common is CYP1B1 and LTPP2. CYP1 gene mutations have been seen as sequence variations and missense mutations, and in Spain, 30% of the cases have shown loss of these function in CYP1B1 variants, leading to null genotypes. So those cases with CYP1B1 have known to have early onset disease with severe manifestations, and post-operatively have more post-operative haze and very bad prognosis. LTPP2 mutations are also known to have causation factor in PCG. They have frame shift mutations most commonly noted. Currently identified genes explain to about only 5 to 50% of the cases that have been identified. Coming to recent advances, the IOP measurement in children is quite challenging and technically difficult. Most of them require examination and anesthesia. The tonometry options we have are Schiot's tonometer, Perkins, TonoPen, and the iCare Pro and iCare tonometers. Schiot's tonometry is not being used here because of decreased scleral rigidity. Perkins is the gold standard, which is the handheld version of the Goldman applanation tonometer. It is the preferred method. We have several studies that have compared TonoPen with Goldman applanation tonometry. It tends to overestimate intraocular pressure. Any IOP more than 16, average of 3 readings has to be taken. That's the preferred practice pattern. Coming to rebound tonometry, we have iCare and the iCare Pro. The iCare Pro can be used in supine position, especially in examination and anesthesia. There are variable limits of agreement, as you see in this table. However, when we have an IOP more than 19 millimeters of mercury, it's better to confirm it with the Perkins tonometer with the child under anesthesia. Coming to other investigations, the innovations in anterior segmentosity. Now this is the picture on the right side that you see, on the extreme left that you see is a normal child with the right eye, whereas the left eye shows absent Schlemm's canal and a hyperreflective membrane on the trabecular area. This is another picture of an intraoperative anterior segment OCT which shows absent Schlemm's canal. This is another eye with patent Schlemm's canal. And this is the picture of the anterior segment OCT showing the HAPS ray as a hyperreflective membrane which is floating in the anterior chamber. The bottom two pictures show hyperreflective membrane of varying densities. So anterior segment OCT helps us understand the varying morphological abnormalities and help us identify the appropriate surgical modality that we can incorporate in treating them. UBM acts as a in vivo histopathology. A study done by Tandon et al. Have shown that those cases with pediatric glaucoma have smaller Schlemm's canal compared to the healthy counterparts. This is the quantitative ultrasound biomicroscopy where we can measure the various parameters as mentioned here, angle to angle, CCT, radius of curvature, and the anterior chamber depth. With the help of Python iMark, that is a semi-automated assessment using UBM, we can mark all these 8 points, and all these can be used, the images can be taken by the technician, and they can be used for telemedicine and research purposes. Posterior segment OCT helps us in understanding the retinal nerve fiber layer, and especially in these eyes with PCG, which are tending to have axial elongation and high myopia. But we need to understand the different developmental trajectories of the different retinal layers, and you see that the development or identification of an ellipsoid zone indicates retinal maturity. There's a picture in the center is the picture of an eye with primary congenital glaucoma showing deep posterior nerve head cup and an absent ellipsoid zone. This is compared to the right eye and the healthy control with the help of handheld OCT. RETCAM is another important investigative modality for both anterior and posterior segment images. The current trends coming to in surgical management, this is the goniotomy that we have and the combined trabeculotomy, trabeculectomy. However, there are certain variations in these conventional surgeries. So once we identify the Schlemm's canal, which is a gutter-shaped position landmark between the blue and the white junction, an incision which is deeper, and you can see an ooze and the fluid coming out of that. So variations are using viscotrabeculotomy. I'm sorry for that spelling. 23 gauge cannula is inserted into it, and a high molecular weight visco is injected into the Schlemm's canal. The other variation is cannulation using a 5-0-proline, that is an ab externo procedure. Another important procedure that has come up now is the impact technique using an illuminated microcatheter where a fiber optic wire is inserted into the Schlemm's canal, and the entire path of the Schlemm's canal that is dilated with the help of this fiber optic probe can be identified, and then once it comes out at the other end, it can be pulled to break the inner wall. Gonioscopy-assisted transluminal trabeculotomy is another where we identify the anterior border of the posterior trabecular meshwork in size for about 2 to 3 clock hours, and the bulbous end of the proline, heat cauterized proline, is inserted through the incision, and it passes 360 degrees. And once it is retrieved at the other end, both ends are pulled out to cut open the inner wall of the Schlemm's canal 360 degrees. Micro-incisional trabeculectomy is another surgery that has been popularized by Dr. Aparna, who is my mentor. She identified the posterior trabecular meshwork here, and the vertical cuts are made at 2 to 4 clock hours, and the trabecular tissue between the two landmark cuts is peeled off using a vitrectomy forceps. So here the entire trabecular tissue can be got for research purposes, and we have studied the histopathology of this trabecular tissue. So TSCPC has been used as a conventional surgery for refractory glaucomas. The novel type is the micropulse diode laser, which has less complications and high success rate. Endocyclophotocoagulation is another cyclodestructive procedure, which is an intraocular procedure. Here we use a probe with light and laser delivery system in a single probe, and the pars plana area is inflated with the high molecular weight visco after a cataract surgery, and the ciliary processes are ablated with the help of laser. The endpoint is just the ablation of cyclodestructive. There are various pharmacological therapies, and netarsudil, which is a Rho kinase inhibitor, has been the newer additive in the armamentarium. Gene therapy is involving introduction and removal of altered genetic material into the cells. This have come from the last 15 years, but the last few years there have been viral and non-viral vector gene delivery systems that have targeted the particular target sites, and there are several studies that have come up. And the key limitation here is these cannot reach the target cells of the fetus. Plus, developing a relevant pharmacological drug target with excellent pharmacological benefit and low off-target side effect is quite challenging. So the future direction is using a personalized medicine with advanced imaging technologies and the futuristic MIGS, that is the future of glaucoma therapy, along with the robotic-assisted surgery, genes and cell therapies, and using artificial imaging and predictive analytics and telemedicine is the way forward in treating glaucoma. And early diagnosis is quite crucial with visual rehabilitation in achieving better outcome in such eyes. Thank you.
Thank you, Dr. Shastri. What is, in your experience now, about what percentage of cases would you still do the traditional trabeculectomy with trabeculotomy with the Professor Ham spatula? Yeah.
I've done 70% of my cases now. I still do a conventional surgery, but the newer surgical techniques have been still evolving.
Okay.
So I've done a few of congenital glaucomas with MIT, that is the microincisional trabeculectomy. The results are good.
But 70% still remains
Yes,
the gold
yes,
standard.
yes.
Okay. Thank you.
Thank you.
There are no other questions. I invite Dr. Usha Johari to talk about the Global Vision Brain Alliance for CVI, cerebrovisual impairment. She is a consultant ophthalmologist at the Hiranandani Hospital at Mumbai.
A very good afternoon to all of you, and special thanks to the local organizer of Dr. Qureshi Maskati and Dr. Dadia for giving me this opportunity. So, the eye problems in developmental disability is not very commonly looked by the ophthalmologist. What to look for, what to do, and when to follow up is a big question mark. And I've just started this work a few years back. And you'll all agree with me that the pediatric eye care services are not adequate in our country, most probably because they're neglected, they're missed out, and they're ignored. So the poet says eye is a window to soul, but in my opinion, the eye is a portal to brain, and it's also a tail and the window to the brain. The visual connectivity and the brain connectivity are so intricately connected that it is surprising to know that the 60% of the human brain is related to visual acuity and 40% of the brain for processing and supporting vision, which was mentioned by Nakoyama way back in 2012. So the vision loss is not just brain related, but it's not just eye related, but it's also brain related. So our aim here is to reach out, medical and the paramedical professionals, provide training in use using simple methods, and have a network of vision professionals. So the facts, you'll all agree with me, that 80% of the all learning takes place in the first 12 years of life, and only 1/3 of the children go to get an eye examination done in the school, and 60% of the students have learning difficulties which have undetected vision problems, and 1 in 4 school-age children have vision problems. So our objective here is to detect the ocular anomaly, record the visual capacity, treat the visual problems which are neglected, and overcome the visual handicap in time, and facilitate overall rehabilitation and development, and not to say nothing can be done. So it is surprising to know that the visual disorders are number 1 in childhood disability, and mentally and disabled children are twice likely to have vision problems. So how early can we detect these eye problems? We all know, as an ophthalmologist, the eye fixation takes place at 3 months of age, binocular single vision fusion and stereopsis at 7 years of age. Visual system in infant is, of course, very dynamic and sensitive, and we have classified them into reversible, partially reversible, and irreversible, which partially and reversible are almost 100% correctable. Now let's look into the irreversible problems where our friends visual rehabilitation people play a very important role. It's because we detect this at a very, very late stage of life. Incidence of visual loss in developmental disability. Peter Black carried out a study where 80% of the children had eye problems, only 20 were normal. But see our statistics, where we carried out a study on 59 children, and 91% of these children had eye problems. So the question here is, can this be incidental? No. And another interesting thing that we noticed was many children had multiple eye problems. It was not just one eye problem. So the question again comes here is, can we make a difference to the lives of these many children and families and maximize their visual potential? It's so simple. Spectacle therapy. Imagine a child having impaired mobility, impaired communication, and over and above that has an impaired vision. These children could be requested by the parents, could be requested to wear the glasses. And of course, there is a best visual outcome if the glasses are worn early. And why will the child not wear the glasses if the child can perceive things around the world, around the child easily? Refractive cycle. Hyperopia, which normally reduces in a child, is retained in a child with cerebral palsy. Astigmatism is also retained. And one other interesting thing is the accommodative disorders, which normally at the age of 40, it appears in a child at the age of, at the childhood age. Accommodation disorders, as we all know, is not just within the eye, it is beyond the eye, and a special attention has to be drawn towards accommodative disorders. So these children have inability to sustain the accurate focus, and they do need reading glasses. Strabismus, the studies which were carried out found that in the normal population, only 3% of the children had strabismus, whereas in cerebral palsy, 46% of the children had strabismus. It was not just because of the muscles in the eye, it was because of the lesions in the subcortical, oculomotor, and the cerebellar area. And the severity was proportionate to the cortical visual impairment. And it's not always due to refractive error or the muscle imbalance. Look at the slide with an eye and the postural abnormalities. Even these children have eye problems because of the retrocaspatic damage of the visual system. Irreversible problems, which is very close to my work which I'm carrying out. Cortical visual impairment, which is where our visual rehabilitation plays a role. We as ophthalmologists have a very limited knowledge about this. So the vision involved and the processing involved are the two aspects. With the occipital lobe, we mainly focus on the occipital lobe, which is between the eye and the occipital lobe, which takes the messages, which is an input system, but we always tend to forget the processing which is involved, where we have the occipital assessed areas like the frontal lobe, parietal lobe, and the temporal lobe. So in a child with cortical visual impairment, the eyes are normal, the vision has fallen down, all the ocular findings are normal because there is a lesion in the lateral beyond lateral geniculate body and at the lateral geniculate body up to the visual cortex. So the CVI is not a new entity. It was introduced way back in 1990, and this is a small functional vision map which shows the roots as the two eyes, the visual pathway which is between the trunk to the occipital lobe, the dorsal and the ventral system with the two branches, and the clusters of visual difficulties which are the branches of the tree. So basically there's a breakdown between the eye and the brain. Now the causes of CV are many. Let's not go into the depth of it. But as I explained to you, it's a damage or the malfunction of the visual pathway and lateral geniculate body, including the optic radiations, occipital cortex, and the visual associated areas. So the dorsal stream, which is the posterior lobe, basically when it helps us to locate the components in the visual scene and gives attention to it, and especially the inferior field is affected when the dorsal stream is affected, and it also helps in visual guidance, whereas the ventral stream, which is at the temporal lobe, the blue area, helps in recognizing the face, shapes, letters, and the alphabets. So the visual part of the visual brain is basically two parts, the dorsal stream and the ventral stream. So in the dorsal stream, when there is a damage, there is a difficulty in getting around, like using the stairs, sidewalks, reaching forward or grabbing a drink. So it helps, when there's a damage to the dorsal system, there's a difficulty in moving in the space. And when there's a damage to the ventral system, there's a difficulty in recognizing face, objects, and places. Now the frontal cortex, which is a light orange area, it allows planning. The frontal area field create eye and hand movement to look at the head movement, to look at the motor cortex, and thus the motor cortex helps the body to move with the response. This is a very important wiring system where I have mentioned that the occipital cortex helps in seeing, frontal cortex helps in thinking, dorsal and the ventral stream helps in processing, and it is connected with the frontal lobe, which helps us to create an action. This is the importance of CVI. So these are the few symptoms of CVI. They have difficulty in remembering things, imagining things. They are difficulty in fast movements, using vision to move the parts of the body, recognizing objects, eyes getting tired, visual loss, and so on. These are few articles that are published. So in my opinion, it's not just the role of an ophthalmologist, it's a multidisciplinary specialties where we could proudly say that we alone cannot do anything. We require these specialists, and the questions to be answered is, can CP be detected in pregnancy? Maybe, may not be. So let's not tell our children that nothing can be done. We let us suspect, detect, and diagnose at an early age, catch them young and catch them at a very early stage. So the take-home message is awareness of visual ability, disability is nil. Awareness to the associated ocular problem in developmental disability with help of visual rehabilitation will go a long way for a better quality of vision. And awareness is like a sun. When it shines on the things, maybe they're transformed. Thank you very much for your attention.
Thank you, Dr. Usha, for throwing a lot of light on something which most ophthalmologists themselves are not very aware of, and putting it in the spotlight and highlighting the fact that we need a huge team approach to tackle these difficult children. Thank you.
Thank you very much.
Any questions from the audience? We can allow one question. Thank you very much for your excellent talk. And we'll move on to the next talk. The next talk will be delivered by Dr. Rajat Mohan Srivastava. We'll talk about screening visual and ocular disabilities.
Namaskar. At the outset, I would like to thank the College of Ophthalmologists of Sri Lanka, Kureti sir and Dadia sir, for giving me this opportunity to present my talk here. And I would like to extend my greetings to the society for a grand success of this conference. I think listening to the previous few talks, this topic becomes even more pertinent. And what I'm going to discuss in my talk is that I'll be going through some of the common methods which we use for screening these children. And what we want to assess is to come up with an appropriate method for these children. I do not have any financial disclosures. So we already understand that visual impairment and amblyopia are pressing concerns. And often what we realize is that the underlying problem is sometimes uncorrected refractive error, which goes undiagnosed. And this is more so, as ma'am just said, in children with neurological disabilities, they are even more underdiagnosed. So what it leads to is that not only compromises the quality of life in these children, but it adds to the socioeconomic burden of the society. So what do we need to do? A simple approach is to just perform a good and appropriate timely screening of these children and maybe prevent severe visual impairment or amblyopia in these children. So how do we go about this screening? When should we screen these children? One of the earliest time, I think the screening must start as early as at the time of birth, that the child should be screened by an ophthalmologist. And thereafter, whenever the children visit for their immunization visit or go for a school entrance, they should undergo a screening. If it is feasible, I would recommend a periodic screening in school or in community so that we can pick up these children as early as possible. What I believe is that a pediatrician's clinic provides a very apt space where if you can perform opportunistic screening of these children, we may be able to pick up even more children who are at risk of developing amblyopia or severe visual impairment. Now, what do we need to actually screen for is simply any significant refractive error in the eye or any media opacity, or if we can pick up any any misalignment of the visual axis in these children. So how do we go about it? Screening can basically be classified into two main categories: the traditional method where we use the visual acuity assessment, or the device-based method. Now with the upcoming of the devices, it has really changed the landscape of screening children. Traditional visual screening is by far the most commonly used and is cost-effective method of screening children. It can be performed in various settings, right from our clinics to classrooms to even community centers. So that adds to the versatility of this technique. But what do we often see is that when we screen children using the traditional method of visual acuity assessment, they are not very reliable. The inherent subjectivity of the responses and of the examiner, it is often difficult to actually know how much is the visual disability in this child. And getting a good assessment of what the visual acuity in a young children is actually difficult in these children. So that And we know that our primary target is to assess these children. So if we are not able to assess them correctly, then it totally undermines the practical approach of this kind of screening method. So we have devices. Now just to put a brief thing, we have two major type of devices. One of them is a photo screener. What it basically does is that it takes images of both the eyes and captures the red glow images and analyzes the Bruckner reflex characteristic. And on the basis of the algorithm, when it tries to analyze these red images, it tells whether the child is at risk for developing amblyopia or not, and then it screens. And what our autorefractor actually does is just it just objectively assesses the refractive error in these children and tells us whether it requires further treatment or not. But you see, the main advantage of these techniques when it compares to the traditional method is that they are very objective in their assessment. So it circumvents the subjectivity which is involved in the traditional method of examination. Not only are they quick, but they also provide us with objective, useful information which increases the quality of our screening. But in spite of all these advantages, the pasture is not completely green here either. One of the major drawbacks when using device-based screening method is the cost and the availability of these devices. And at the same time, we must remember that these technologies are still developing. So what happens that the result which you may obtain from one particular device may vary from the other one, and that would add to the confusion. So you may not have a complete idea about what the problem is, even with the help of these devices. Now what we see is that apart from these devices, smartphone use is actually coming. It is a very unique and upcoming way of screening these children. Smartphones are ubiquitous by nature and are very easy to use. And that makes them an ideal screening devices. In fact, one of the studies which we performed was that we captured the red glow using these smartphones in school children, and we compared the outcome of screening with the traditional method of screening. And what we realized that when we assess the red glow remotely in our colleges, we could do a better screening compared to the traditional method of screening. So that was very encouraging for us. And now we have app-based screening methods like you have got the Go Check Kids app or even the Apollo Infant Sight app. These apps are upcoming and they, I'm sure, will help in further improving the screening of these children using the smartphones. So that shows that the use of devices is going to come up more and more for screening these children. So does that mean that device-based screening is actually superior to the traditional method of screening? Well, the jury is still out. What we can say clearly at this point of time is the device-based screening method is recommended in pre-verbal children, and that too in the developed world, where you have some insurance support to bear the cost. We have also seen that especially some studies in India, it shows that if you have got children with neurological disabilities, device-based screening tends to be beneficial in those things. But the gold standard says that you must always try to have an objective, accurate assessment of the visual acuity as early as possible so that you can truly pick up the case who requires further management. So, when it comes to screening, do we need to use all these methods? Which one is the best for us? That is what we need to know. And I think here the thing is that your choice of screening modality depends upon what is your requirement and how feasible that thing is. For example, if you are a pediatrician, let's say, you need not have all these things to screen these children. All you need is just assessment of the red glow, a fixation pattern, or maybe use a simple E-chart to know some idea of the visual acuity, and you're done with your screening. Or if you are an institute wherein you can afford to have devices, then you may use these devices to have better screening of these children. So it is very customizable. At an individual level, what I would suggest is that developing a skill for analyzing the red glow of these children is a good skill for screening these children. And when you combine the red glow analysis along with the fixation pattern and a quick torchlight examination, you can truly screen a lot of children even in busy clinics. When it comes to community examination for a screening of large population, I would suggest, I truly believe that smartphones, they have a huge potential. Once the algorithms get a little more refined, these would be the devices in future to be used for mass screening. Until then, my message is that you can rely upon the traditional method of visual screening assessment, which is going to work for most of us and at least will help us screening and picking up these children as early as possible. Thank you so much.
Thank you, Dr. Rajat. Are there any questions on visual screening? If not, I invite all the speakers to come to the stage for a group photograph. Dr. Kamalji, Dr. Usha, Dr. Shastri.
Dear colleagues, welcome to this session. We'll immediately start this session. This is the first time the APSPOS, Asia Pacific Paediatric Ophthalmology and Stability Society, which is a society representing Asia Pacific, I would say. It is a great honor, the first time APSPOS joining the Sri Lanka meeting. I'm deeply thankful to Amala for the very kind invitation and a lot of hard work efforts put in to making us joining together. And I'm deeply honored. I'm representing APSPOS. I'm the Secretary General of the APSPOS, Jason Yan from Hong Kong. Today, we have a meeting composing various topics. Here with me is Professor Saurabh Jain, Professor of the UCL Medical School, and we are chairing this session. And I will pass the mic to Professor Saurabh Jain to start the symposium.
Good afternoon, and thank you so much for inviting us. It's a real pleasure to be back in beautiful Sri Lanka and to have a Pediatric Ophthalmology Day. So what we're going to try, and it's great to start early. I mean, that's the first for me, so that's fantastic. So we're going to start with Frank Martin, who is a professor at the University of Sydney, and he's going to talk to you about when do we need to perform imaging in sudden onset strabismus and pediatric nystagmus. So this is going to be the only virtual talk of the session. So over to Professor Martin.
Thank you, Sir Brian and Jason. My topic is when do we need to perform neuroimaging for sudden onset strabismus in children and in pediatric nystagmus. Let's look at two quotations. Science, my lad, is made up of mistakes, though mistakes which it is useful to make because they lead to the truth. And from Thierry Henry, you learn from your mistakes. Well, on this topic, I can honestly say I have learned from my mistakes. Let's look at my first case, Harry, a 4-year-old referred to me for a second opinion. He developed left esotropia at the age of 6 months. He attended an ophthalmologist, found to be hyperopic with astigmatism. A diagnosis of accommodative esotropia was made. He was prescribed glasses, which have been worn full term. Part-time right occlusion of 2 hours a day was commenced, and despite occlusion, his left vision has not improved. His parents, in his history, said quite clearly that he's clumsy and unsteady on his feet. I examined Harry, found vision of his 6 on 7.5 and 6 on 36. He had a part accommodative left esotropia with poor left fixation. Eye movements were normal. I checked his refraction, no different to what was found by his ophthalmologist. And retinal examination found the optic disc and retina of both eyes to be healthy. I advised his parents that I agree with other ophthalmologists' diagnosis and management. I recommended continuing with glasses. I increased right occlusion to 4 hours a day. I arranged to review Harry in 3 months. And I indicated to his parents that if his left vision had not improved, I would arrange for investigations. 1 month later, I received a telephone call from Harry's dad. Harry has been admitted urgently to hospital. He has bilateral papilledema. He's had an MRI. He has a glioma. So what were my mistakes? First of all, I ignored that despite good compliance with part-time wide occlusion, there was no improvement in left visual acuity. And secondly, I ignored the history that he is clumsy and unsteady on his feet. So when do we image a child who has sudden onset strabismus? We image the child if from the history there are any neurological symptoms: headache, vertigo, diplopia, nausea and vomiting, reduced coordination. And from our examination, if our clinical examination does not explain the reason for the strabismus, like with Harry, we thought hyperopia explained it, but it didn't. If the child has neurological signs, cranial nerve neuropathy, pupillary signs, associated nystagmus, optic nerve problem, papilledema or atrophy, or if the child does not fit a clinical pattern, Harry's vision did not improve with patching. Let's look at my second case, Natalia. Natalia was referred to me at the age of 4 months by a paediatrician. Natalia had very poor eye contact. Parents doubted if she could see. Nystagmus had developed around the age of 6 to 8 weeks. Development was normal. There was no family history of nystagmus of any other ocular problem. I examined Natalia. I noted that she was a very fair child. She had poor visual responses. I thought perhaps she looked at light. Horizontal jerk nystagmus. I couldn't perform an adequate slit lamp examination to look for transillumination. Refraction was age-appropriate hyperopia. I considered the optic discs to be normal, and I noted that she had blonde fundi. I made a provisional diagnosis of possibly ocular cutaneous albinism, or could it be congenital idiopathic nystagmus? I questioned it, and I didn't really make a definitive diagnosis. I arranged for review in 4 weeks. 4 weeks later, Natalia returned. Her vision was still extremely poor, and there was no change in nystagmus. As I was examining her, I noted she had a bulging anterior fontanelle. I looked at her fundi, and she had pale, swollen optic discs. I arranged urgent neuroimaging, and Natalia had a large optic glioma involving both optic nerves and chiasm. I reflected as to what mistakes I had made. Well, first of all, from the history, I overlooked poor vision and didn't really focus on it. She had unexplained nystagmus. So these were the two things that I should have focused on more when I saw Natalia, and I should have organised her MRI at the initial consultation. So when I consider nystagmus in the paediatric age group, I divided into infantile nystagmus syndrome, which we used to call congenital nystagmus, but it's not truly congenital, as the nystagmus typically comes on between 6 weeks and 4 months of age. And then we've got acquired nystagmus, which can come on at any age. What's the etiology of infantile nystagmus syndrome? It can be due to ocular pathology causing various degrees of visual impairment. It can be very obvious, bilateral dense cataracts, optic nerve hyperplasia, retinal dysplasia, or it can be subtle, a retinal dystrophy, or something further back along the optic nerve. There can be neurological abnormalities with or without ocular pathology. Then we've got the so-called isolated inherited or idiopathic ocular motor disorder. This was what we refer to as congenital idiopathic nystagmus. And then there are other causes which should be obvious, like albinism, can be vestibular, which is nystagmus often worse in the dark than light, syndromes like Joubert's, Downs, systemic disorders, disorders of glycosylation. And then we have the special types of nystagmus. These often are acquired. We have seesaw nystagmus. This is a localizing sign of something in the rostral midbrain. We have convergence retraction nystagmus, a localizing sign of something in the dorsal midbrain. It can be opsoclonus, which is not a true nystagmus, but can signify a neuroblastoma. It can be vertical, downbeat nystagmus in Arnold Chiari or with sedatives, monocular, then dissociated nystagmus. Diffusional maldeveloped nystagmus syndrome, late nystagmus, is a benign condition. And then there's vestibular nystagmus. So when I see a child with nystagmus, how do I assess this child? I ascertain, does the child have good vision at near or not? If there's good vision at near, it's almost certainly going to be congenital idiopathic nystagmus. This is a diagnosis of exclusion. A child with poor nystagmus, there'll be some pathology somewhere from the front of the eye to the chiasm. Or acquired nystagmus? This child must have some form of pathology. The history and clinical examination will allow you to make a diagnosis in 90% of patients. So when do we perform neuroimaging in pediatric nystagmus? If the etiology of nystagmus is not detected at clinical examination or with ancillary testing, image all children with acquired nystagmus and image all children with special types of nystagmus except for those with latent nystagmus. So what have I learned? Listen carefully to what the parent tells you. Do not ignore any suspicious symptom or sign, and have a low threshold for neuroimaging a child about who you have any concern. Thank you. I'd like to invite all of you to attend and participate in the 3rd Congress of APSPOS next June in Brisbane. Come and enjoy the sunny weather. Thank you.
So Dr. Martin will be joining us online, so you'll get a chance to question him directly. So we'll move on to our next speaker, who is Dr. Yan, who is a clinical assistant professor from the Singapore National Eye Centre. We're going to talk about the pre-myopia management, a new paradigm.
Okay. Good afternoon, everyone, and thank you for the kind introduction. It's a pleasure to be here. So today I'll be speaking on pre-myopia as well as is it a successful paradigm shift in terms of preventive therapy. So in general, the issue that we are facing right now is that myopia is an increasing trend, and as we know, 50% by 2050 will be myopic and 10% will be highly myopic. So these figures have been re-emphasized multiple times already, but what is the main issue is that all these patients, in the end, they are still myopic. And as we later will know, as patients get more and more myopic, the higher the risk there is. So now there's another thought, whether we can even prevent them from reaching the myopic stage. And that's why now there's more thought being put in to suggest that whether pre-myopia is actually a viable choice. So, as Prof. Mark Bullimore has published in his landmark paper, that every diopter counts. With every diopter build-up, it results in either, depending on the denominator, it results in either a 30 to 60% increase or decrease in the risk of developing sight-threatening complications such as myopic macular degeneration or things like retinal detachment or Lanka cracks. And hence, it might not be just sufficient to slow down myopia per se, but actually try to prevent the onset in the totality. Right. And so what are the options right now that have been investigated? So first one would be lifestyle choice, which is more outdoor activities, 2 hours per day under the light. But other interventions include things like atropine eye drops as well as low-level red light repeated therapy. And so the first one was actually published by Prof. Yem back in 2023. So this is the most important one so far to date, where he looked at the use of the low concentration atropine, whether it was successful in preventing the onset of myopia through the LEM2 study. And so from there, the results, we can see that there's actually significant protection or a retardation in terms of the myopia development. And as you can see, compared to placebo and atropine 0.01, it's the atropine that 0.05 that shows a significant reduction, about 50% compared to the control rate. So with a control at 53%, what we get is actually reduction to 28.4. So in general, it means that about 1 in 4 children will still develop or progress to myopia compared to about 1 in 2. So generally, we are saving about one out of 4 children for everyone that we treat. And this is so for a population age group of 4 to 9 years old over a course of 2 years. All right, and so that was significant. And the next one is that preventing a fast myopic shift is a rather stringent guideline over here. That was the definition, which was 1 diopter over 2 years, which it equates to at least 0.5 diopters per year. So that's a bit more stringent, but in that sense, it still prevents about half of them, actually it saves half of the children from being fast myopia into a slow myopia progressor or even non-progressor. And again, compared to atropine 0.01 and the placebo, the 0.05 is the superior the product. And this again is translated for axial length elongation, where from 0.7 it is reduced to 0.48 millimeters. And in that sense, if we divide by 2, it's about 0.24 millimeters per year. And for the age group of 4 to 9, that's a pretty acceptable rate of elongation, especially with normative data coming out from places like Taiwan and China, that we know that 0.24 mm in this age group is pretty acceptable. Right, and so that is also significant. So earlier on, in a slightly different context, Prof. Wu Wei Chang from Taiwan also looked at this pre-myopia management, and this was about a decade plus ago, where he used atropine 0.025. So as we know so far, the 0.01 doesn't seem to have significant impact on the protection against pre-myopia. So looking at 0.025, it is another alternative that's available. So as we can see, again, it's about half reduction or so, from 54% of a placebo to 21% over a 1-year incidence. Right? And these are for patients of the pre-myopia range defined between minus 0.5 to plus 0.5. And same thing we see for the fast myopic shift, that it can drastically reduce from 58% to 8%. And similarly for spherical equivalent, we can see that it's a reduction of a minus 0.14 diopters versus a minus 0.58 diopters. So quite a significant reduction against the placebo cohort, though knowing that this is only a small retrospective cohort as compared to the LAM2 study, which was a larger prospective trial over 2 years. And the last one that has been just been published last year is by Prof. Herming Kwang, which looked at the effect of repeated low-level red light therapy for myopia prevention, and that's amongst children in China with pre-myopia. And because it was conducted during the COVID period, so it was split into 2 groups. One that is totally without COVID interruption, where they could come back for repeated follow-up, and the second group, which is a totality of the all group of average for all those under treatment, where some had interruption and some did not have interruption compared to the control group. And again, we can see that with treatment, with the low-level red light therapy, it actually reduced the progression or preventing myopia development significantly from about 61% to 40.8 or 28.1%, depending on which group we are comparing. But even in the so-called a combined interrupted / non-interrupted group, it was still a saving of about 40% as compared to the control group, right? And this was across a 1-year period. So that was preventing the onset. In terms of axial length elongation, again, we can see a significant reduction from 0.47 to 0.24, which is quite similar to what the atropine 0.05 showed of a 0.24 millimeters per year elongation, which is within acceptable norm for this age group. And hence, it shows that there is significant reduction, and this was coupled with a slight increase in choroidal thickness. As you can see, 70% of the groups, they had some interruption, but even there, overall, there was a 3.0 nanometer thickness increase as compared to the control group, where there was a minus 9.2 decrease in the choroidal thickness. And this was again shown if spherical equivalent changes, and it matches what is observed with the axial length elongation. So again, it's a significant reduction, either within about 50% to 70+% to 80% sort of a reduction range compared to those who are under the control group. So it then has shown that it seems that both atropine 0.05, 0.025, as well as low-level repeated red light therapy can have significant effects in terms of retardation or prevention of developing myopia. However, special mention for the low-level red light therapy is that they've noticed that those who are between 0 to plus 0.5 tend to do better as compared to those who are the treatment group where they are already between 0 to minus 0.5. So if you look at the left side, the relative efficacy, that means prevention, is about 64% versus those who are between 0 to minus 0.5, which is only 14%. And that is again seen both for spherical equivalent changes as well as the axial length changes. So again, much more significant, it's important to prevent them from even getting below 0 at this stage, right? And of course, with red light therapy, there are of course some concerns due to the strength of the illumination. So 2 actually withdrew from the study because of after images, and whether the other intensities or duration of treatment is required or whether there's any long-term side effects, those are still unknown at this point. Right. So what else? So in general, now that we know that, okay, it seems to be pretty effective, then there are certain things that comes to mind with this set of results. So firstly, most of the children, they are investigated in the age range of between 4 to 9. So what about those above? And after 2 years, which is the longest study so far, is this effect, what happens after this? Is this effect sustained or will they have any acceleration, right? And again, all 3 studies are mainly conducted in the Chinese population. What about the rest of the non-Chinese Asian population? Will we see a similar trend or protective result as well? In terms of forms, so far we have is 0.05, 0.025, and shown that 0.01 doesn't work. What about other availabilities like 0.125 or even 1% atropine? As well as the newer modalities like Deems Halt. If we were to give a plano form, because right now they don't really have the hyperopic form, if we give the plano form, does it really help? Of course, then next comes the reliability of the products, reliability of the results. Can it be reproduced? And what is the real-world benefit? Is there significant side effects? Are parents willing to entertain? And so translating into clinical practice right now, what we know is that we have the results now, all right? Someone has thought about it, there's the result, and then now we need to convince clinicians to adopt this new form. However, how do we get parents to actually come in with their children? So there needs to be a patient journey at this stage. So it needs to go through a few things like increasing awareness, school triaging, such that, and then informing parents so that they can then bring their child in for further assessment, right? And so at this point in time, my last few slides, these are possible scenarios that can be thought of where a child can actually benefit from such pre-myopia treatment. So one where one side is slightly hyperopic and the other eye is already myopic. One where there's significant family history, such as siblings as well as parents having significant myopia, or those where they are significantly progressing at a faster rate even though they are not at the myopic range yet, from their hyperopic reserve is gradually significantly decreasing. And though the last option where someone just suddenly steps into a room with their highly hyperacute, hyper-aware parents, however, that is still currently under a very rare occurrence so far. So to end off with a case study, so this is a particular patient that's seen in clinic, 5-year-old child with a 0.25 and a 0.5 hyperopia, cycloplegic refraction. Elder sister is already having, is a 9-year-old already on atropine, and very anxious parents with moderate myopia. And they're working, usually leaving the child to be with the grandparents, and usually grandparents will indulge them with near electronic gadgets. So we can see that there is a high myopia risk profile in this, and current risk of myopia sequelae, not really, because he's still in the hyperopic range, right? He's a pre-myope. So what are the options, and where is there significant risk? All those are still in their favor. However, after this special discussion with the parents and long-term long consultation, overall parents still decide to go for careful monitoring. So to summarize, pre-myopia management is now a new thought form. Is it a paradigm shift yet? Maybe not, but it takes time for clinicians to buy into the results, for more results to come out, and then subsequently then maybe we can then convince parents whether this form of a treatment would be effective for their children. Thank you very much.
Thank you very much. Do we have any questions? Okay, if you think of any, we'll get the panelists back. Thank you very much. That's a fantastic lecture.
So we have our next speaker, Dr. Jeremy Hu, consultant ophthalmologist, National Healthcare Group Eye Institute, Tan Tock Seng Hospital from Singapore. He will share on the low-dose atropine in myopia management.
So today, my topic for today will be low-dose atropine in myopia management and how I apply evidence-based medicine to my practice. So for the purpose of today's discussion, we have a young child who is diagnosed with myopia, and the mother is keen to start on atropine eye drops. So as a practicing ophthalmologist intending to start atropine for myopia management, here are some questions that one may ask. At what age should I start patients on atropine? What concentration should I start with? What should I do if myopia progresses while on atropine? And when should I stop? So I shall share with you how I use evidence-based medicine to guide my practice. To start, myopia is characterized by excessive axial elongation due to increased vitreous chamber depth of the eyes, causing light to focus in front of the retina, and historically thought to be due to excessive accommodation leading to myopia. Hence, atropine was used as it paralyzes accommodation. And trials done decades ago showed it performed better than placebo. However, it was found in animal studies subsequently that there are actually non-accommodative mechanisms at play. Hence, the exact mechanism of how atropine works is still unknown, but we know it modulates biological mechanism, mainly in the retina and sclera. So there's a paradigm shift following the publication of ATOM2 study, in which 400 children were randomized into different concentrations of atropine. Originally, it was intended by the authors to have minimal placebo-like effect by diluting 1% atropine 100 times, and it was intended to be sort of a placebo in that study. But atropine 0.01 turned out to have a good efficacy on myopia control while maintaining minimal side effects. Hence, that kick-started the use of low-dose atropine in myopia control. Hence, when we first intended to start the patient on atropine, what are the considerations we should take into account? What age can we start them on, and who should have it? So looking at previous randomized controlled trials, most are generally done in the school-going age, usually hovering at the lowest about 5 years old, except for the LAMP study, who recruited 2 4-year-old patients. And with the LAMP study, they looked at the effect of age on treatment responses to atropine, and found that the younger the patient, the more likely they are to progress and they require a higher concentration to achieve a similar reduction as compared to older kids. So in my decision tree to determine whether to start a patient on atropine, I'll first determine if they have risk factors for myopia, such as age of onset, parental myopia, as well as if they have progression more than minus 0.5 diopter per year. And then subsequently, if I decided to start a patient on atropine, the next question I'll ask is what concentration should I start them off with? And to answer this, we need to figure out whether there is indeed a dose-related response to atropine for myopia control. So looking at the 2 randomized controlled trials in the ATOM2 study, if we were to look at the third column there, the ATOM2 study, the different concentrations perform rather similarly in terms of the progression, myopia progression over 2 years, whereas in the LAMP study, there is a dose-related response. So in face of these 2 contrasting results, we looked into a network meta-analysis to try to answer this. And to start off, atropine at any concentration performs better than no treatment at all. So that's atropine definitely works. But then at what concentration, if we look across the different concentration and look at the overall myopia progression, it seems that the dose-related response is less clear. If you will look at the last column there, the 0.05 seems to perform almost equivalent to the 1% atropine. But the side effect profile follows more of a dose-related response, in which is a stepwise progression in the pupil diameter as well as the accommodative amplitude. So the authors conclude that the 1%, the 0.5%, and the 0.05% atropine were the most efficacious in myopia management. So the recommendations by the AAO in 2017 recommended starting off with atropine 0.01, but the recent updated WISPOS myopia consensus statement in 2023 stopped short of giving a specific concentration to start off with, but instead summarized the different efficacy of atropine concentration. They also note that there's about 10% non-responders despite high-dose atropine. So then, that leads us to the next question. Suppose that the patient we started on 0.01, and what should I do if they still continue to progress? So most randomized controlled trials look at treatment-naive patients and put them on over different concentrations of atropine to determine their response. However, I'm not too sure whether it's the same response you get with patients who are already treated on lower dose atropine. Does higher dose atropine actually perform similarly in this cohort of patients? So when we look at the ATOM and the LAMP study, we can see about 20% of patients who are on 0.01% still progress over more than 2 diopters over 2 years. So without any good RCTs to answer this, we looked at our own unpublished internal audit results on children who were switched from 0.01% to 0.05% due to myopia progression. So in our center, we carry these 2 particular doses, and patients who progressed while being on 0.01 was switched to 0.05% if they progressed. The definition of progression is left to the treating physician, but here it's the overall real-life experience. The mean age of atropine 0.01% in our cohort of 123 patients were around 8 years old, and they were switched to around 10 years old at 0.05%. So subsequently, there's an increase of around minus 1.5 diopters over 2 years in which they were on the separate 2 eye drops before they were switched. And the mean cervical equivalent change while on atropine 0.01% was about minus 0.9 diopters, and while they are on minus 0.05, or they were on 0.05% atropine, they progress only a minus 0.3. Of course, this is not a robust RCT, and there are inherent confounders within it, but this gives a real-life perspective of our own experience. So then, with that, comes the next question that we will try to answer. When do we stop atropine? So first, we need to determine what happens when we stop atropine. So in the ATOM studies, they show that the higher the concentration of atropine the patients were on, that there's a higher risk of rebound. So if we look at the first graph over there, at the top left-hand corner, where the atropine was 1%, okay, here. So this graph shows the 1% atropine. It has the best efficacy in controlling initially, but when they will abruptly stop here, there's the highest risk of rebound as well. So this follows a stepwise, it is also a concentration-dependent response. So the higher the concentration of rebound happens when you stop atropine with a higher concentration abruptly. So this is similarly replicated in the LAMP studies, although the effect was less and it's less significant in the LAMP studies, but also they do see a rebound effect when atropine was stopped suddenly. So with the ATOM-2 study, we were to look at the washout phase where the patients was stopped atropine abruptly for a year, and then they were retreated if they were have a progression of minus 0.5 diopter in 1 year with an atropine of 0.01%. So if you were to look at the graph here, if they were stopped at less than 8 years old, nearly 62% of them requires retreatment. Whereas if you were to stop them much later, in the teens, then it drops down quite drastically to 8%. So with that, my decision tree on whether to stop the patient on atropine is based on the following key considerations. Firstly, it will be the age of the child. Usually I tend to stop them when they are in the teens and when their myopia progression has stabilizes, and if they are on a higher dose of atropine, I will tend to taper rather than to stop abruptly. With that, thank you.
Thank you. Do you have any questions for Jeremy? Dr. Hu? Okay, can I ask you a question, if that's okay?
Sure.
So, do you measure the axial length in these children, and if so, how does that feed into your protocol?
Yes, we do measure their axial length. So we tend to look at them in terms of when I should decide to stop atropine. So once their axial length has stabilized, not increasing more than 0.2 per year, and then I tend to start to think of stopping them. Yeah.
Thank you very much.
Thank you.
Okay, so I'd like to welcome Dr. Lilian Fu, who's a consultant ophthalmologist at the SNEC in Singapore, to talk about some real-life clinical cases in childhood myopia management.
Thank you, Dr. Jen, for the very kind introduction. Thank you, everyone, for taking your time to join us in this segment of the symposium. I also like to take this opportunity to thank the organizing committee, Dr. Sonel and Prof. Yang, for the kind invitation to be here. Today, I'll be presenting on clinical cases in childhood myopia management. I'll start off with a clinical case. It's a 5-year-old Chinese, parents with high myopia and not wearing glasses at this point in time, 5-year-old child. So parents are keen to delay the onset of myopia, and this is so because we know that the earlier the onset of myopia, the higher the risk of high myopia later on in life. And so this child presented with a visual acuity of 6.6 in both eyes, and on cycloplegic refraction, we found that he is low myope of plus 0.25 on the right and plus 0.5 on the left-hand side. Otherwise, the rest of the examination is unremarkable. So the million-dollar question here is, how would you manage this child at this point in time? Will you A, go for monitoring, B, advise for more outdoors time, C, provide single vision glasses, or D, start atropine eye drops? So in this case, I managed by advising more outdoor time, and I'm going to share with you why so, based on the evidence-based approach. So based on this IMI paper, Prevention of Myopia and its Progression, what it has been reported was that every 2 hours spent every day reduced the odds of developing myopia. And also, the odds reduction for every additional hour per week is 2%. And outdoors time has also been shown to reduce the axial length progression risk. So we move on with the same case, but now 2 years later, the child is 7 years old and they are working parents, so they are unable to fulfill the outdoor requirements. Difficult to take the child outdoor to spend at least 2 hours a day. At this point in time, when we examine the child, he has developed low myopia, minus 0.5 on the right, minus 0.75 on the left. So during cycloplegic refraction in clinic, we also found that the child has anxiety towards putting in eye drops. So parents also learn about a specific myopia control spectacle lenses. So we move back to the million-dollar question. How would you manage this child at this point in time? Low myopia in both eyes. Will you give single vision glasses, bifocal glasses, progressive glasses, or none of the above? So in this child, we shouldn't give any of the above from A to C. And why so? Because currently, as technology advances, innovations, there are myopia control spectacle lenses that can slow down myopia progression And this includes the defocus incorporated multiple segments glasses by Hoya. There's also a highly aspherical lenslet technology that was published subsequently by Essilor-Stellus. Also, there's cylindrical annular refractive element spectacle lens by Zeiss, also known as the Care lens. And up next, there will be diffusion optic technology that utilizes the decrease in contrast sensitivity. As you can see, once the lens is over the eye, there is decrease in contrast sensitivity, and this has been shown to also help slow down the rate of progression as opposed to the earlier three, which works by peripheral defocus technology. So this child, another 2 years later, now he should be about 9 years old. Yes, he is now the school basketball team captain. He would like to consider contact lenses because sports difficult to wear glasses when they play sports activities. So on examination of this child, he is currently -1 diopter on the right side and -1.5 diopters in the left eye. The rest of the ocular examination is otherwise unremarkable other than some slight increase in axial length progression. Again now, this child is 9 years old and would like to consider contact lenses. Would you give single vision soft contact lens? B. Prescribe rigid gas permeable RGP lenses for the child. C. Autokeratology lenses. Or D. Dual focus contact lenses. So in this case, you can manage by either auto-K or dual focus contact lens. And why so? Same thing, we go by an evidence-based approach. So there are soft contact lenses now in the market that can help to slow down the rate of myopia progression, and these are daily disposable lenses, can even treat up to -10 diopters of myopia, and even with astigmatism. I mean, personally, clinically, I even can treat up to close to 2 diopters of seal without having any significant blurring of vision, despite it being a non-toric soft contact lens. It's advisable to wear about 5 to 6 days a week, about 8 to 10 hours a day. Auto-K has been long-standing, has also been shown to help to slow down the rate of myopia progression. Usually advise the child to wear at least 8 hours to sleep. So now the child is 11 years old, taking major examinations, would like to counter the excessive near work because examinations-wise, they tend to read more, leading to progression. He is now about -2 in the right eye and -2.5 in the left eye. So 11 years old child taking exams have a lot of near work reading. What would you do? Wearing contact lens, remember he's a basketball school captain. Will you add low dose atropines to the contact lens? Add moderate dose atropine? Add high dose atropine? Or add blue light therapy? So in this patient, I managed by adding low-dose atropine eye drops. And what are the evidence you may ask with regards to combination treatment? There are currently a mixture of evidence in the literature that supports as well as disprove of combination therapy. So we start with 2019. It's a 2-year study, auto-K with atropine. And this study shows, a tick on the left-hand side, which shows evidence in supporting the combination therapy of auto-K with 0.01% atropine. How about in the year 2020? There's another trial, same thing, low-dose atropine with auto-K. And these studies also support the use of combination therapy, shown by a tick in the left-hand side as well. How about 2022? So now is comparing 0.01 atropine with progressive lenses as well as defocus of contact lens. However, this Edina study shows that there's no difference marked by a cross, adding 0.01 to either progressive or defocus of lens. So moving ahead, 2022, we have another study, poor responder to auto-K. Is there a use of adding 0.01%? Oh well, doesn't seem so. So it's a cross. Probably they are also poor responder. They also fast development and progression in terms of axil length. And 2022, she did a study comparing auto-K with 0.01%, and it's a tick. So there is significant improvement in terms of slowing down the rate of progression. Adinus 2022 did another study, defocus of contact lens this time round, not auto-K. So what he found that there's no significant difference adding 0.01 to defocus of contact lens. Palo 2023, he did a study on DIMS, which is the MyoSmart, with 0.01. It does shows that there is significant difference in terms of slowing down progression. And finally, 2024, Adinus again, he did another study, multifocal with 0.05 this time round. And what it shows, yes, it does have significant difference in terms of myopia progression. So after 2 years, the child has stable myopia. What will you manage? So first, the child is on low dose. Will you continue treatment, extend follow-up, taper atropine eye drops, or discharge the patient? So in this case, I managed by tapering the atropine eye drops. Rather than to stop completely, is because there can be risk of rebound, as we can see here. There is significant risk of rebound if we suddenly stop the atropine eye drops. Similarly, there is risk for rebound for axil length if we stop suddenly. I'd just like to finish the last few slides. How do we taper atropine eye drops? So we taper atropine eye drops in this case by tapering the frequency of the eye drops, cutting down the eye drops instead of every night, 6, 5, 4, 3, 2, 1, every 3 monthly. That's how we taper the eye drops. So I'd like to thank everyone for the very kind attention. Thank you very much.
Do you have any questions for Dr. Fu? Okay, great. Thank you. Fantastic presentation, very action-packed. So we've had some great talks on myopia, so we're going to top them all by Mr. Myopia himself, Professor Yam, who needs no introduction. He's a professor of ophthalmology at the Chinese University of Hong Kong and has published many landmark studies on myopia, and we're really delighted to have him with us today. Jason.
Thank you. Thank you, Sarab, for the very kind introduction, and I would like to thanks again Professor Amela for the very kind invitation for us to be here, and I'm deeply honored to be here. So today I would like to share about on the topic of cost effectiveness. The cost effectiveness of myopia intervention. So just to share some of our work that has been done in CHK, we do in Hong Kong, in the Hong Kong Children Eye Study, the Hong Kong Children Eye Genetic Study, and the LAM1 and LAM2 study. That the Hong Kong Children Eye Study that we have been doing now is already 10 years. Over the last 10 years, we have kept recruiting children from Hong Kong. Every weekend, we recruit 100 children, and with detailed questionnaires, detailed eye examination, and some biosampling. And we build up a biobank. Now have the children that we recruited, about 45,000 children and 90,000 parents. It's also a public health campaign that we go to the shopping mall, we go to the schools to do the screening, and we have recruited, involved a lot of eye doctors in Hong Kong, optometrists, nurses, medical students, nursing students. We've managed to publish a few papers, and also we have published the LAM1 study and also the LAM2 study, and we are very thankful for the funding that we obtained over the last 10 years. So today my topic is not just on the intervention but on the cost effectiveness. The reason is myopia prevalence keep increasing. By 2050, we will have more than roughly 50% of the whole world become myopic. And the impact of myopia, including the impaired vision and also the poorer quality of life, affect the learning ability, activity limitation, and emotion. And so, when we talk about the cost, there is a global potential productivity loss of a huge amount. And in Singapore has reported the annual direct cost is $25 million in Singapore teenager in the cost, and an individual lifetime cost is also a huge amount. So myopia progression has reported, mentioned by our dear colleagues just now. There's a various different interventions, including the spectacles, including the contact lens, red light therapy, pharmacological agents, lifestyle modification. So cost-effective analysis is a form of economic analysis that compares the relative costs and the outcome of different courses of actions. So it helps us to determine how best that we can spend the money for maximum quality and quantity of life. It also helps us to know the value that is in exchange of the resources. It is important kind of to help the policymaker on the economical benefits, on the intervention to reduce the disease-related mortality and morbidity. So we have in this cost-effective analysis, we have two models. One is simple decision analysis tree model, and the other is state transition model, is Markov model. For myopia, it is kind of chronic state, so we use a Markov model. And so myopia, the preference increasing, there's a high economic cost, there's increased demand for the services. In the limited resources, we believe a cost-effective analysis is important. That to tell the policymaker in how we can spend well on this treatment. So before the cost-effective analysis, we do a systematic review to understand what is the current literature knowing about the CEA of myopia management. And interestingly, it didn't have many papers. It only have one paper on the myopia progression with atropine 0.01%, 2 studies evaluating refractive surgery, and 3 papers evaluating on the myopic CMV with the injection. So with this, this is a summary of the systematic review of the cost-effective analysis of myopia management. Atropine 0.01% is cost-effective. The ranibizumab was cost-effective in the United Kingdom, and the Corbicet was more cost-effective than ranibizumab in China. So this summary let us know that in fact the cost-effective analysis of myopia intervention was unknown, and there's not many data has been compared to which cost-effective analysis, to which intervention is important. So therefore, we conduct a study to look into the cost-effective analysis of various myopia interventions and then in children. So what we do is we compare 13 myopia interventions in terms of the spectacles, in terms of the contact lens, pharmacological lifestyle intervention, and the light therapy. And we use a Markov model for this, and we incorporate the level into health state into low myopia, moderate myopia, and high myopia. And we use a hypothetical cohort of 10 years old children. And then we look into it for a period of 5 years. And so we include the cost, effectiveness, and the transition probability. So the cost in this study was mainly based on the charges in hospital authority in Hong Kong. So it is the cost may vary when we apply to various regions and countries. So this analysis is based on the cost in Hong Kong. The outcome of effectiveness was obtained from published studies, and we calculate the rate of myopia progression and also from the published study. So here we can see it is the CEA plane showing the cost-effectiveness of intervention in terms of the refraction. And in fact, the result shows that the outdoor activity, here you can see the outdoor activity and also 0.05% atropine, and the red light therapy was cost-effective. And comparing to the single vision lens, outdoor activity and also the followed by the atropine 0.05% and the red light therapy is cost-effective. And based on the SU length, again, the outdoor activity were more cost-effective, followed by 0.05% atropine and the OK lens. And in the probability sensitivity analysis, the cost effectiveness over several, we also look into the willingness to pay threshold. And the outdoor activity was more likely to be cost-effective at a lower willingness to pay threshold, while atropine, 0.05% atropine, were more likely to be cost-effective as the willingness to pay threshold increased. You can see that when the willingness to pay threshold is low, outdoor activity is very cost-effective, but when it increases, the more cost-effective is 0.05% atropine. So the red light therapy and also the HAL lens were cost-effective when it compared to intervention depending on the willingness to pay threshold. So to summarize, atropine, 0.05% atropine, and also outdoor activity are two most cost-effective interventions for controlling myopia progression in children. At a more expensive, a more higher willingness to pay, the red light therapy, HAL lens, OK lens, also can be cost-effective. And the use of intervention can help us to understand in what way cost-effectiveness help us to control myopia in an effective way. So I'd like to stop here. Thank you to all the funding agencies. Thank you to my department for all the work together. And once again, I would like to thank the organizer for allowing me to be here to share the work that we have been doing. Thank you very much.
Thank you very much, Jason. Fantastic talk as always. Any questions for Professor Yam? Okay, if not, we'll move on. I would like to invite to the stage Dr. Soumya Ravindra Murthy, who's a consultant in Paediatric Ophthalmology at the Shankar Eye Hospital, Bengaluru, to talk to you about recent advances in amblyopia.
Very good afternoon, everybody. And at the outset, I would like to thank the APSPOs for the kind invite. Shifting our gaze from myopia, we would be discussing a little about recent advances in amblyopia. The overview of my talk would be to understand a little about what is the recent things that we know about amblyopia, what are the screening technologies in amblyopia, our own screening innovation at Shankara, which is called Kanna Photo Screener using the artificial intelligence, the recent treatment modalities which are available, and our own experience regarding the same, and where do we stand now. The recent understanding, let's look at what we know so far with respect to amblyopia is that it has a critical sensitive period, and that's beyond the sensitive period, there is no plasticity which is left. So the recent understanding is that there is a residual plasticity beyond 8 years of age, and this is the game changer in terms of amblyopia management. So what is that implied to our clinical practice is basically that the uniocular amblyopes retain intact binocular processes, and that is generally suppressed, not irreversibly lost. That exactly goes on to say that monocularity in amblyopia is functional, not structural. What does that imply? That means that the adult amblyopes also can be treated. The recent screening technologies are based on 3 different things, not based on picking up the amblyopia risk factors, but picking up the amblyopia per se, which could be based on binocular retinal birefringence, OKN visual acuity, or on artificial intelligence. Now let's look at this retinal birefringence, which is basically based on the radial arrangement of the fibers at the fovea and also the birefringent property of the outer layer of Henle. What it implies to us, a circular spotlight of a particular frequency when it hits the fovea, if the fixation is CSM, that is steady and maintained, it gives you a backup frequency of 200 Hertz. When it is parafoveal, it gives the same frequency. That means it gives a indication as a pass, which means the child has no amblyopia, versus microstrabismus or amblyopia, which means it's to be referred. So that becomes a screening device. The next important device that we have on the block is using the vanishing optotype, which picks up the OKN. Unlike the grating recordings that we have in the OKN nystagmus visual acuity, this uses a vanishing optotype, similar to our Cardiff. They have pertained, this basically involves an inexpensive portable iPad with an eye camera incorporated in it, and also the facial feature recognition software takes care of the head movements of the child, so that is getting nullified, and the analysis software gives you an OKN nystagmus graph which helps us understand if the OKN is present or absent, picking up the amblyopia. The next important thing was with respect to using the artificial intelligence. What we have developed our own algorithm. This was basically developed by 2 high school children, one of whom is amblyopic. So we use the same photographs which is taken across and run along the algorithm to pick up the amblyopia risk factors. We use the same to validate in nearly 654 children at our hospital. And picked up the amblyopia risk factors by this screener versus the complete ophthalmic examination. What we found, the results were interesting. We could get the images in all the children in nearly 97%. When we looked at the PHI coefficient, it strongly correlated for amblyopia and strabismus, picked up by the clinician versus by the photo screener were almost the same. We had a sensitivity and specificity which was close to 90%. So this could be used as an effective screening alternative, especially in a mass screening in school health camps. Now, the recent therapeutic approaches could be ranging from a perceptual learning to binocular therapy to newer interventions. Now, a word about perceptual learning. What it exactly implies is practice makes man perfect. The stimulus which is used here is the same for both the eyes, unlike in binocular therapy, which could act at various levels, though it is not very clear, by reduction of lateral inhibition or internal noise or improving the cognitive learning processes. The various evidences why perceptual learning should work across the studies. It has shown improvement in the contrast in the visual acuity, both in trained and non-trained visual tasks as well. A significant reduction in the contrast thresholds of the amblyopic eye has also been noted. What is the criticism against perceptual learning is basically all the studies have smaller participants. All of these are task-specific trained gains, and there is no the need for the home-based therapy, which is not available in perceptual learning, and a long-term follow-up, which is not available in these patients. Now coming on to binocular therapy, which basically uses a particular concept, that is, we use a high contrast, high luminance to the amblyopic eye versus a low contrast, low luminance to the non-amblyopic or a fellow eye. So it could be based on either anti-separation therapy, a balanced binocular viewing, or an interactive binocular treatment system. So the various modalities, or the 6 modalities which are available are these. Now moving on to dichoptic therapy, which should work or which works based on reducing the active cortical inhibition. This is one of the representations of the same. So reduce the contrast of the fellow eye to a level that the amblyopic eye contrast is also seen. So this could be done using a dichoptic therapy or using an anaglyph glasses. We can also use an eye bit therapy, which is based on the similar stimulus using a movie watching or a VR handset. A randomized control trial using an IBIT system was comparable to that of a passive video watching as well. Now let's look at a quick look at all the randomized control trials using these systems compared with the patching. Most of them have compared with glasses versus these 3 studies which are randomized control compared to that of patching. And only these particular studies says that it is slightly better than patching, but the visual acuity improvement is in par with the patching. That means the binocular therapy, we are comparing with the gold standard, that is patching, and telling that it works, rather than saying it works better rather than that. What it also implies is that it's a promising option in both anisometropic amblyopia, not in the other forms of amblyopia. And what is also important is it has also shown improvement in stereopsis and sensory reversal in terms of relieving the suppression, unlike in case of patching. There is an interesting meta-analysis which published that there is no support for the efficacy of binocular treatment as a replacement or as an alternative for patching. It can be used as an adjunct rather than using as a primary therapy. And this particular this particular study throwed a little more light, saying that it showed improvement in par with the patching, but also showed improvement in contrast sensitivity and near stereo acuity, which was not seen with respect to patching. So it does show evidence in terms of improving stereo acuity, in terms of improving the contrast, but the age included in all the studies is very variable. The amount of or the type of amblyopia which is included is again variable. The prior history of patching, which may have an effect on the effectiveness of binocular therapy, is not mentioned. The games were thought to be more compliant compared to patching, unlike in the studies which proved the reverse. So our own work on the same, we use this binocular therapy in adult patients, that not in children, that is between 18 to 40 years of age, primarily included only the anisometropic amblyopes, not including those with strabismus or sensory deprivation. So this was just done before the onset of COVID, so we had a lot of problems with the COVID when continuing with the study, but we finished the study though. So the gaming we used was 30 minutes a day, 7 days a week, based on MFBF, that is monocular fixation in binocular field. So these were the certain games that we use, basically using red and green glasses and using a various set of games where the adult is supposed to be using the glasses, playing 30 minutes a day, 7 days a week for 6 weeks continuously. And then we looked at the visual acuity. We had nearly 29 of them. Most of them were anisohyperopes and very less of anisomyope. We saw an improvement in both distance visual acuity and near visual acuity across all of them in mild, moderate and severe amblyopes. We also saw an improvement in both anisomyopes and anisohyperopes, though the visual acuity improvement was a little better in anisohyperopes. So we also noted that the contrast improved in all of them. Interesting thing was stereo acuity was improved in 7 out of 29 subjects of ours. We had a few limitations with respect to COVID, and we had more anisohyperopes, and there was unequal distribution between mild, moderate, and severe amblyopes. But this proved to be a game changer with a lot of adult patients coming to us with no options, and we could start them on this particular thing. In pipeline would be for the treatment would be using asynchronous conditioning, where we use the refractive gratings, but timely space between the two eyes, which has shown improvement in the perceptual dominance being changed. And the other one, which is a home-based therapy, which could be used on the same principle. The experimental drugs and the environmental changes have been used especially in animals, not extending to humans. And our own innovation in pipeline, we've used another device or another app which we have developed, which could be connected on the Android phone, and we use a virtual reality handset which is indigenously developed, and this is something that the child has to play by moving the head. This incorporates 3 different things. One, these gratings are based on the visual acuity of the amblyopic eye. This is similar to Geber's patches. 2, we use a split in the visual field, and we use that the car is seen by the amblyopic eye and the road is seen by the fellow eye. So that combines perceptual learning with binocular therapy with MFBF therapy, and we have completed recruiting the patients. We are just analyzing the results. We show promising results. Again, we have tried this out only in anisometropic amblyopes, not in the others. So where do we stand now currently? There is no level 1 evidence telling that we use binocular therapy in all the patients with amblyopia and replace it with patching. Yes, and the overall safety and effectiveness and the sustained effectiveness of binocular therapy still remains to be understood. Is there an ideal and perfect photo screener where we can pick up every amblyope before they develop amblyopia? Probably no. Binocular therapy as an adjunct or a primary modality, as an adjunct it proves much better. Optimal timing and treatment duration, we really don't know. What do we do about it? Applicability to all types of amblyopia, yes, works beautifully well in anisometropic amblyopes. Sensory deprivation probably doesn't work, and in strabismic amblyopes, yes, probably to an extent. Dose-response relationship, individual variability, we really don't know. Do we have enough engaging games to continue it for a long time? We really don't know. Sustenance of visual acuity gain achieved? Again, we don't know. But does that mean we stop using binocular vision therapy? No, it has shown promising results in both adults and children, and it is on par with the patching. It also improves stereo acuity and contrast sensitivity. To sum it up, so useful and effective in anisometropic amblyopes, it does improve near stereo acuity, it greater visual acuity gain, and shortens the duration of therapy, especially in combination with patching. I would end this talk by quoting a few lines that I appended myself. Explored are the numerous ways to get rid of laziness in the form of penalty, patch, or gaming. We are near, yet so far from saying paradise lost and paradise gained. Thank you very much.
Thank you. We will leave the question to the end and to have a panel discussion. Thank you very much for the excellent talk and for the very important update for the advances in the amblyopia. So I would like to invite my co-chair, Professor Surabh Jain, Professor in the UCL Medical School and also consultant ophthalmic surgeon in Royal Free London NHS Trust, UK, to share with us on the Botox for childhood strabismus. Professor Jain, please.
Thank you very much, Jason, and thank you, Amila, and to all of you for this very kind invitation to be back in Sri Lanka. So we've had some amazing talks with lots of science. So this talk, like most of strabismus, is free of any science, just to let you know. So I'm going to show you some cases where I think Botox can be useful in childhood strabismus. So my name is Saurabh. I work in London at the Royal Free and UCLH hospitals, and I am in charge of Year 2 at the UCL Medical School. So if you're ever in London, please do drop me a line. I'd love to see you and show you around our centers. I'm going to talk to you about botulinum toxin. Now, this drug has been around for a long time. Since the 1980s, we use it in strabismus, and what we know is that this drug is split by the proteolytic cleavage enzymes within our body into the active the active drug, and the drug tends to block the neurotransmitter junctions to limit the release of acetylcholine, and by doing so, it limits the contraction of muscles, and that's how we've been using it. You have many different preparations. The one that we use in London mostly is Botox, which is botulinum toxin type 8 produced by Allergan, but you can also get Dysport and Xeomin. And all of them have slightly different dilution. So that's the important thing. The pharmacokinetics is also important. And what happens is when you inject somebody with Botox, and I say to all my patients, nothing will happen today or tomorrow. It starts working in about a week. It tends to peak between 3 and 4 weeks, and the effect tends to gradually wear off over 3 or 4 months. And this graph is really important, and we'll come back to it in a second. So what I'm going to do is show you 5 cases where I think Botox can be used in childhood strabismus, and I'd love to hear your experiences as well. So this is the first case. This is an 8-month-old boy whose mom noticed his eyes deviating soon after birth, otherwise fine. You can see him sitting there happily with a large angle esotropia. So we know what this is, right? This is a essential infantile esotropia. This is something that we see often. It's a young child with large angle esotropia, no refractive error, and they tend to get this cross fixation. So they look to one side. They tend to not show any abduction because they're fixing with the other eye. Okay, so when you first see them, it may look like a 6-nerve palsy. It's not. It is an essential infantile esotropia. So just patch one eye, and you can see the abduction tends to improve. So there are many, many ways to treat infantile esotropia. Now that's a bad thing. But there are many ways to treat something, means there's no one good way. So you can either observe them, try and treat the refractive error, but they tend not to have very much, or you can operate. Okay, you can do a bimedial recession, or you can do recess resect. Studies have shown they're almost the same in efficacy, or you can try toxin. And so the 2 ways of doing the toxin. So I usually use the same needle I use for adults because you have that surgical proprioception. And you can use EMG monitoring, but you don't actually get much benefit if they're under general anesthetic. You need to use ketamine. Or you can use these Mendonca forceps, which I've just obtained. And this is a video from Dr. Salgado, because used much more in Latin America. And what you do is these forceps are really good at actually going and grasping the muscle. So you get much better accuracy of your injection. So what do you want to see? You want to see this convert to this after 3 weeks. You want to see a induced exotropia, because then what you're trying to do, you're trying to reset the visual symptoms. And over time, when everything settles down, another of my cases, you want to see nice straight eyes after injection of Botox. So does it work? And does it work as well as surgery? Well, this is one of the largest studies by Alejandra Campomanes, who is in UCLA. And they looked at almost 450 patients, and the largest group had toxin, the rest had surgery. And they used 5 units for less than 50, 7.5 for more than 50. And this really is all the findings in one key graph. If you have a deviation of less than 30 diopters, they are both similar. Okay? Although you may need more than one injection, so you have to balance the need to take this child to theater more than once against the need, against that they have no scarring. If you're more than 30, you're probably better off having surgery from the beginning. Okay? This is a fantastic meta-analysis in IOBS in 2017 that looked at all the big studies using toxin in infantile esotropia. And this is really difficult, right? Randomizing things are always difficult. To randomize strabismus in children is more difficult still. But they came up with some really interesting findings. So in all these groups, the mean deviation before treatment was about 40. After treatment was about 6. So it really works, okay? But as I said, you do need sometimes more than one injection. Okay, the higher the dose injected, the lower the success rate. Now that seems a bit counterintuitive, but actually it makes sense, because the higher the dose injected means the bigger the deviation, which probably is why they didn't have much success. And they found that open sky worked. If you use EMG guided, it works as good as open sky. And to me, open sky just means open the conjunctiva. And to me, that makes no sense. If you're doing a non-interventional procedure, you should really leave the conjunctiva alone. And I tend to just use EMG guidance in these children. If you can use ketamine, you get a good signal. But if you can't, I still use the same apparatus. Any complications? Well, consecutive exotropia, which you sort of want really, but what you do not want is ptosis, because if you give this child a ptosis, the young children with a lot of neuroplasticity, you do not want to give them amblyopia. And what I found is if you leave the needle in the track for at least 60 seconds, or if you can raise the head end of the bed, that reduces the incidence of ptosis drastically. Okay? There's a bit of vertical deviation. There was one paper in 2016, and you can see this child had induced ptosis, but they also got an atonic pupil. So I'll go to my next case. This is also a young child with large angle esotropia. But the difference here is that they have periventricular leukomalacia and developmental delay. Now, this is not a group of children that you really want to operate on early because there's a high degree of variability, and we know that they might go exotropic over time. Their parents are really keen on doing something, so he had one injection of toxin. This was after him in 3 weeks, and now he's 5 years later, and he has not had any recurrence of his strabismus. So we published this a while ago, showing that toxin works really well in children with cerebral palsy and PVL. This is the third case. This is a 14-year-old girl who came with double vision, progressing over the last few weeks. She had a history of dizziness maybe 10 months ago, but otherwise absolutely fine. On examination, she has a sudden onset large angle esotropia, but otherwise fine, full motility. So we know it's not a sixth nerve palsy, very low hypermetropia, and when we look at a Hess chart, it's absolutely normal. So this girl essentially has an acquired non-accommodative comitant esotropia. There are 3 different kinds you see, and she really has the Franchetti types. The Burian Franchetti type is an acute onset esotropia with no signs of paralysis, good potential for BSV and low hypermetropia. So she did really well with injection of toxin to both medial recti. This is another condition in which it is quite useful, and you can do the older case just with some sedation. There's another case we published in 2014. This is a child whose mom was very specific. She said one day he has a squint, the other day he doesn't. And she's right. Mothers are always right. So if a mother says this child has something, listen to them because they know what they're talking about. And you can see here, they have straight, esotropic. And actually she'd even made a calendar, and she'd marked good day, bad day, good day, bad day, good day, bad day. So this is a cyclical esotropia. So on a good day, absolutely everything is fine. On a bad day, they have a large angle esotropia. So we treated them. So this is a therapeutic dilemma because you don't really want to operate. If you do operate, you have to operate on the full angle, and people do get a bit anxious because you're treating a normal child. They come on a good day on the day of surgery. So we gave this child some toxin, and they responded really well. And this was the first report of using toxin in cyclical esotropia, which we published in JPOS. And these children are another group in which you might want to consider using toxin. This is another child. This is the one we're talking about. Is a girl from Hong Kong who flies to London to get her toxin injections every 6 months or try to dissuade them. And here's another child, and she has continuous cycles of cyclical esotropia. So I'm going to finish with this case because this case gave me a lot of sleepless nights. It started off quite easy, quite nicely. 8-year-old girl with a large angle exotropia that she could control from time to time. So he has some stereo when she controlled it. So that seemed straightforward. So we offered her some surgery, resect, and I was just expecting she'd do well. She didn't. So she had a large angle consecutive esotropia, a lot of unhappiness. Her stereopsis disappeared. So we said, okay, we will wait. Maybe this will get better with time. It didn't. 4 weeks later, she's still very esotropic. Now, this is a problem, right? Because there's a loss of stereopsis. The family is very unhappy. There's a big overcorrection. So in this case, we used some toxin to both eyes. And it initially worked really well. Okay, 1 week afterwards, worked really well. Everybody was happy, me, the mother. But remember this graph I showed you? We know the peak effect will occur in about 4 weeks. And this is exactly what happened. This is 6 weeks later. This is 3 weeks later. Now she's got a huge overcorrection. Family is very unhappy. The squint has returned. What have you done? But again, remember the graph. It will go down. So lots and lots of reassurance. And 6 months after the injection, both mother and child are very happy. Full restoration of binocularity. And they are well controlled and been discharged. So just to finish, these are the indications of use of toxin pediatric strabismus in small angle infantile esotropia, less than 30 diopter, those with developmental delay or plasticity, but the angle is variable, consecutive exotropia or esotropia as a rescue mechanism, acute acquired esotropia. Now, the last two I've not really talked about because it's not very common in children, but in adults, you can also use them as adjunct to surgery of sixth nerve palsy and in exotropia. Thank you very much for your attention.
Thank you very much, Professor Jane. We will leave the discussion at the end. So we'll invite our next speaker. Yes, Professor Sita Agrawal, from a professor in ophthalmology in charge of the Strabismus and Pediatric Vision Clinic of Department and KGMU, India, to share with us on pediatric cataract for beginners.
Good afternoon. I am happy and proud to be part of this APS POS session. I would be touching on some important points for surgeons who are considering starting pediatric cataract surgery. Paying attention to them would make their initial experiences with pediatric cataract a pleasant one. Preoperatively, the surgeons who are considering starting pediatric cataract should be well versed with adult cataract surgery and should have performed a certain number of pediatric trauma cases. They should perform their initial 50 cases under supervision. Regarding patient selection, it makes sense to select older children. Avoid comorbid conditions like microphthalmos, coloboma. Insist on a recent B scan to rule out posterior segment involvement. It makes sense to implant IOL in children older than 6 months and those who have normal sized eyes. The SRK-T or Holiday 2 work well in younger children. And the choice of implant is hydrophobic acrylic. There should be no shortcuts in preoperative counseling. The parents need to be talked in detail about the need of glasses, the long-term follow-up, possibility of amblyopia, resurgery, and all the complications. Take a detailed informed consent. It takes care of a number of medico-legal issues later. Now coming to the interesting part, the surgery. Incisions in children tend to gape. So they should be biplanar or triplanar. They should be slightly longer than those you make in adult. Pay attention to these diagrams. They show that the inner opening and the outer opening are on different planes. The side port incision should be made with an MVR blade and it should be a clean entry. Keep in mind not to extend the incision while withdrawing the blade. The main incision, the entry should be made by making the blade vertical so that the inner lip is valvular. Also, you may consider making the main incision after completing the capsular excess for better chamber stability. The most difficult part of pediatric cataract surgery is management of the capsules. First, I'll talk about the anterior capsular excess. The chamber should be deep and you should make small, gentle pulls, and you'll need to pull, the pulls should be minimal and repeated. Like if you are making, like Dr. Khokhar had said in the morning, if you are making 5 pulls in adult, here they should be 7 to 8. Staining the capsule, if visibility is an issue, it should be done with trypan blue. Note here again that the pulls would be repeated and gentle. You can either use a cystotome or an Uttrata forceps. You need to regrasp, deepen the chamber, and the capsular excess has to be completed from outside within. Aim for a rhexis which is smaller than what you are actually aiming, and you would, as the rhexis would eventually gape on completion. If you are aiming for a 4 mm rhexis, you will end up with a 5 mm one. Now sometimes the capsule would be unyielding to either the Uttrata forceps or the cystotome or even the vitrector. So you need to enlarge the incision and do the capsulotomy with a Vanna scissor. Initially you make this opening and you may need to even to smoothen out the edges later. Once the capsular excess is done, hydrodissection and cortical aspiration and management of the nucleus is relatively easy. The nucleus just flows out with adequate hydrodissection. And the cortical management can be done like you do in adults. Now, the posterior capsule management is again tricky. Here I would be showing an opaque posterior capsule. The chamber should be filled with a viscocohesive OVD, and it should not be overfilled. It should be just adequate, otherwise the posterior capsule will tend to bow backwards and go away from your plane of focus and make the management even difficult. Here again, you would be making small, gentle pulls, regrasp the capsule as the capsule advances, and aim for a posterior capsular opening which is smaller than the anterior capsule one. A useful technique to be followed by beginners is that you perform the posterior capsulotomy after implanting the intraocular lens. I prefer to take a suture after the IOL implantation when the chamber is still filled with viscoelastic. Then you manipulate I've just taken the suture bite, I've not tied it. Then you manipulate the vitrector behind the IOL, and the irrigation can be managed through the same incision, or you can have a separate port for it. The vitrector axis is initiated with the mouth of the vitrector facing backward. It is extended by rotating the vitrector forward, and then you proceed with a liberal anterior vitrectomy. The surgery subsequently needs completion just by tying the suture. Now, a few tips about IOL implantation if you are doing it after performing the posterior capsular axis. Here, the leading haptic should go in between the capsular rims, and the trailing haptic should open in the anterior chamber or in the sulcus. This is achieved by slightly withdrawing the injector as the leading haptic unfolds and depressing it. Subsequently, the trailing haptic needs to be dialed in place with a Sinskey hook. Now, these photographs show the ideal placement of the IOL. The first photograph on your left is showing the IOL placement between the capsular rims. The second one shows the capture of the IOL optic in the posterior capsule while the haptics are in the capsular bag. This technique should be gradually learned by all pediatric cataract surgeons for good outcomes. Incisions in children need to be closed. Suture tying and suture tightening with an air bubble in the anterior chamber and observing the shape of the air bubble gives you an idea about the tautness of the suture. Doing a small peritomy initially to bury the suture makes sense. Post-operatively, the eyes should be bandaged. I prefer to keep the children admitted for at least 2 days post-operatively. The pediatric cataract surgeons should be suspicious for inflammation and infection as the examination of the pediatric eye is difficult and the children are often uncooperative in the post-operative period. You should have a high index for suspicion and need to learn how to differentiate between these two conditions and start timely management. The examination should be performed without touching the eyes and be ready for a long journey ahead with management of the changing refractive errors, amblyopia, and the visual axis opacification. All the best. Thank you.
Thank you so much. Thank you so much, Siddharth, for the excellent presentation sharing with us on the cataract surgery. Yes, please.
Yeah.
I see you use your posterior capsular rectus before you put the lens in. I've got concerns about the placement of the lens. You've had a successful operation. Why not do the posterior capsular rectus after the lens is in? All you have to do is flip the lens up a little bit. The lens is already in place.
Yeah, I described both the options there. So for beginners, it is better to do the posterior capsular management after implanting the lens. That way, it's better because the IOL remains in the bag. However, the margin of the posterior capsular opening doesn't remain smooth with the vitrector. it becomes a ragged margin which is prone to extension. So the ideal management would be performing the posterior capsular excess and implanting the IOL within the donut which is created. However, it's a technically challenging step to be performed. Requires a lot of practice because sometimes the IOL opens vertically and the leading haptic may go behind the posterior capsular opening. That makes it challenging.
Thank you. And now we have about 10 minutes for panel discussion. And we also have Professor Frank Martin who will give us a closing remark after that. So our symposium in fact composed of several major topics involving myopia, amblyopia, strabismus, cataract, all these. So may I start with asking Dr. Sowaya for the amblyopia. So first I want to ask the audience, are there anyone using binocular therapy in your practice now for amblyopia? Maybe when I want to ask Dr. Saraya for what is your choice for treatment therapy now? Say when a child comes to you for amblyopia, are you still doing patching or when you will seek alternative management?
Okay. So in the clinic, when I see a child with amblyopia, I usually start off with patching. Patching is my first line of therapy. I don't switch on to binocular therapy as my first modality of choice even today. Though in our hands it has worked beautifully well. I use binocular therapy in certain set of conditions. 2 consecutive visits, no improvement in the vision at all with compliant patching. Or the child is absolutely resistant to patching and the parents are not able to get time for patching, but they are okay with trying the vision therapy because this software is available as a home therapy as well. So this could be given as a software where they download it in the laptop and use it at home. Or when there is a mixture of 2 or more causes for amblyopia, like the patient has an isometropia but also has a strabismic component, that is when I use a binocular therapy as the first modality rather than just patching alone, but as a combination always.
Thank you. Thank you very much. And another question is asking also the audience, any one of you is using Botox? Botox for strabismus? Are you using in children, adult, or as Professor Jane has shared, is also using in children? So can I ask Professor Jane, for children using Botox, in my scenario, it's difficult to convince the parents that usually they need to put into sleep for what's your experience and how to manage that?
Yeah, thank you, Jason. I think that's a really fair point because you have to balance the two issues, right? You're putting a child to sleep for a second time, whereas, what's the benefit you will get from toxins? So there's some very selected cases in which it is useful to do that. And, as in all the cases we've heard today, evidence-based medicine is your guide. So you say to them, well, studies have shown that we can do an operation for your esotropia, or there is a possibility that we can use just the Botox, but then there's you may need more than one GA. So then, you sort of involve the parents in the decision-making process. And, in cases if you can avoid surgery and avoid scarring, they just have to balance that against the risk of a general anesthetic.
Right. Yes, Siddharth, you want to give a comment? And also some colleague want to give a comment. Please. Yes.
I tell the parents that there's a 30% chance that your child may not require surgery after the first injection.
How many percent you say?
30%.
30% chance.
30%.
Okay.
For infantile esotropia. And more so where the general anesthesia fitness is doubtful, the child is low weight, then in the waiting period, Botox is the good option. More so when the measurements are not very accurate in small children, there Botox is very useful because if the child is able to keep the eyes straight for just about 3 to 4 months because of the effect of Botox, the fusion develops. And then many of these children would eventually not require surgery.
Okay.
And if the parents are willing enough, you can repeat the injection after another 3 months, and then that percentage would go from 30% to maybe 50%. of that the children who don't require the definitive surgery. So that's a good percent. Like many of the parents, they get convinced for the injection. You tell them it's a much less invasive, you only need a small general anesthesia. So it's not difficult to convince.
Thank you. Thank you. Another colleague wants to give comment.
Yes.
Maybe you can introduce yourself first.
Thank you so much. Basically, I have a question from Dr. Jain. So I started using esotropia and squint very recently after hearing you in one of the conferences in India, actually. So I have a question, that is, till what age do you recommend using Botox in children?
Thank you. Can you introduce, where do you work?
I am Associate Professor in Medical College, Kanpur, UP. Yeah.
Very pleased to meet you. So, I think one of the things that's useful when offering toxin is the amount of the deviation. So I use that as a guide. So if it's a really large angle strabismus, you can still offer toxin, but then your end result changes. You can say, well, if I give you toxin, it might be that you settled from a 80 or 70 diopter esotropia to a 30 diopter esotropia. So we'll go from 3 muscles to 2 muscles. So that's one advantage. As children get older, because you can get the measurements much more accurately, and if they're more than 30 diopters, then I tend to offer them surgery. I don't offer toxin. But younger age, less than 30 diopter, variability of measurements, developmental delay, in all of these children, toxin is a good option in esotropia.
Okay, and one time I was doing surgery for a very large angle esotropia, and there was some residual. So in that patient, I tried Botox. Although the patient was older, not a young child, I was operating, and I think it was some 12 to 14-year-old girl, and there was a residual esotropia. So I thought before going to surgery again, I tried Botox, and I had a wonderful result. Both eyes were straight. Now I have to see, how the patient comes after 4 to 6 months and what the result would be.
Now, I think that's a good point. So residual or consecutive strabismus, toxin is a really good rescue therapy. The only thing from the rule, deviation from the rule, is if you have a big consecutive esotropia following surgery and there's limitation of abduction, just think of a slipped muscle. But otherwise, it's a really good option.
And can we go in the other eye as well? Sometimes for the residual esotropia, sometimes can we go to the other eye and try Botox in the other eye? Would it serve the purpose?
Absolutely. If there's no limitation of motility, it doesn't matter which eye you put it in.
Okay, thank you so much.
Thank you. Oh, there's two more. Yes, one by one, maybe. Yes, maybe.
For Dr. Jain.
Can you introduce yourself first?
I'm Hasanka. I work as a pediatric ophthalmologist in Galle, southern province, Sri Lanka. So if you have a child who's presenting at the age of between 6 months and 1 year, who's having a very large angle esotropia, maybe more than 45, would you consider giving the Botox first and then reassess and then go for surgery?
Yeah. Well, I think so it depends what you're chasing, right? Inner esotropia, are you chasing stereopsis or you just want good alignment? I think I try not to operate in infantile esotropia really early because, as I said, the measurements are variable. So if the parents are keen and there's a large angle esotropia, I think it's absolutely sensible, and they want to do something, you can absolutely do some toxin. When they're older and you can get reliable measurements, and if they are large angle, then on the whole, I prefer surgery. But I have many colleagues who will still offer toxin first, so I think there's no hard and fast rule.
What's your view on augmenting with Botox if you're doing for a large angle recession, maybe after 1 year or so? Early?
So we actually looked at that. We looked at our sensory exotropes. So these are people who have big 50, 60 diopters, XTs, and they only want the one eye done because that's the eye with the poor vision. So we looked at using toxin as a chemical traction suture almost. So we did toxin 2 weeks before the surgery. We found actually long-term there was no difference in the two groups. They still settled to the same angle. So we didn't find a big benefit. But I think, again, in that group, you need all the help you can get. So I don't see any drawback to using it.
Thank you.
Thank you. In the interest of time, one last question, and then we'll invite Professor Martin to give us a closing remark. Yes. Can you introduce yourself first?
I am Dr. Usha Johri from Bombay. I have burnt my fingers several times, injecting Botox on a child with cerebral palsy, because I always felt that there is a spasticity of the muscle, and so injecting Botox would really help. But once the child is given general anesthesia, you do not, it's very difficult to assess what is the relation between the spasticity of the muscle and the relaxation of the muscle. So I just wanted your opinion about this.
So I think one thing that really, I think you're absolutely right. Because these kids get toxin all over their body actually. They get spasticity and they get flexure contractures, etc. So I use the FDT as a guide. So it depends how much you can move the eye. Now it's been shown even in infantile esotropes, the muscle is very tonic. So even in them, there is a bit of limitation of abduction. So if you do an FDT and there's limitation of abduction, I think this supports your decision to put in toxin.
Would you prefer to inject Botox in a patient who has already been operated and there is a, strabismus? Would you inject Botox in those cases, or do you feel that there will be a lot of fibrosis and Botox may not work?
So it again depends. It depends upon the amount of deviation, and if they've had say a bimedial recession and they still have a large angle esotropia, then I think it's a viable option. In these kids, usually I tend to do bilateral LR resection, and I do a bit more than I've got a little table I use. But yes, absolutely. If the parents are not keen on more surgery, and I have many families who do not want any more scarring, it's an absolutely worthwhile option to try.
Thank you.
Thank you. I think we have an excellent discussion. And because of time, otherwise we can have many discussions to follow. So I would like to invite Professor Frank Martin, who is the president of our Asia Pacific Paediatric Ophthalmology and Cerebral Society, to give us a closing remark. Professor Frank Martin, can you hear us?
Yes, thank you very much, Jason, and thanks, Jason and Sabran, for chairing such an interesting session, and for the speakers for sharing their knowledge with us. I learned a lot, and I'm sure you all learned something from this. APSPOS is the Paediatric Ophthalmology and Strabismus Society of the Asia Pacific region. It's a relatively new society, it's growing. Next year in Brisbane, the 29th of June to the 1st of July, we're having our third conference. It's back-to-back with the International Orthoptic Congress, and I'd like to invite everyone to attend and participate. It will be a good meeting, and when you get paediatric ophthalmologists together, we always have fun. So thank you very much, and I'd like to thank Emila de Albus for inviting APSPOS to have the opportunity to have a symposium at your annual Congress. Thank you.
Thank you, Professor Martin. Please stay here. We would like to take a group picture together with you. Please stay. So I think it is, we will end this session, and when I invite our speaker to come on the stage, including our president, Emila Evans, professor, come on the stage to have a group picture.
At the outset, I would like to thank Dr. Amila for giving us this opportunity to have our state society's session in this auspicious conference of College of Ophthalmologists of Sri Lanka. We are here for the last 3-4 days, and we have had a very great time. Sri Lanka is actually very beautiful. So we, the ophthalmologists from UP, Uttar Pradesh, it's a state in India, will be presenting some topics on the updates in ophthalmology, covering retina, oculoplasty, cataract, myopia management, etc. So, at the outset, I would like to invite the chairpersons, Dr. Daminath sir, the ex-president of UP State Ophthalmology Society, Dr. Vinod Rai sir, the present president of UP State Ophthalmology Society. Is Dr. Gijesh here? No. Dr. Ramesh Chandra sir, Dr. Mohita Sharma ma'am, our dynamic secretary, because of whom this session was possible. And I would request the panelists of this session, Dr. Parul Singh ma'am, Dr. Iram Parveen ma'am, Dr. Gunjan Prakash sir, Dr. Puri Shukla ma'am, and Dr. Abhishek Dikshit. So please come on the first row. I would request our president to say a few words, and then we will start the session.
Good evening, everybody. I would like to thank again Dr. Amila
for giving us a session here in this auspicious conference of College of Ophthalmologists of Sri Lanka. Last year we had a collaboration with Nepal Ophthalmological Society for international sessions. And as he said, Dr. Navendra, that we would like to again come nearer to this place also. I would request our moderator to start the session. Thank you.
Without wasting time, I would like to call our first speaker, Dr. Dhamir sir, to present his talk on aligned chopping in phaco. Dr. Dhamir sir is the medical director of Agra Eye Center. Agra is famous for Taj Mahal. And he is a member of managing committee of All India Ophthalmic Society. He was the ex-president of UP State Ophthalmic Society. He is ex-chairman scientific committee of UPSOS, and he is an international phaco trainer. Till date, he has trained more than 450 international phaco fellows. This is to his credit. And he is the innovator of MD2 procedure, sealed implementation, aligned chopping in phaco. Sir, please proceed.
Thank you very much, giving such a nice introduction. So this is a new technique of doing phaco chopping known as aligned chopping in phaco. So initially the chopping was designed by Nagahara in 1993 in ACRS, and since then there were so many modalities, so many techniques came like Nagahara chop, stop and chop, pop and chop, bimanual chop, quick chop, pre-chop, and finally I have designed my own technique which is very suitable for the hard cataracts. This is aligned chop. Two main categories are there, whether you chop the nucleus horizontally or vertically. So why the chopping is important? Just to give less stress and easy manipulation of the hard nucleus inside the bag. So for the efficacy, safety, and reduces stress on the granules, the chopping technique is advantageous. This is kinesthetic. No red reflex is required in this chopping. Good for mature cataract, and the workstation is only 2 to 3 millimeter of the pupillary zone. So it's good for Brunison nuclei, white cataract, weak zonules, capsular excess tear, and a small pupil again. So this is what we know about the horizontal choppers. You know very well. They are the vertical choppers, nothing to deal. And what is the difference? Nothing to tell about it. And why this aligned chopping came into my mind? Once when you hold the nucleus and you chop in the regular choppers, what happens? It moves, it spins in the tip of the nucleus. So this is the great difficulty during the chop. Once you hold it and start chopping, what happens? Just see in this video, and it moves. Chop is going towards the periphery, centripetally it's coming, and it moves. And difficult to chop. Repeatedly multiplying, you doing so many things, and so many stress happens. And during this process, so many complications this still do happen. And then this is the chopper which was designed. This is 3-dimensional chopping. And this is bent at the tip, 1.5 to 2 millimeter away from millimeter long. Bend is about 30 to 40 degree at 2 millimeter away from the blade. 26 gauge shaft, left bend for the left-handed surgeon and right bend for the right-handed surgeon. So this is the video you can see very well regarding the aligned chopper. So chopper is aligned. We have to insert it from about 30 to 40 degree away from the main port. Not at the 90 degree as usually we do it. Follow the curve of the instrument. That is very important. So just see this brown hard cataract. Insert the chopper along the line of its own axis. Follow the curve. And you see, this is how it chops without any rotation of the hard nucleus. And with the same instrument, it's easy to rotate on its axis, go to the periphery, and the chopper moves towards the tip centripetally.
the force, two forces they are applied, and one is from the tip and second is the instruments. The force is directly opposing each other and ready to chop it. And see this again, hard cataract. Always make sure that your CC should be round and big. It will allow your chopper to run comfortably. If your CCC is very small, then it becomes very difficult. Make a small crater, go along the curve of the instrument, hold the nucleus with a high vacuum. 1 or 2 bursts you can use. Centripetal force is applied and it cracks through and through without rotation. And the lateral separation is done with the help of this angle chopper. This is also very important. It helps in lateral separation. Again, hold and chop. And you see there is a crack in the chop. Crack is anteriorly and chop is behind. Chop is anteriorly and the crack is behind. Again, hold it in the soft cataract. You see this? Again, it is the same thing. You can go for the grade 2 and grade 3. Easily you can chop them. And the more you make the pieces, the less energy is used during the phacosurgery. So you can make 4 pieces. It is better to do the 8 pieces. More pieces, less energy is used. See this? It's a white cataract. Go along the axis, the curve of the instrument, hold the instrument, hold the nucleus with a tip, with a high vacuum, and see this, how it chops. Instrument goes in the periphery, hold the nucleus, and it cracks. And then the lateral separation can be done. And then after you can eat the nuclei very well. So this is, if you are using the femto, then take out the button. And after that, just hydrate whole of the segments to take out the bubbles. It is very important to take out the bubbles. With a little gentle hydrodissection is required in these cases. This is the last video. Rotate it. This is the bubbles, they are coming out. And place the nucleus after rotation in the comfortable position so that you can hold it. Take your phaco tip inside. Along the curve, just take your instrument inside and you just see it is not in position in the alignment. A little is rotated again just to make sure it's alignment. Hold it and just do the separation. This is how it's separated, and all the fragments then they are sucked inside with a high vacuum. Thank you very much. So few of the instruments, if you want this instrument, I can deliver it free of cost from my phacomaster@gmail.com. Just write to me, and I am sorry, Dr. Anand Parsari, not to supply you. I will definitely send these 2 instruments to you. Thank you very much.
Thank you, sir. Thank you for a wonderful talk. I would request someone from the panelists to please give 2 minutes to comments on this. Dr. Ravi, can you comment? There has been so many innovations in phaco
Sir, it's a good idea to make, rather going with a hard leathery cataract, rather going just 4 parts. If you are make a cake in the pie, a pie shape, definitely a less energy will require, and no loss to the endothelium as well. So my suggestion is also with the sir that make 8 or 9, 7, 8, 9, whatever you want. Small chunks is very important. Thank you.
Thank you, Dr. Ravi, for the comment.
I have used this chopper. He presented to me also. So the main advantage of this chopper is that in a hard cataract, when we are trying to chop, then sometimes the nucleus rotates. Now, since this is a little curved, it gets engaged in one segment, and that rotation doesn't happen. So it's not like we have a rotating nucleus. We have a very stable nucleus in which the chopper is already engaged, so it becomes much, much easier. That's one of the advantages, apart from all those that he has already said.
Sir, a question. Do you prefer making the cuts and or you prefer eating away as you make the cut? I mean, what do you...
So basically, you have to make a small crater in the from paracentral to center place. And then after, you have to run the chopper directly towards the tip. And once it is chopped, this is classical chopping. What other choppers they do, they are almost breaking the nucleus because they are hitting the nucleus. They are not exactly chopped. So the blade is actually used to chop the nucleus. So this is the chopper. So if you cut in the alignment of the tip, it chops. Again, you rotate with the same instrument this way or that way, clockwise or anti-clockwise. So then after, again you can chop. So it is my classical idea to chop it in so many pieces, even 8 or 16, 17, 18, as much as you can. The more you pieces, less is the endothelial damage, less is the energy. Sometimes when you are sucking these nuclei with simple high vacuum, you can take it one. Burst is more than sufficient. Hardly taken, energy is taken about 0.1 second or 0.2 seconds. That much is the time taken for the energy, that's all. So this is very comfortable technique and very useful technique, especially for those patients where the endothelial cell count is less. So use it and you will be quite comfortable doing this kind of surgery with this chopper. Yes.
I have a concern, and
yes.
That is with a very hard cataract, to get that to rotate. I saw you did it very well, but that probably meant that you had hydrodissection first. And my concern is if you have a very hard cataract that's usually tight against the posterior capsule, by infusing around it, you run the risk of bursting that posterior capsule. For a softer lens, yeah, I could understand it. Now, I do like the technique of going around the edge to chop. I do it myself rather than a sharp one. Your chopper is not sharp, you said. It's rounded.
Yes, we have the two kinds of the chopper. One is the sharp and one is the blunt. So blunt chopper is used for the periphery. So that doesn't damage the posterior capsule.
Well, the blunt one is for the periphery. The sharp one is to...
sharper is for, because we have to bury directly this. So in the mid periphery, we just bury inside the substance and then it is a vertical and then chopping. Yeah. But the blunt chopper is for the periphery. You go to the equator and from there you just chop it, whatever the hardness it is, except the cataract nigra. I don't allow anyone to practice for the cataract nigra. Otherwise, every cataract is possible for this.
Yeah, because to start with a chop, to get it straight down, sharp, and you're splitting it, then you could actually hydrodissect because you have this cannon valley that the water could come up without bursting the posterior capsule, because that's one of the main risks of doing hydrodissection with a very hard cataract, bursting that posterior capsule. And by making a canyon or a valley, one way or the other, it gives the fluid a chance to come up.
Yes,
and then you could rotate
the
segments as you like, safely.
Yes, you are very right. Thank you.
So this means you need two choppers at a time, one blunt and one sharp in a same surgery. Okay. Then blunt one. Right. Thank you. Okay. Blunt one. Right.
In the periphery, for the hard cataract, you have to go to the periphery. So I don't recommend that you use the sharp choppers. The tip, only the sharp choppers means the tip. The tip is blunt for the hard cataract and tip is sharp for the soft cataract because you are just cracking from the, just near to the tip, phaco tip. You just bury it and then you chop it.
Hello. I would like to know for the beginners, which one would you recommend from the start? Any learning curve? This your chopper only, or they should do surgery with the normal?
If you use Sinski basically from the very beginning, that is the first learning curve. Start with the Sinski, then go for the chopper or straight chopper, then use my chopper. Is it the third stage? Don't start immediately with this. Once you are encountering variety of the cataracts, then once you are trained enough, then you can use it.
Thank you very much, everybody, for such a wonderful discussion. Thank you, sir. Gerald, sir. Next, we have Dr. Kamaljeet Singh, sir, who is Professor in Ophthalmology, ex-Head of Department of MLN Medical College, Allahabad. He has a very vast experience in both retina and as well as cataract, and that is why we chose this topic for him. That was management of diabetic retinopathy and cataract.
Thank you, Navendu, for giving me this opportunity. This is a very, very prominent meeting here happening in Sri Lanka, and a very nice organization that they have. Everything is running on time. So my topic is phaco in diabetic patients, and as Dr. Navendu has said, we have lots of diabetic retinopathy. I was basically a squint man, then I started doing diabetic retinopathy, and cataract is of course bread and butter for us. So these kind of cataracts we get in our setup, in a government setup where we do hundreds of cataract surgery. So since both the things together I was doing, so I was getting quite a large number of diabetics whom I had to operate. So basically the cataract occurs earlier in diabetic patients. And when you do surgery and how you do surgery depends on whether the patient is having diabetic retinopathy or not, and what kind of diabetic retinopathy, non-proliferative diabetic retinopathy, PDR, or whether CSME is present or not, or vitreous hemorrhage, or neovascularization of the iris or glaucoma. These are the associations of cataract in these patients. Basically, what we have to remember is that in diabetic patients, the lens is usually bigger, and there is a steeper anterior lens curvature. So rexis becomes slightly difficult in some cases, and pupil does not usually dilate in these patients. So you have to be, you should arrange all the things, armamentariums, for dealing with a myose pupil. Lens capsule is fragile, and there are chances of post-operative flare. It's very common, and there could be a transient elevation of IOP also. About CME, it was said in the past that there is a high incidence of CME, but in my opinion, I have done maybe more than 2,000 cataracts in diabetic patients. The CME does not have incidence in Indian patients. So when we do cataract surgery in diabetics, if you have performed good extracapsular, that means whether phacoemulsification or a small incision cataract surgery or a conventional ECE, you will not see any progression of diabetic retinopathy in these patients. But if you have created a complication, a PCR, then there are chances of NPDR progressing to proliferative diabetic retinopathy, or PDR might progress to neovascularization also in the angle. So those kind of chances can be there. There is another problem in diabetic patients is that there is release of pigments from the iris. It's very common, so you should implant the lens in the bag only. And there could be deposition of protein exudates on the IUL. So that may stay for quite a long time, though disappear after some time in some cases. So if there is hypotony, then also the progression of diabetic retinopathy can take place. This occurs because there is disruption of blood-retinal barrier, and this leads to progression of diabetic retinopathy. So when should you operate in a diabetic patient? If there is just the cataract and no diabetic retinopathy, you can operate. Or if there is cataract and it interferes with visualization. So many a times you will find that the laser would not work in a patient of cataract, and then it becomes difficult to manage diabetic retinopathy. Then only you should do surgery, even if the cataract is very little. And if there is cataract-related diseases, then also you should operate. This already I have mentioned that ICE, if you have performed, then or PCR has occurred, then the neovascularization or the progression increases. So, and what preoperative assessment you have to do? You have to check overall health status. That means that metabolic regulation has to be there. There are many people who operate, if they get a diabetic patient, they give insulin and they operate. That should not be done. Diabetes should be well controlled for at least 1 month. HbA1c should be looked into, and it should be less than 7. Then only you should think of operating these cases. Because if it is uncontrolled diabetes and you operate them by giving just insulin for a day, the complication chances would increase. So that is there, and then the surgery should be carried out only when there are appropriate medical indications. Otherwise, avoid the surgery as far as possible. And when you are doing intraoperatively the surgery, the iris should not be touched. Because if you touch the iris, the pigment release occurs and the progression of diabetic retinopathy would occur, and maybe cystoid macular edema would also occur. So that care you have to take, and you should do only that surgery in which you can master it nicely. That means that you can do SICS or phaco. It does not make any difference in the ultimate final result. So you can do that surgery only. Which PCIOL should be used? First thing is that it should be in the back. Then rexes that we make, it should be larger, because it becomes many a time difficult for the retinal surgeon to do laser photocoagulation. If there is a small capsular excision, then they have to do YAG anterior capsulotomy also in many cases. Use plano-convex lens or biconvex can also be used, so that the convex posterior IOL touches the posterior capsule nicely. There should not be any holes in the IOL if you are using this thing. And there are many problems that can occur. If there is silicone oil, you have to be careful in using. In the past we used to use silicone IOL, so it should not be used. There could be complications. If there is severe diabetic retinopathy, then one should first try to do a proper laser photocoagulation, then should proceed for cataract. But if cataract is advanced and it does not help, in the laser photocoagulation cannot penetrate the lens opacity, then you should do first cataract, and you can do laser simultaneously also by indirect ophthalmoscopy after putting a viscoelastic into the anterior chamber and making the proper chamber, and then you can do intravitreal injection. Similarly can be given at the time of surgery if there is CME, and later on you should follow it with post-operative laser. A proper PRP has to be done in these cases. So these are some of the cases wherein you do laser at the time of on table, or post-operatively also use a laser indirect ophthalmoscope to do laser photocoagulation in these cases. So with the shortage of time, I finish it here only. Thank you so much.
Thank you, sir, for the wonderful presentation. I would request Dr. Gunjan, sir, to please.
Thank you for the very nice and informative talk, Dr. Kamaljeet, sir. I have learned much from you and your ideas. You have almost covered almost everything. I would like to add a few, that the cataract, if you consider it as a grade 3 cataract, then consider it would you would found on the table as grade 4. Usually the grade is harder as assessed in a diabetic cataract. Another thing is usually the higher grade cataracts in diabetics are more leathery and more difficult to chop also if you are doing phaco. If you are doing SICS, then it does not matter much. Just try to do a big, larger capsular axis in such cases so that in the end or in the follow-up, the capsular phimosis does not happen. And plan an uncomplicated, everybody plans for that. So cataract surgery in diabetics should be performed by much more experienced cataract surgeons as compared to beginners or initial phases of surgery. So if you have a patient who is a diabetic, it is better that the patient gets operated by a more experienced phaco or SICS surgeon, because the complications might create havoc also in the long term for the patient's recovery of vision, and long-term deterioration and maintenance is a problem. At the end, we should, as you have pointed out, that do not touch the iris. Even if a single touch happens and good round circular pupil is not there at the end, initial phases it won't affect, but in the long run, it might become less amenable to dilatation and further management of diabetic retinopathy in the long run. Thank you, sir.
Thank you.
Point well taken, sir. I would request Kamil sir to please come and have a seat over here with us. And
just one thing I want to mention here, like in diabetic patients having cataract and retinopathy. So if you are not able to see the fundus in an eye which you are going to operate for cataract, always look for the other eye fundus findings. This can give you a good idea that what severity this patient can have and what kind of treatment regarding retina this patient will call it later on. Thank you.
Thank you, Abhishek. Point well taken. I would request our dynamic secretary, Dr. Mohita Sharma ma'am, to please present her topic, which is on transepithelial PRK. Is it the future? Dr. Mohita Sharma needs no introduction. She is a well-known figure in the world ophthalmology, I would say. She is the secretary of UP State Ophthalmology Society. This is the second term. She is the founder of the Women Ophthalmology Society, and she is presently the director of Tirupati Eye Center in Noida.
Thank you, Navindu. Before I start, I want to thank Dr. Amila and his team for inviting us here and giving us this opportunity to be with you all. And on behalf of our whole executive committee of UP State Ophthalmological Society and our whole team who's sitting here, I would like to also thank again Dr. Amila as well as Dr. Subhash Dadia, who was responsible for making this session happen today. The aim of this session is basically to interact with ophthalmologists of Sri Lanka, so that as a first step we interact with you in this conference, and as a second step we develop a collaboration where there can be exchange programs. Conferences are always the first step, and the second step is a more focused step, which is an exchange program. So today I'll be talking about transepithelial PRK. Now, we call it, the transepithelial PRK is sometimes called an old dog with new tricks. We all already know about PRK, and it was very popular a few years back. And then after some time, it fell into disrepute. And two major causes for this were pain and haze. The patients used to complain of intense pain after PRK, and there were a significant number of cases of haze. So now we have a resurgence of this PRK, and it has come up in the new form, which is called transepithelial PRK. There are most of the machines that are now available for LASIK have this transepithelial PRK in them, and almost all have a similar principle of working. The technology that I use is the Bausch & Lomb T-Neo M2 technology. So why has there been a resurgence of surface ablation? We all know that while we are doing LASIK, whatever precautions we may take and whatever preoperative investigations that we may be doing, we still come across some cases of ectasia, despite everything being normal. So we are not sure that what is the reason for these cases of ectasia. Probably it is related to biomechanical stability of the cornea, which we are still not checking on a regular basis, or probably it is something else. So we we are all looking for safer procedures, whether it is lenticular procedures or it is surface ablation. Our aim is that we should have something which is safer, where there is a zero risk of ectasia and there is a minimal amount of complications, because it's ultimately the long-term safety which is important. So the resurgence has been mainly because we want less risk of ectasia. It is also better in borderline pachymetries and borderline topographies where we were refusing cases. It is better in cases of dry eye because there is less dry eye. Since there is no flap, there are no flap-related complications and lesser aberrations. There is no stress on the retina since we are not increasing the vacuum. And these LASIK procedures are generally commercially driven also, so it is marketed nowadays as flapless, bladeless, and touchless. So these were the classical indications: anterior basement dystrophies, anterior stromal opacities, history of recurrent corneal erosions, deep socket, small palpebral fissure, thin cornea, flat cornea, steep cornea, atypical corneal topographies, asymmetric astigmatism, re-enhancement after LASIK, mild to moderate dry eye, and family history of keratoconus. These were classic indications, but here I would like to say that in the last more than 1 year, we have been doing this as a primary procedure also, where none of these investigations may be there. Still, we choose to go in for transepithelial PRK, and in fact, it is 60 to 70% of our patients we are doing transepithelial PRK instead of the keratome procedures. Now, if we see the risk assessment of corneal ectasia following PRK, and this is an article which is showing that whatever we may do, there is still, after LASIK, there is an incidence of 0.04% to 0.6% of ectasia after LASIK. We also know from this percentage tissue ablation that flap is not responsible for my biomechanical stability. So hence flap has to be reduced, and in this transepithelial PRK we are saving extra 50 to 60 microns. And as I said, since there are no flap related, since there is no flap, there are no flap related complications also. Now there are several studies which have shown that single step transepithelial PRK is giving very good results. Even in lenticular procedures, apart from LASIK, we find that there is dry eye because the subbasal plexus are transected even in lenticular procedures. So it is transepi PRK which scores here where dry eye is concerned, because here only the terminal nerve fibers are transected. So what after all is transepi? It is an advanced surface ablation where in a combination we do a epithelial removal as well as the correction of the refractive error, and we do both these things in one step with a 5 seconds gap in between. So the epithelium that is removed is equal to the ablation zone plus a small transition zone. So as I said before, pain and haze were the two major obstacles where PRK was concerned, and hyperopia was another obstacle which have been now almost taken care of. I'll just show you a short clipping of transepi PRK. So if you see that it is in 3 steps, that's the first step where epithelium was removed. You can see the green part. The second step where there is an ablation done. And a third step which is also very important, because there used to be hyperopia after a PRK because our epithelium is not regular all over. We find that the epithelium is thinner centrally compared to mid-peripherally. Hence the profile that used to be there was a hyperopic profile created, and PRK patients used to have hyperopia. But in this we do a mid-peripheral removal of epithelium, which is the third step, which takes care of this hyperopia, and it actually becomes a more prolate profile, and hence we are not finding any cases of hyperopia after transepi PRK. The pain and haze is taken care of by the truncated Gaussian beam profile. That is one reason for less pain and haze, because this gives a more, this provides a more smoother surface, and you can see the difference in the left side on the right side, and you can see in transepi PRK how smooth your bed and your sides are. As I've already explained about the mid-peripheral zone effect to you. For pain management, the modalities that we are using is Acuvale is no longer available, but ketorolac eye drops or Amplinac eye drops in the post-op period. And along with that, we also give an contact lens which is soaked in Amplinac eye drops. And this is soaked for, I'll show you a short video for this too. We just take a bandage contact lens and we inject some proparacaine, some Amplinac into this 20 minutes prior to the procedure, and then we refrigerate it. So it is a chilled contact lens and it is soaked in Amplinac. And this has really cut down on the pain that the patients used to complain of. With PRK, we used to have our patients at night calling up and shouting and screaming that they have lost their eye. But with Trans-Epi PRK, we don't find any such patients. It has actually changed the whole scenario. There are special drugs also which we use, and one which we have found very useful is a diluted proparacaine. That is, we dilute the lubricant drops with 20% proparacaine and we give it for the first day. So first day they will put it for 4 to 6 times, and that first day is the crucial one. And these are with the patients when they come after 3 to 4 days. When we ask them if there was pain, they would generally say no, there was no significant pain. And we have done more than 300 cases, and this is the pain score in 122 cases, and the overall pain score in a score of 10 was 2. The whole pain score was 2, and the patients are pretty happy with the result that happens. So pain is also probably less because there is a smaller defect, because till now with PRK we were removing the epithelium with an alcohol swab, and after that we were removing it manually. So it was a larger epithelial defect and it was an irregular epithelial defect. Here it is a smaller defect and it is a regular defect, which results in less pain, and it also results in a faster healing. We have found that whereas in PRK the healing happened in around 3 to 4 days time, here on average it is taking around 2.6 days that complete healing happens. So as far as haze is concerned, haze used to be another concern with PRK. But in trans-epithelial PRK, in the more than 300 cases that we have done, we have not found a single case of haze, which was surprising to us also, because we expected at least some cases would have haze, but we have not found any case of haze. And probably this is because again, because this is a very regular epithelial removal, so there is less stromal hydration in pockets and better healing. Since there is less pain, there is less inflammation, less release of inflammatory mediators, which are also responsible for haze later. So we find that with PRK, the good vision used to be achieved in 3 months, and the same good vision is achieved in 1 month in Trans-Epi PRK. So finally, summarizing, transepithelial PRK is here to stay because it's a safer procedure with wider application, and it is a touchless, bladeless, and a flapless procedure. Thank you.
Thank you for the wonderful presentation, ma'am. Any questions from the audience or panelists? I think we can take the questions later on at the end of the session because we are having shorter of time now. So I would request.
Now I request Dr. Parul Singh to deliver her lecture. She is an associate professor, Department of Ophthalmology, GSPM Medical College, Kanpur, UP. Her specialty is in cataract oculoplasty, preferably pediatric ophthalmology. She did her MBBS from LLRM Medical College, Meerut, DMS from RIO, Eye Hospital, Sitapur, DNB from Sargangaram Hospital, New Delhi. She's been observationist in LB Prasad Eye Institute, Hyderabad. She has a lot of work experience in GSVM Medical College, District Hospital, Kanpur, and some different places also. She has so many publications in her credit. Now I request Dr. Parul Singh to please deliver her lecture.
Thank you so much. It was so kind of you, sir. Thank you so much, UP SOS, Dr. Mohita Sharma ma'am, and Sri Lankan College of Ophthalmologists for this wonderful opportunity and welcoming us in your wonderful country. So I'll be speaking on aesthetics and oculoplasty. So first of all, why aesthetics? Aesthetics is something which means something which is visually appealing to the eye. So what is the scope of aesthetics and oculoplasty? So basically, aesthetic and cosmetic eye procedures are a group of those procedures that basically improve the appearance of eye and face, but to keep it in mind that most of these surgeries are performed on the surrounding tissues rather than on the eyes. So the scope of aesthetics in oculoplasty, it can be explained in three ways. First, the scope is in reconstruction of orbital structures. Second, in correction of eyelid deformities. And third, enhancement of eye appearance. Now, the importance of aesthetics in oculoplasty, to summarize, I can say that there can be three things. First and foremost is to enhance the patient of self-esteem. Secondly, to enhance the overall facial aesthetics, making a facial harmony among various facial features. And it definitely enhances and boosts the confidence of that patient in the social settings. So now to divide the adnexal aesthetic procedures, I would like to divide them first non-surgical and second surgical. In non-surgical, as we all know, botulinum toxin is becoming really popular these days. We can have augmentation procedures like the dermal fillers. We can have rejuvenation procedures, to name a few. And most of it is usually done by my derma friends. But of course, we can also attempt having good knowledge of the planes around eyes and on face. In surgical procedures, the first and the most widely done is blepharoplasty, upper and lower eyelids. Second would be ptosis repair. Ptosis, although would be considered more in therapeutic, but for milder ptosis, I think it can be taken into a aesthetic procedure. And third is browoplasty, which is usually done with plastic surgeon friends unless you have trained as an ophthalmologist much into browoplasty. Now coming first to non-surgical, so first I will take botulinum, and botulinum toxin has come a long way, which was initially thought to be used as a toxin in World War II by Americans and Germans, but they never used it for some reason. And now it has come a long way to be used as a therapeutic procedures. So basically, the main mechanism of action of botulinum toxin is inhibition of acetylcholine release. It has a long chain and a light chain and a heavy chain, and it is combined via disulfide bond. So basically what happens is at the neuromuscular junction, it basically involves three discrete steps in binding, internalization, and inhibition of the release of snare proteins. So when usually when the muscle contracts when acetylcholine is released into the synaptic cleft. Now when toxin is injected into the muscle, it internalizes itself and does not allow the release of acetylcholine, so the muscle is paralyzed. But sometimes as passes like beyond 2 months, 4 weeks and 6 weeks, what happens is sprouting of the nerve terminal happens, and that is the reason why botulinum action fades away and the muscle again regains its contraction. Now, commercially, botulinum toxin can be a type A or type B. Botox most commonly used as type A toxin is more stable, more purified, and has a longer duration of action. We can reconstitute it with 0.9% saline, and it should be stored at refrigerator at 4 degrees centigrade. And after reconstitution, it can be used very cautiously till 6 weeks. Dosage are recommended in different clinical conditions is differently, and now, the basic indications of botulinum toxin would be in facial dystonias like hemifacial spasm, benign essential blepharospasm, ocular myokemias. We can use it in senile entropions, we can use it in chemotarsorrhaphy, upper eyelid retractions, and for cosmetic indications, we can definitely use them widely now in dynamic facial wrinkles and chemical brow lift. So this is a video in which you can see this is a patient of abnormal twitching and movement, and you can see this patient, this is having this abnormal twitching hemifacial spasm, and we mark and we do this marking of the injection, and then we inject the botulinum toxin, and the peak action comes at 2 weeks. It starts to come at first week, and then it would last maybe till 4 to 6 months. So after that, the injection would have to be repeated. So this is a happy patient now after 2 to 3 weeks. Now this is a patient of benign essential blepharospasm before injection here. These patients, actually BEB patients, they actually suffer a lot socially also and not able to do their work, and this is a patient after the Botox injection. This is the video after 2 weeks of the injection. So effects are, as I told you, now this is the picture which is showing the dynamic facial wrinkles. First is the crow feet before and after. Second is the glabular furrows, we can see before and after. This picture shows periocular wrinkles before and after, and the horizontal forehead lines as they are gone by the use of botulinum toxin. Now, the contraindications would remain neuromuscular disorders, pregnancy, active infection, hypersensitivity. Complications are usually low, but we should know them. In order, if they happen, we should be able to manage them properly. They would be like ptosis if the injection goes deeper into LPS, leg of thalmos, entropion, diplopia, hematomas are usually rare with this. Now coming to dermal fillers, we have three types: reversible, semi-permanent, and permanent. The hyaluronic acid, the reversible fillers are the most popular because they are naturally occurring, they are biodegradable, they are reversible, very good safety profile and low reactions. The indications would remain the facial lines, wrinkles, folds, some post-surgical or traumatic scars, dark circles, and most commonly sunken eyes and tear trough hollows. This is a picture in which dermal filler was used pre-operatively. You can see a tear trough and dark circles, and post-operatively after injection. Since the tear trough is gone, the visual appearance has definitely improved aesthetically. The contraindications would be an autoimmune disease, any risk of anaphylaxis, and complications would be allergic or reactions, vascular occlusions, any granulomas, and any abscesses. It has to be kept in mind that the pros of the surgery, although instant results, easy technique, and simple OPD procedures, but it is short-lasting, the cost is high, adverse reactions can happen, and unrealistic expectant patients should be avoided. Coming on to surgical retinexal aesthetic procedures, the first is a blepharoplasty. Indications would remain eyelid dermatochalasis, stable interferon, nasogagal grooves, malar deflation, any eyelid asymmetries. The contraindications again would be an unrealistic expectant patient, coexisting medical conditions, thyroid, and a dry eye syndrome. This is a patient with dermatochalasis. Dermatochalasis, as we know, is an excess skin in the. In this patient, you can see excess skin in the upper lid, and this is a post-operative picture in which it is very aesthetically appealing now. This is a picture of stabilibifron, which is a condition in which there is prolapse of fat in upper or the lower eyelid. Post-operatively, it has become visually aesthetic. So, in upper lid bioplasty, the most important is the marking of the upper lid. Then we can pinch to see the skin to be removed, and then we do superficial skin excision, and excision of the skin and muscle is done in one layer, and tissue excision completed, closure done with 6-0 silk. As far as lower lid blepharoplasty is concerned, we can do transconjunctivally or transdermally. Transconjunctival approach is more preferred. We apply a traction suture, incision is given by RAF, exposed. Fat is exposed after we excise the orbital septum, and very carefully we can do the central pad excision, nasal fat excision, lateral fat excision. In the lower lid, we have to keep in mind the placement of inferior oblique. We might end up damaging, and it would be causing diplopia later. And this is the picture of pre and post blepharoplasty. Coming very fast to ptosis, as you all know, ptosis can be graded into mild, moderate, severe, and we have to look at the levator functions. So basically, we have to do ptosis for avoiding the risk of amblyopia, but at any age, it could be done to give, if we are concerned on the cosmetic levels. So if levator function is more than 10, if it's more than 10, and ptosis is mild, we can do facialar servat. At more than 2, we can do epinortic repair. If levator is less than 10, the function, and if it is more than 4, we can think of levator resection. If it is less than 4, we can do brow suspension. This is a patient of facialar servat, very mild ptosis, but the patient becomes more confident after the surgery. This is a patient of levator resection, 20-year-old boy with moderate ptosis, left eye, good levator, wonderful results. This is a patient of frontalis sync suspension, very poor levator function, but wonderfully the surgical result. And this is a patient, old patient with epinortic ptosis repair. Pre-operative, post-op results were really very making happy. I would skip this. And so I would summarize and conclude that the aesthetic oculoplasty is actually really important in enhancing the appearance of eyes through surgical and non-surgical procedures. Considering the complications and risk of strategies, aim is to achieve the optical aesthetic outcome while minimizing adverse effects. And importance of aesthetics in oculoplasty is to enhance the patient satisfaction and outcomes in the orthoplastic surgery. Thank you so much.
Thank you very much, Maya, for such a wonderful presentation. And just a disclaimer that Dr. Paul Singh has not used any of these aesthetics on herself. She's naturally so beautiful. So with the shortage of time, I would request Dr. Kamanjit sir to please welcome the next speaker.
Now I invite Dr. Aram. She is a wonderful ophthalmologist from Muradabad, a very rich place in UP. And she is a great worker, very active worker. For the last 10 years, I am seeing her do quite a lot for ophthalmology and should be speaking on myopia.
I'm sorry, before the session starts, I have a question to Dr. Parul Singh. What are the complications, short or long term? Have you ever studied on that? Yeah, of course. Did you ever find any muscle atrophy in
yes.
longer time?
So I would still wait for the long-term results because I have not been using Botox for such a long time to see the long-term results. But yes, in one patient, while I was using in actually Squint, a younger patient, I saw ptosis. Although I am sure I didn't inject it too deep, but the patient still encountered ptosis. So these complications can happen. Long-term I don't think much because the effect goes away anyways in 6 months. So how do we expect a long-term complication?
No.
Known complication. Yes, ptosis.
Ptosis is a known complication.
If at all it goes away in 6 months of time, but still it might be leaving some complications behind. Have you
Not
ever?
much because we apply it very superficially.
Okay.
Lid, the orbicularis oculi is just near the near the skin, so hardly it goes deep. We apply it just intradermally actually, and it goes into the muscle.
Thank you very much.
Good evening, everyone, and thank you for your kind words, sir. I feel privileged to be presenting my talk here on recent updates in myopia management. See, according to Holden et al., quoted in the World Report on Vision published by the WHO in October 2019, the estimated number of people globally with myopia in 2020 was predicted to be 2.6 billion, with a further expected increase to 3.36 billion by 2030. The predicted prevalence of myopia by 2050 is 65% of the population in Asia, 56% in Western Europe, 54% in Central Europe, and 50% in Eastern Europe. And pathological myopia is predicted to become the most common cause of irreversible vision impairment and blindness worldwide. Here, as you can see in this table, the last column is showing myopia prevalence percentage. You can see in prevalence of myopia in children in Europe is around 19.6, 11.5, 17.7, such figures. And in the next, prevalence of myopia in teenage Asian children, last column shows the prevalence of myopia in percentages 87.2, 66, 84.6, 84.0. So you can see the major difference, and for that, for myopia as becoming a global epidemic, we need to take proper interventions for controlling myopia. In the form of public health lifestyle interventions, pharmacological approaches with topical medicines, and optical devices. The International Myopia Institute defines pre-myopes, a refractive state of an eye of less than or equal to 0.75 diopters and more than or equal to minus 0.50 diopters in children, where a combination of baseline refraction, age, and other quantifiable risk factors provide a sufficient likelihood of the future development of myopia to merit preventive interventions. So this is the group where we need to take proper interventions. Optimization of environmental influences include outdoor activities. The chance of becoming myopic is reduced by around 1/3 if the time spent outdoors is increased from 0 to 5 hours per week to 14 or more hours per week. And vitamin D deficiency is found in myopes, so we can get it checked and supplement it in cases. Then the indoor lighting. In a Chinese study, increasing the light levels from approximately 100 to 500 lux in school classrooms had a significant effect on myopia onset, refraction, and axial elongation. So the NSIS is not recommending LEDs in domestic places and where children spend most of the time. Now, in the form of pharmacological treatment, we mainly have topical atropine in various concentrations. Pirenzepine is not commercially available, and the others are still in line. Atropine, as we all know, is reported to stimulate extracellular matrix biosynthesis in scleral fibroblast cells, thus thickening the scleral tissue and reducing the elasticity and tendency to elongation. We have landmark studies on atropine used for myopia, which includes ATOM-1, ATOM-2, and LAMP-1 and LAMP-2 studies. ATOM-3 studies is a low concentration study in pre-myopes. So we'll focus on, as you can see in this graph, the black triangles. You can follow the line along the black triangles. That is the ATOM-1 study, 1% atropine, higher concentration of atropine we have used. And after 2 years, 24th month, you can see it is quite efficient in reducing the progression of myopia, but the higher concentrations of atropine has rebound effect after 2 years. After 2 years, it has a rebound effect, but the lower concentrations, the ATOM 2 study, where low concentration is used, 0.01% of atropine is used. You can see the lighter circles. You can follow that line. I think I can use cursor. This line you can see after 5 years, there is much less rebound effect. Much less rebound effect in case of 0.01% study. And the side effect profile is better in low concentration. Now in LAMP study involving children treated with concentrations of 0.01%, 0.025%, 0.05% atropine for a year, there was a reduction of spherical equivalent progression of 27%, 43%, 67%, and a slowing of axial length of 12%, 29%, and 51% respectively. In the LAMP2 study, the efficacy of 0.05% eye drops was double that of 0.01% eye drops with respect to the reduction of myopia progression. A poorer response was associated with younger age, a higher degree of myopia at baseline starting spectacle wear at a younger age, and history of parental myopia. Now the optical interventions, we have single vision glasses, then we have single vision peripheral defocus correcting spectacle lenses, then we have bifocal and progressive additional lenses, or then contact lenses, soft contact lenses, bifocal and soft and rigid contact lenses, both bifocal and multifocal. In spectacle lenses, we have very promising single vision peripheral defocus correcting lenses. There are studies who have reported relative peripheral hyperopia. As you can see here, when we give myopic correction, we have to ensure that the image is formed onto the retina centrally for optimal vision, but it induces a myopic defocus in the periphery. So these are lenses which correct this natural peripheral hyperopic defocus, thus helping to reduce the signal, to send the signal to the eye to reduce continued elongation. And therefore, there is reduction in myopia progression with these lenses. You can just have an idea of such lenses. This is central 9.4 millimeter, and there are islands. There is island of honeycomb defocus around 400 points. One such lens is Hoya's MyoSmart lens, and there are many other lenses like Stylist from Essilor and Myopilux from Essilor, which works on almost similar technology. So this we have DIM spectacle lens has been used for myopia control in a 2-year randomized trial by Lam et al. And the results from the clinical trial showed that children from East Asian ethnicity wearing DIMS lenses had 52% less myopia progression and 62% less axial elongation. So and around 21.5% of the DIM lens wearers had no myopia progression. Then spectacles, bifocals and progressive lenses, they reduce accommodative lag during near work, reduce accommodative demand. Children with larger accommodative lag and near esophoria have greater myopia control with progressive lenses. Comet 2 study showed that pals of 2 diopters resulted in reduction of myopia progression by 24% in 3-year study. Then we have contact lenses, soft multifocal contact lenses or bifocal contact lenses in various designs. The principle is similar. Then we have ortho-K-wear. These are specially designed RGP contact lenses that are worn overnight. The redistribution of corneal epithelial cells temporarily corrects the myopia next day after the removal of the lens, making it a relatively oblate corneal surface, temporary oblate corneal surface. The effect of slowing axial length elongation ranges from 30% to 63%. The overall treatment effect is very good. It's around 50%. However, the safety remains a concern because of the risk of potentially blinding microbial keratitis. As you can see in the last column, reduction effect is from 30% to around 63%. On an average, it is 50%. One more controversial thing is undercorrection of myopia is not recommended. Earlier we used to undercorrect the myopia, But now it is not recommended as it increases myopia progression slightly according to Cochrane study, and there are many studies contradicting this thought and did not slow myopia progression as previously thought. Bifocal spectacles or progressive addition lenses versus single vision lenses yielded a small effect in slowing myopia progression. Studies evaluating different peripheral defocus correcting lenses versus single vision lenses reported inconsistent results for refractive error and axial length outcomes, although results for dim spectacles are promising. Surgical interventions, because of the invasive nature and lack of large randomized trials, surgical interventions are not recommended as a first-line treatment modality. Now, treatment duration. Axial length is the most important metric to monitor in pre-myopic and myopic children. Myopia progresses most rapidly during pre-teenagers years, 7 to 12 years. The mean age of stabilization is 15.6 years and 95% of myopes stabilize by age of 24 years. In case of atropine treatment, myopia progression may accelerate after stopping higher dose atropine usage. But despite the rebound effect, the level of myopia post-treatment will be less. Ortho-caviar should not be discontinued before age 14, otherwise it will lead to increase in myopia progression. Now, the average efficacies of main myopia management options. DIMS lenses, these myopic defocus single vision spectacle lenses, have 60% average efficacy. Atropine 0.01% has 59%. Contact lenses have 50% and ortho-cav 45%. Combination of interventions. Myopia progression was slower in children treatment with combination of atropine eye drops and multifocal spectacles than in children treated with placebo eye drops and single vision lenses. Orthokeratology with low dose atropine improved myopia control by the synergistic effect compared with orthokeratology treatment alone. There is no direct clear-cut guideline or treatment for the management of myopia, but we have various guidelines and various factors, various risk factors that we can consider and customize the treatment of our patients with these combinations, like 2 or 3 combinations, like lifestyle modification, like using DIMS lenses with low concentration atropine, or you can go for ortho-caviar lenses with low concentration of atropine, or you can go for, instead of multifocal spectacles, you can go for multifocal contact lenses in combination with low dose atropine. Thank you for your patience.
Thank you, Dr. Iram. I think we'll take the questions considering the time factor. We now invite our next speaker, Dr. Navendu Rai. He's a very dynamic and a prolific VR and phaco surgeon from Devariya, India. He has done his MBBS from LLRM Medical College, Meerut, and MS from KGMU, Lucknow. He has done his fellowship in vitreoretinal surgery from Aditya Jyot Eye Hospital, Mumbai, and he has been very active member of UPSOS, being past joint secretary and now as a co-chairman, academic and research committee in UPSOS. Dr. Navendu, please.
Thank you, Dr. Pooja, for the wonderful introduction. At the outset, I would like to thank Dr. Amila and the College of Ophthalmologists of Sri Lanka for giving me this opportunity to present in front of this August gathering. I would request how many VR surgeons are there right now in this hall? 1, 2, 3, 4, 5. That's great. So, as you all know, scleral buckling, there has always been a debate whether it is on the verge of extinction or still has some importance. So I would say that it is still not on the verge of extinction, and it has its own importance there are certain indications that require scleral buckling, and it's better suited with that. So it was before the turn of 20th century, the eyes with retinal detachment were considered doomed. From 1902 to 21, Jules Gonin almost single-handedly changed the landscape of retinal detachment surgery, but it was in 1950s that when Ernst Custodes reintroduced scleral buckling. The most difficult step in this procedure was precise localization of the retinal plaque, which became easy by the invention of endothermoscopy by Charles Kiepens in 1947. Then came the sealing of breaks to the RP was made by Mahesh Crawford, who developed photocoagulation in 1950s, and Linkoff pioneered modern chiropractic in 1960s. Whereas the plasma vitrectomy was introduced in the early 70s. So scleral buckling came almost 2 decades before PPV. This PPV was augmented by 3 other innovations like silicone oil by Paul Sibis, fluid exchange by Stephen Charles, and PFCLs by Stanley Chang. These were the innovations that made PPV more better as suited to scleral buckling in most of the complicated cases. There are two schools of scleral buckling. One is the Custodes Linkoff school, which uses radial buckles, and in this SRF is not drained, it is absorbed on its own. And the other that is more commonly used is Aruga-Skippin school, which uses circumferential buckles and in which SRF drainage is done. The drainage of SRF is usually required in the highly elevated breaks and detachments, including adequate cryopaxy retinal break, high stellar indentation of more than 6 hours, in which to reduce the IOP we need to do SRF drainage, and chronic detachments when the SRF is thicker. Retinal reattachment, what happens is once we put the buckle, it induces scleral indentation, which leads to reduction in the magnitude of vitreous traction, or it alters the direction of vitreous traction and reduces the flow of vitreous fluid to the break, leading to the shifting of balance towards retinal reattachment. Now, this is not just the part. The placement of buckle does not alone, it treats the break and prevents break from reopening. There needs to be an adhesion between the two surfaces, and that is done either by cryopaxy or photocoagulation. In procedure, we all know, we do a periotomy, we tag the muscles. After tagging the muscles, what we do is we localize the break, we mark the break on sclera, we place the buckle, we do a trapdoor drainage of SRF, place the buckle, suture it, close it. This is what we do in scleral buckling. And this video is not working, sorry. So advantages of buckling are it is an extraocular surgery. In phakic eyes, less chances of development of cataract and other serious intraocular and postoperative complications. It is early visual rehabilitation. There is excellent anatomical results. The longevity is good, and there is a good visual outcome. The disadvantages of scleral buckling are it induces refractive errors of about -3 diopters. Ocular movement disorders could be there. Choroidal hemorrhage, subretinal hemorrhage, explant exposure could be there. And certain conditions like GRTs and advanced PVRs are difficult to manage with scleral buckling. So here comes primary vitrectomy, which has the advantage of it can be used in pseudophakic eyes, in which the undiagnosed breaks can be diagnosed perioperatively. It is relatively easier to perform. The removal of vitreous opacities is there, and good anatomical results in the cases like PVR and the NGRT cases. The disadvantages are, formation of attenuated retinal breaks. PVR is more common in post-vitrectomy. Lens trauma and cataract progression are the potential side effects or disadvantages of PPV. Contraindications of scleral buckling are relative, and it can be for the detachments that are caused by breaks which is very significantly posterior to the equator, if there is opaque media like in vitreous hemorrhage, and if there is significant vitreoretinal traction. In these cases, PPV finds better indication as compared to scleral buckling. The complications could be intra-op and post-op, which are really very small, and there could be like anatomical failure, if there is inadequate buccal height, there are missed breaks, and because of PVR. Immediate and early postoperative discomfort is there, refractive error as discussed. There could be restrictive strabismus and double vision, glaucoma, choroidal hemorrhage, buccal infection, which is not very uncommon because we don't use the open air sponges. Extrusion of buccal and anterior segment ischemia are the potential side effects of complications of scleral buckling procedure. PPV as a primary procedure for repair of retinal detachment, the advances in vitrectomy technique and the introduction of those three things that we just discussed before, that has led anterior vitrectomy, the vitrectomy, passive vitrectomy to be used more as a primary procedure now instead of scleral buckling. So it removes especially in cases of pseudophakic and aphakic RDs. So if we have a phakic patient, we better go with the scleral buckling, and if the patient is having pseudophakic, if the patient is pseudophakic or aphakic, PPV works better. PVR, the incidence of PVR in PPV cases, it ranges between 5.3 to 11.5%, while in scleral buckling it is as low as 1.9%, and that is why the chances of re-detachment and requiring re-surgery is less with scleral buckling. Special indications for buckling is indicated in uncomplicated inferior detachments, young phakic patients with clear lenses, RRDs with anterior tears, and absence or minimal PVR. So these are the indications in which serial buckling should be sought of. Vitrectomy is better indicated in pseudophakic and phakic RDs, RRDs with complicated with vitreous hemorrhage, PVR traction over large breaks, posterior breaks, and others like in ILM peeling, ERM removal, and endophthalmitis. Vitrectomy plays a better role. The final best criteria visual acuity in both the procedures is almost same. The main factors predicting poorer visual outcome after surgery could be same in both, which are usually poor preoperative visual acuity, increasing extent of detachment, increasing number of breaks, inferiorly positioned breaks, macula of RDs, preoperative PVR, and intraoperative hemorrhage. So my pulse for buckling would be a well-versed, the surgeon should be well-versed with indirect ophthalmoscopy. Proper identification and treatment of all the existing breaks and proper SRF drainage is important. I do trapdoor scleral flap for drainage. After draining some sub-SRF, I inject some amount of gas, 0.6 ml of undiluted SF6 that facilitates further removal of SRF. So is SB on the verge of extinction? No, I would say no, because always remember, do the needle minimum to reattach the retina. So whenever serial buckling is indicated, irrespective of cost difference, it should be done. No single surgical technique can be considered as optimal and routine for all the cases of RDs. It is noteworthy to consider some of the following factors like the cost of these operations, experience and capabilities of the vitreoretinal surgeons, and availability of proper instrumentation. The art of doing a good scleral buckling is diminishing nowadays, and learning how to find a retinal break with large drawing is definitely on the wane. A retina reattached by a scleral buckle is generally stable, lifelong, and gives a very good postoperative visual recovery. Scleral buckling as a procedure is an art, right from student's attempt to localize the breaks, to its drawing, to its treatment and placement of buckle, and adequate height, and finally to retinal reattachment. This is all an art. Let us prevent this endangered art from extinction. The newer generation of vitreoretinal surgeons should be adequately trained in scleral buckling surgery, or else this simple procedure will face a danger of extinction in the years to come. Thank you, and I bow my guru, who taught me in a beautiful way how to reattach a retina with minimal efforts and cost. Thank you.
Thank you, Dr. Navendu, for this beautiful presentation. Just one thing I want to mention here, like these results are really good, especially in young patients in buckling. But the case selection should be actually is very important in these cases. Yes. If you have even a single doubt, I think we generally move to the vitrectomy. Because if you are not able to see all the breaks, because if you are not good in indirect ophthalmoscopy, then I think it's very difficult to do the buckle. But results are really very, very good in all these patients. Thank you, Dr. Navendu.
Thank you very much. With this, we come to the end of this session. I would request Dr. Mohita ma'am to request. I would request all the speakers to come on the stage.
So we again thank Dr. Amila and his team for giving us this opportunity. And we invite you, sir, on the stage. Our president, sir, would like to give you a small token of thanks. And we invite all our UP speakers as well as panelists as well as delegates here on the stage. Dr. Anvi, you too.